Hi, everyone, and welcome to our summit today. We're so happy to have you here. We are just going to dive right in with our first presentation. This presentation was pre-recorded by Valeria Gary, but she will be with us for a live quick Q&A at the end.
Hello, everyone. This presentation is I'm no neurologist, but this seems atypical, recognizing signs of atypical Parkinsonism. And I'm Valeria Gary. My disclosures are I receive a salary as an independent contractor with the Medical SLP Collective. I have ownership of Parkinson's Speech Services. I receive a salary as an employee at Wellstar Health System. And my non-financial disclosure is I'm an ambassador for the Parkinson's Foundation Georgia chapter. Now, this presentation is coming a lot from my perspective, my clinical experience, where I currently work. I work at an outpatient neuro rehab program where we have a rapidly growing Parkinson's disease program. We have 7 SLPs, lots and lots of OTs and PTs, including 2 that I interviewed for this particular presentation. In our hospital system, we have 2 movement disorder specialists and we have lots of neurologists. So team collaboration is something that we are really working on building and getting better and better at. And we have, through trial and error over the years. Now I realize that not everyone has that same access, doesn't have the same number of colleagues to bounce ideas off of. And so that is what this presentation is for, is to help people to kind of create some team collaboration and to help patients as best as possible. A little bit about me. I'm a speech language pathologist and I'm also a life coach for people with mild cognitive impairments. And for fun, I'm a competitive powerlifter. Our learner objectives today are 1, list 3 signs of atypical Parkinsonism. 2, describe how atypical Parkinsonism is diagnosed. And 3, describe how to communicate suspicions to the patient and medical team. My inspiration for this presentation is really just kind of coming from wanting to know more and to kind of better serve some of my patients. There have been times I've noticed something and I was glad I spoke up, and there were times I didn't notice something. I wish I had noticed something sooner to help people get a proper diagnosis. And that goes with both Parkinson's and also atypical Parkinsonism. So a few patients that kind of come to mind as those patients I kind of never forget. One was someone who was diagnosed with vocal cord bowing. They were referred to me just for voice. And I noticed that the patient had what looked like kind of a masked face. Their posture was stooped. They took small footsteps. The voice was soft, but it was a little bit coarse, but when they increased their loudness, the voice was nice and clear. And I asked the patient and the care partner, is there any neurological history, any neurological concerns? And, they didn't have any concerns. And I, brought up, as far as even just noticing like the gait pattern. I asked about falls. And the care partner was like, well, no, they never fall. They just have some, trouble sometimes going up and down curbs. So that's a red flag, which we'll talk about. In this case, I pushed them to talk to their doctor about just some of the concerns I had. The primary care didn't really have any concerns, and so didn't follow through initially with a neurological consultation. But later on, that patient did come back to us with a diagnosis of Parkinson's disease. So I saw some Parkinson's red flags in this case and maybe red flags for something else. I think of another patient. This patient was relatively newly diagnosed with Parkinson's disease. Their voice was loud enough, but it was very strained and strangled, had a lot of rough quality. So we don't expect to see that. They did have a ENT consult, but there was no actual pathology noted on the vocal cords except for some tremor. This particular patient came back a couple of years later, had a notable decline in function, and ultimately was diagnosed with multiple system atrophy. And then I think about another patient who was fairly recently diagnosed with Parkinson's disease, and noticed that this particular patient had difficulty sometimes with just like a lot of repetition of sounds and syllables in speech, some oral festinations. And that patient later on was diagnosed with progressive supranuclear palsy. So I say this to say that our objective is to kind of look for red flags or something that just kind of seems off, whether it's someone who doesn't have a neurological condition and you think they might have Parkinson's or something similar, or what we see a lot, patients come to us initially diagnosed with Parkinson's and they end up having a typical Parkinsonism. I think of even yet another patient, great loudness, was able to do all the exercises as long as they had a model and a cue every time. Like every day was like starting all over again with the exercises and doing the models and cues, and they could do everything beautifully. That patient was later diagnosed with Lewy body dementia. So these patients kind of pop into your mind. Hindsight's 2020, but again, just being able to recognize some potential red flags is what we want to accomplish today. All right, our overview of Parkinson's disease. So Parkinson's is a neurodegenerative disorder that affects predominantly the dopamine-producing neurons in a specific area of the brain called the substantia nigra. 90,000 people are diagnosed in the U.S. with Parkinson's disease each year. The number of people in the U.S. with Parkinson's disease is projected to be 1.2 million by 2030. Men assigned at birth are more likely to have PD than women assigned at birth. And the number of people with PD that are diagnosed increases with age. When we look at prevalence, Parkinson's disease, if we look at the group of people 45 and older, it's 47 to 77 per 100,000 people. If we look at the age group of 65 and up, it goes to 108 to 212 per 100,000 people. Life expectancy, for the most part, is considered to be the same as someone without Parkinson's disease. Now, again, sometimes people with Parkinson's do have conditions that end up being kind of related to that can slightly shorten the expected life survival. However, if we look at someone with like an older onset Parkinson's disease, 88 years old is going to be our typical age as far as mortality. And then someone with early onset Parkinson's, the life expectancy is around 71 years old. So again, Parkinson's disease, think about those numbers because we'll talk about prevalence and some of the other conditions. So age 45 and up, 47 to 77 per 100,000. And as we talk about that older group, 65 and up, 108 to 212 per 100,000 people, with a life expectancy anywhere from 71 to 88 years old. And so our goal for this presentation is to identify some red flags for atypical Parkinsonism. With atypical Parkinsonism, these patients will have symptoms in common with Parkinson's disease, but they'll also show symptoms not typically seen in Parkinson's disease. There may be limited or no response to levodopa. These conditions are not considered to be or not thought to be hereditary, and they tend to be rare and under-recognized. And I want to emphasize the under-recognized part. So, as speech pathologists or PTs or OTs, whoever you're working with, on your own, you might not necessarily recognize this, but putting pieces of information together along with what the neurologist might find in testing is what helps to get the diagnosis for these patients. But remember, everything is like quote unquote easy to pick out when you have everything laid out in front of you, or if someone just fits every single pattern of a condition. But it's different when you see someone on a day-to-day basis and you're really focused in on your part of that patient's care. All right, so the 4 types of atypical Parkinsonism syndromes that we will talk about today: multiple system atrophy, MSA, progressive supranuclear palsy, PSP, cortical basal degeneration, CBD, dementia with Lewy bodies, DLB. And you might also see it as LBD, Lewy body dementia. And with cortical basal degeneration, a lot of times you might see a lot of talk about CBS, cortical basal syndrome, instead of CBD. And basically, cortical basal degeneration is a rare progressive neurological disorder, and the most common presentation of it is cortical basal syndrome, which includes some cortical and extrapyramidal symptoms. Now, what's not included in today's talk are conditions such as vascular Parkinsonism, which is caused by multiple strokes. So we'll be talking just about these 4. Again, atypical Parkinsonism syndromes can be challenging to identify and diagnose. In hindsight, everything looks very crystal clear, but in the moment, it can be hard. A team approach can lead to discovering patterns. So some of our big red flags that we're going to see in atypical Parkinsonism include cognitive changes in the early stages, early frequent falls, rapid progression, poor response to levodopa, severe autonomic dysfunction, and early symptoms of dysphagia, dysarthria, and dysphonia. As far as the autonomic dysfunction, the Mayo Clinic describes it as autonomic dysfunction includes things like trouble with balance, syncope due to a sudden drop in blood pressure, tachycardia, bradycardia, exercise intolerance, which is heart rate that stays the same instead of adjusting to a level of activity, blood pressure difficulties, keeping that managed, trouble with temperature control, difficulty with digestion, bladder dysfunction, and sexual dysfunction. So if you look at this list here, you see the word early a lot. That early stage changes, that's a huge red flag for atypical Parkinsonism. Parkinson's tends to progress very slowly. So if we have someone early in that progression, recently diagnosed, and they're having a rapid decline or they're having these changes we don't expect to see at the beginning of Parkinson's, that's your primary red flag for atypical Parkinsonism. All right, so now my little disclaimer here, each of the conditions we'll talk about, they're highly complex in nature. We don't have a lot of time today, so I'm not going to go into every manifestation or every symptom, every test that's involved. But what I want to do is kind of give the speech pathologist some things to take note of in the context of rehabilitation. I say refer to the references for a thorough description of each condition's motor and non-motor symptoms. There are two papers that I really like. One is the Bluet paper, the best practices paper, and then the MSA trust fact sheet, and that's in your reference list. But I love both of those papers because they give lots of great clinical information in a way that's you can use it right away. All right, multiple system atrophy. Our statistics, the prevalence is 1.9 to 4.9 per 100,000 people. Let's contrast that to what we talked about with Parkinson's disease. We can see that this is a much rarer condition. The average survival after symptoms and diagnosis, 7 to 9 years. In imaging, we might find bilateral T2 hypointensity, lateral putamen margin hyperintensity, olivopontocerebellar atrophy. Some key notes for speech pathologists to note: abnormal postures. So especially leaning forward or leaning to the side. We see that a lot with multiple system atrophy. Autonomic dysfunction like orthostatic hypotension, dizziness, postprandial hypotension. Mixed dysarthria, so a mixture of hypokinetic and ataxic dysarthria. Voice impairment, looking at variations in fundamental frequency during maximum phonation time, uncontrolled changes in pitch compared to people with Parkinson's disease, uncontrolled changes in loudness, so that ataxic dysarthria can be quite common. Patients with MSA tend to have higher voice handicap index scores than people with Parkinson's, but similar scores to someone with PSP, progressive supranuclear palsy. We might have respiratory stridor in this population and emotional lability or pseudobulbar affect, which tends to be mild. All right, so we're going to start with multiple systems atrophy, but I'm going to kind of backtrack a little bit with some statistics about Parkinson's disease. So we look at prevalence with Parkinson's disease in the age group of 45 and older. The prevalence is going to be 47 to 77 people per 100,000 people. So 47 to 77 per 100,000. When we start looking at an older age group, age 65 and up, that prevalence increases to 108 to 212 per 100,000 people. Now, some things you look at will say someone with Parkinson's has the same life expectancy as someone without Parkinson's. Other places you'll look at sometimes some of the conditions that go along with Parkinson's can shorten that life expectancy a little bit. But Parkinson's disease in and of itself is not considered to be a fatal condition. The life expectancy with Parkinson's, in one of the sites that I looked at, said age 71 for someone with early onset Parkinson's, and then someone with older onset 88. So 71 to 88 as far as life expectancy. Right. Now, with multiple system atrophy, there are two classifications. There's MSAP, which has similar motor symptoms as Parkinson's, but autonomic symptoms that might come before the motor symptoms. And there's MSAC with cerebellar symptoms that originate from the trunk and spread to the lower limbs. Gait and limb ataxia, dysarthria, oculomotor disturbances, those are often seen in MSAC. Now, the statistics for multiple system atrophy, the prevalence is 1.9 to 4.9 per 100,000 people, so far more rare than Parkinson's disease. And the average survival is between 7 and 9 years. In imaging, findings might include bilateral T2 hypointensity, lateral putamen margin hyperintensity. We might have some olivopontocerebellar atrophy on the findings. Some key things for speech pathologists to note. If we start, we look at abnormal postures. So someone with MSA will tend to lean forward or tend to lean to the side. They'll have some autonomic dysfunction like orthostatic hypotension, dizziness, postprandial hypotension. With motor speech, we often see a mixed dysarthria, so a combination of hypokinetic and ataxic dysarthria. With voice, variations in fundamental frequency during maximum phonation time, uncontrolled changes in pitch compared to someone with Parkinson's disease, uncontrolled changes in loudness, like an ataxic dysarthria, that's quite common. And then voice handicap index scores with patients with MSA tend to be higher in MSA than someone with Parkinson's disease, but similar to someone with progressive supranuclear palsy. We might also see respiratory stridor and mild emotional lability in the MSA population. Progressive supranuclear palsy. So this, we have a prevalence of 5 to 7 per 100,000 people with a median survival rate 5 to 8 years after diagnosis. Imaging on MRI might show atrophy in the midbrain and superior cerebellar peduncles. Some key things for a speech pathologist to note: postural instability. So this is, and especially the poor ability to recover from loss of balance. So we talked about MSA, a lot of times we'll see the forward leaning or the side leaning. With PSP, a lot of times is more of a backwards leaning. And once someone, whatever direction they start to lose their balance in, so let's say they start going back, there is almost no attempt to recover from that. So you don't see the arms flailing, you don't see them trying to readjust the balance, it's just down. So high fall risk and injury risk. We might see some rigidity of the limbs, difficulty with downward eye gaze. That's a big one. And when I mentioned about the patient earlier who had trouble with curbs, one of the things I suspected is, like, does he have trouble looking down? Is that why he does fine on flat surfaces, but when he has to look down for a curb, he has difficulty? Personality and behavior changes are fairly common in PSP. Cognitive impairments we'll talk about a little bit more, but basically like executive dysfunction, memory problems, and a lot of times those memory problems are related to the executive dysfunction, as can sometimes be some of the personality and behavior changes. Dysphagia, the onset of that around 3 to 4 years after the onset of initial symptoms. With motor speech, we might see the palalia, repetition of syllables, words, or phrases. Echolalia, which is the repetition of what someone else has said. Some people with PSP experience stuttering, and then we often see a mixed dysarthria with hypokinetic and spastic dysarthria. So again, we see that the hypokinetic dysarthria, we might see it in PSP, see it in MSA, also see it in Parkinson's disease. So that's why initially, a lot of times these all look like Parkinson's. With voice, patients might have phonation breaks, or they might have no phonation at all. Their voice handicap index scores tend to be higher than someone with Parkinson's disease and similar to someone with MSA. With language, we might find some limitations with language, word finding difficulties, and a non-fluent variant of primary progressive aphasia. Behavior, apathy, impulsivity, disinhibition, and lack of insight. And again, we could also see these in Parkinson's, but we tend to see these early in the progression with PSP. All right, CBD and CBS. So our prevalence is 4.9 to 7.3 per 100,000 people. A median survival after onset of symptoms, 7.9 years. Imaging findings might include symmetrical cerebral atrophy, widespread neurodegeneration, and asymmetrical frontal parietal atrophy. There are different phenotypes of cortical basal degeneration. The most common one is going to be cortical basal syndrome, CBS. But there's also the frontotemporal dementia variant, the posterior cortical atrophy syndrome, progressive non-fluent agrammatic aphasia, and progressive supranuclear palsy syndrome. Okay. The predominant involvement with CBD is going to be in the cortex and the basal ganglia. Now, there is a classic presentation for this population. So we might have that asymmetric rigidity. So one side is just really rigid. Dystonia, so difficulty with muscle tone. Ideomotor apraxia, and that's going to be the inability to perform a motor task such as imitating or miming how to use an object, despite having the motor ability to do so. Alien limb phenomena. So that's when on one side, one of the limbs just does kind of almost like whatever it wants to do. So someone might be trying to do a two-handed task, but that other limb is just moving in an uncontrolled manner, not related to the movement needed for that task. CBD has features similar to frontotemporal dementia, primary progressive aphasia, Alzheimer's disease, progressive supranuclear palsy, and posterior cortical atrophy. Again, kind of leaning to the reason why this could be hard to diagnose. But asymmetry is the biggest red flag for CBD. Someone with CBD may also present with cortical sensory loss, language impairments, dementia, oculomotor dysfunction, postural instability, gait difficulty, and hyperreflexia. They share similar treatment options, though, with PSP. So medications such as levodopa, trials, Botox, muscle relaxants, antidepressants, medications for pseudobulbar affect, may or may not be beneficial for this population. Gait training and assistive devices, lubricants for the eyes, sunglasses for eye sensitivity, also like balance and eye training, dysphagia intervention, motor speech therapy, dementia-based interventions, all can be appropriate for both this and PSP. And we will talk a little bit more about like evaluation and treatment in a moment. Motor speech, we often see apraxia of speech in CBD. So think about your typical Parkinson's disease. You don't expect to see apraxic errors. So apraxia of speech is a highlight thing. With language, non-fluent aphasia, dysphagia, especially when we see that earlier in that progression. The onset of dysphagia with this population tends to come around 5.5 years after the onset of symptoms. And one of the hallmark features, that could be oral or pharyngeal, with any of our swallowing components, we might see impairment. But one thing we see a lot with CBD is going to be piecemeal deglutition. So it's kind of a characteristic swallowing trait of CBD. And then cognition, we can have an impairment. They tend to have better executive function than someone with PSP. But again, we have those cognitive impairments with this group. All right, so Lewy body dementia or dementia with Lewy body, so LBD or DLB. With this, we see an early onset and a rapid progression. Statistically, approximately 4 to 16% of all dementia cases are LBD. Right? It's the second most common cause of dementia, second only to Alzheimer's disease. With imaging, it might show diffuse cerebral atrophy, but less involvement in the occipital and mesial temporal lobes than Alzheimer's disease. There's some key things for us to look for. So REM sleep disorder, so especially the acting out a lot in sleep, so not having that feature of sleep where we don't move when we're dreaming, but having a lot of body movements. Hallucinations, definitely a key symptom. Every patient I've worked with that has Lewy body dementia that has hallucinations, they most of the time, I shouldn't say every patient, but they're not usually like horrifying hallucinations. They're usually pleasant, and the patient knows it's a hallucination. So they might see, I see the family, that lives upstairs, but they know there's not really a family living upstairs. They know it's a hallucination. But still, when people start reporting that, especially, if you're noticing cognitive changes that are coming like early on, even maybe more so before the motor changes, that's going to be a big red flag for Lewy body dementia. Fluctuations in cognition and alertness. So that's like you have the good days and bad days type of patients. So some days they're really alert, some days they're not, some days they're maybe more on top of things, some days they're more confused. And then another big defining thing is the cognitive impairment preceding or within 1 year of motor symptoms. So with Parkinson's, we have the motor symptoms. There can be non-motor symptoms to Parkinson's that also come early on, but the cognitive changes that impact ADLs tends to come later. So if someone's having these cognitive impairments before they even start to have the motor dysfunction, most likely Lewy body dementia, or if it's in that first year, so it's like they come on together, that's going to be a red flag. Right. Also, things to look for are like balancing gait difficulties, syncope, paranoia, also common with this one. Treatment tends to be, like with all of these, symptomatic. We're just treating symptoms. Levodopa might be beneficial, but it can also make psychosis work. So the doctors and the patients really have to work pretty closely together as far as the timing of the medication and the dosage to see if that helps. There are some medications that should be avoided, like MAO inhibitors, because those can cause a worsening of cognition and psychosis. There are some medications they're trying out for some people, like donepezil, which might improve cognition. All right, so now getting into, so we have the red flags, but like how do we evaluate patients? That's what we want to really get into now. So I always say, our evaluation is the opportunity to gather information. We don't have to have all the answers the very first moment we lay eyes on a patient. We're just trying to collect as much information as possible. Also, depending on your work site, your evaluation might not your slot might not give you enough time to really tease apart everything you need in order to help identify these patients. So it might be something that takes place over a period of time, like you might start off with doing your standard evaluation for Parkinson's disease. And during the course of therapy, you start noticing other things. You might say, you know what, I want to take a look at some cognition right now. I want to look at word finding a little bit more. And so it can be an evolving assessment process. I put down just kind of like the basic components of like the things that we want to look at some point with our patients, especially if we are suspecting that they might be someone with atypical Parkinson's disease. A lot of times my evaluation is more of a non-standardized assessment if I'm trying to figure things out. And that's because in order to kind of look at everything I want to do, and we only get 45 minutes to 60 minutes for our evaluations. So to do a lot of things in that time to get a good picture of the patient, I can't necessarily do like a full battery of everything I want to do. But again, there are batteries available for these different areas. Right. But we want to start with a really good interview. That interview process, talking to the patient, digging through the chart, talking to the care partners. The active listening is a big piece of our assessment. And of course, we start assessing motor speech and assessing word finding during the interview itself. Also, we can assess their ability to comprehend and respond to the questions that we're asking. Do we have to repeat things a lot? Are they able to remember the information? Do they remember what they've been told by the physician? And then we also want to determine like what changes the patient or the care partners have noticed. How fast have these changes come? So when were they diagnosed? And again, if we're talking about trying to identify patients with atypical Parkinsonism, chances are they've come to us with Parkinson's. So we want to find out, when were you diagnosed with Parkinson's? How long had you had symptoms before that? Because it's usually, people will say, well, when I think about it, I probably had Parkinson's for a couple of years, but it wasn't until such and such year that I got officially diagnosed. So we'll ask, like, okay, when were you diagnosed? When did you start noticing that something was different? When did you start noticing the changes that you're here for me now? So did you have Parkinson's for several years and now you're noticing changes with your voice or your speech or your swallowing? Or you diagnosed just last year and you're noticing these changes. So really kind of getting that timeline is worth spending time in that interview process, because that can help you with your red flags for atypical Parkinsonism. For motor speech, because we want to look at our 5 subsystems of speech. A lot of times we're going to be looking out for hypokinetic dysarthria, ataxic dysarthria, spastic dysarthria, and apraxia of speech, because that can help us with our differential diagnosis. Of our articulation, we're looking at the precision of the speech, intelligibility, comprehensibility, which is more than just articulation, but I kind of lump that into when I'm making a comment on articulation. Phonation, we're looking at voice quality, voice intensity. Does voice improve with increased loudness? Respiration, breath support for speech, maximum phonation time. For resonance, we're looking at, is there hypo or hypernasality? It's just a lot of times kind of more of an observation. That's usually not something that you see a lot of in Parkinson's or atypical Parkinsonism, but it's something to take note of. And then prosody, like, what is their rate like? What is their intonation like in conversation or in a sentence level task? That can give us some information too. As far as voice, acoustic analysis and perceptual measures, we're looking at things like frequency modulation, excessive changes in volume and pitch, phonation breaks or no phonation, and that general voice quality. So when we have significant voice impairments, that kind of makes us think about the red flags for atypical Parkinsonism, because Parkinson's in and of itself will get some roughness, will have a low vocal intensity, but once that patient increases their loudness, that voice should be fairly clear. Might not be necessarily perfect, but we should expect some good clarity. And our atypical Parkinsonism is it's going to be more common for someone to actually have a voice impairment. And it's going to be more severe than what you would expect with the straight Parkinson's disease. We can use perceptual measures like the Gerbus or the KV. And then for acoustic measures, like acoustic voice quality index measures on Pratt with a plug-in, or using VisiPitch to get the capsular peak prominence. Those are some good ways to kind of see is there something else going on with the voice other than the lack of volume, the lack of amplitude. Language assessments, we can use things from our traditional aphasia assessment batteries. Some things I like to do if I'm not doing like a full language evaluation, I'll do some discourse analysis tasks like the cookie theft or the peanut butter and jelly discourse tasks. I rarely get into reading and writing during my initial evaluation because I'm trying to do so many other things, but at some point I do want to do that, especially if we're suspecting PSP, like what's that scanning looking like? I'm looking at comprehension. Sometimes it's just within the context of the tasks that I'm doing for the evaluation itself if I'm limited on time, but ultimately I might want to do a more standardized way of looking at comprehension. And then I like to look at confrontation naming and responsive naming. So if they see it, can they name it? If I ask them a question about it, can they pull that word for that object or that action? Cognition, we're looking at assessment of global cognitive domains. We can use dementia assessments, we can use verbal fluency tasks, and when we think about our cognitive domains, we're thinking about language, memory, executive functioning, visual spatial skills, attention, and there are other domains that a lot of times OT will take a look at, but for us, we tend to look at those 5 domains. And we can use screeners such as like the MoCA or the SLUMS. We might use assessments like the CLQT, the Cognitive Linguistic Quick Test, or the FEMAT, the Functional External Memory Aid tool, which I absolutely love because it's very useful. Verbal fluency tasks like category naming or letter tasks. Story retelling, giving a space retrieval task, just a variety of ways that we can look at cognition. And then swallowing, of course, our cranial nerve examinations, which we'll want to do anyway as part of any kind of motor assessment. And our clinical swallow evaluation, which we might include things like like the Yelp swallow protocol, the Tomas mastication test, imaging, of course, to see what is happening with the physiology. So again, these are some of the things that if we're doing like a really comprehensive evaluation, we would try to hit as many of these as possible. But if not, just trying to get at least enough to kind of comment if there's a red flag in any of those areas. All right, so as far as treatment, so just like the medical things tend to be based on symptoms, as far as the care, our treatment is basically symptomatic. These are all progressive conditions. We are aiming to maintain and improve quality of life. We're not necessarily always going to change the physiology itself. Sometimes with our motor speech, our voice things, we can make some great improvements. But basically, we're looking at what's the symptom, and then what are some things we can do to help the patient to continue to function. I like to refer people to the ASHA practice portal and evidence maps. So if you're looking for motor speech, what does the evidence say about motor speech? You can go to that and see what types of things are or are not beneficial. We use a lot of compensatory strategies with this population, and we'll talk about some care partner things too. So motor speech, LSVT has been researched quite a bit, and it's been looked at for both big and loud in the atypical Parkinsonism setting. And I know that of the things I found, I didn't do a deep dive, but they found LSVT loud was helpful for people with PSP, for speech, and also for swallowing. And then LSVT big helped, resulted in motor improvements for PSP. And then they also looked at the MSA, the multi-system atrophy C patients, and they found improved speech and swallow with LSVT loud. So there are some things, from a motor standpoint, that we can do. For voice, some of the evidence shows doing things like semi-occluded vocal tract, resonant voice, breath support, EMST can be beneficial. Language, things like semantic features analysis or scripting are things that we might do to help the patients with, for example, the like the primary progressive aphasia type symptoms. Cognition, kind of same things we do with other patients with dementia. We'll utilize a lot of external supports. Some of the patients might be able to do internal memory strategies. I love the INCOG papers for information on addressing cognition. Now, the INCOG is INCOG 2.0 now. Those papers were actually written for traumatic brain injury, but the information in there is valuable for a lot of populations. It just tells you, as far as memory or attention, executive functioning, what things tend to work and what things don't have any evidence. So, treating dementia is totally different from treating TBI, but also knowing how things carry over. It's like doing a rote task that's decontextualized in TBI is not shown to be beneficial. So there's no real reason to think that it's going to necessarily help someone with dementia. Other things we might do for cognitions, space retrieval training, memory aids, timers, alarms, smartphones. I like to use the patients' phones to record things like their exercises. A lot of our patients have smartphones that they don't really use because they haven't been taught. But we can create a visual graphic, taking a picture of them pointing to, okay, here's point to the photos, point to where this video is. Labeling things on their phone, even with the videos, I'll do it so it shows up on a search on their phone. And then I have a video of them doing their exercises so they can follow along with it so that they can remember how to do it correctly. And a lot of people are receptive to learning new things. So, the technology tools we've got, the Google Assistants, Alexa, Siri, all of them can be beneficial for our patients. Memory books also can be beneficial. So there are quite a few resources out there that are helpful for knowing how to use those. All right, so for swallowing, That's going to be based on what the clinical and instrumental assessments tell us. The treatments, there might be direct things like exercises, or there might be indirect, like some of our compensatory strategies. We might be addressing drooling, which is typically related to the reduced frequency of swallowing. So not so much that it's more saliva, but it's just people with these neurological conditions tend to swallow less frequently. Sometimes it's related to medication side effects. Medications and Botox can be used to help with drooling, but they also come with some side effects. And those side effects can be things like a really dry mouth or increased difficulty swallowing. So a lot of times doctors will, they'll be hesitant about addressing drooling with medications or Botox, especially if the patient has dysphagia. So they can have like no more than a mild dysphagia. Otherwise, it can put them at some significant risks. One of my goals as far as compensatory strategies is to be more proactive about AAC. I'm an outpatient, so I typically see people in the early stages and maybe the middle stages of Parkinson's. And often when someone gets to the later stages, they are getting home health or they're in a skilled nursing facility. So I'm not seeing them at the point where they need to have AAC, but I'm thinking, that's something we probably, could be doing at an earlier stage. And so that might be also part of our role for treatment, is getting people maybe used to using some form of assistive device or other technologies to help with communication. And then incorporating care partner training, that's something else I am working to get better at. There's a great paper called Take Us Into Account, and that was by Baylor et al. In 2024. And basically what this paper asks is like, how can we provide better services to care partners of people with Parkinson's disease? So the paper itself was on Parkinson's, but of course this information goes not just to Parkinson's, but to Parkinsonism and beyond. And the big question was like with the caregiver burden, like what are we doing as speech pathologists to help reduce that caregiver burden? And the people that were polled in that particular paper didn't feel like we were doing a lot to reduce their burden. They felt like we were adding to the burden because whenever they needed something to help with communication, we would tell them, okay, what you need to do is remind him or her to be louder. So we're telling the care partner, remind them to be louder, remind them to use their loud voice. And they felt like that's all they got was just these tips to tell someone to be louder. And they feel like they're nagging all the time when they have to keep saying that. They feel like it's not addressing all the other aspects of communication that loved one is struggling with. So, when I read that paper, I really thought, I need to change my education, my patient family education practice pattern, because that's kind of the advice I was giving people. They also didn't like the fact that we were giving what they call like just generic recommendations or generic tips. They wanted something more personalized. So that care partner training is going to be really important. And I say especially with the atypical Parkinsonism community, because they go through this rapid progression of symptoms. So the care partner's needs are going to change pretty quickly. What tips we give them, the first time we see them, they might come back a few months later or a year later, and it's going to be a completely different thing. And how can we prepare the care partners for how their role is going to change over a fairly short period of time? So there's just some things to food for thought. Here's some additional cognitive considerations. This comes from one paper, Ramo et al. In 2022. But they talked about common cognitive impairments among people with PD and atypical Parkinsonism, and the commonality, nonverbal reasoning, and memory. And then the difference between cognitive impairment among people with PD and atypical Parkinsonism, all of which are more severe in the atypical population: global cognitive functioning, executive functioning, visual spatial skills, and language impairments like naming and semantic fluency deficits. So this is where we have that dividing line. So this adds to our red flags. Additional information. People with PSP tend to have significantly more cognitive impairments than those with PD and MSA. And people with MSA share similar cognitive profiles with people with PD, except for poor performance in cognitive shifting. All right, so the team approach. Our team we have our rehab professionals, we have our physicians like the neurologists, the movement disorder specialists, other MDs, and then we have our patients and care partners. So I'm sharing this information for those of you, especially who don't necessarily work with a neuro team. So maybe you don't get a lot of people with Parkinson's on your caseload, so you don't see enough people with Parkinson's to recognize if something is atypical. Or maybe you work with PTs and OTs who don't work a lot with Parkinson's, so they're not necessarily coming to you and saying, hey, I see these red flags of atypical Parkinsonism. So these are some things just to kind of guide conversations with your colleagues, or help you, like if you do a chart review and you're looking at the PT and OT notes, just to guide that process to see if you all share some red flags for your patients. For the first person I want to highlight, this is Selena. This is an occupational therapist that I work with. And she gave some insights about things that your OT might report or might document. So for example, difficulty with oculomotor skills, especially shifting eyes up and down, left and right, convergence, which is the ability for both eyes to work together when something comes closer for that close-up vision, and scanning. Reduced proprioception, so just when the patient doesn't know where they are in space or they have poor body awareness. Difficulty with dual tasking. Behavior changes and outbursts, especially when they happen early in progression. So basically it looks like they flip on a dime. There might be like some paranoia, some name calling, things the patient did not do before. Rapid increase in rigidity. Myoclonus, which are quick, uncontrollable twitching or jerking motions. Difficulty with perceptual skills such as navigating doorways, just knowing how do I center myself so that I can go through the door without hitting my shoulders. Difficulty orienting clothing such as shirts and socks. Alien limb phenomena, as we mentioned earlier, just the limb just going wherever it wants to go on one side. Hallucinations, especially early in the disease process. Difficulty filling out forms or seeing food on the plate. All right, this is Nicole, a physical therapist I work with, and I personally selected this picture because she had just finished raising money for Parkinson's disease at the New York Marathon. So with Nicole, she talked about some of the things that PTs might document based on specific diagnoses. So for example, with PSP, lots of falls for someone early in the early stage of PD, more freezing a gait than is expected at their stage, or difficulty shifting from one surface to another, like from tile to carpet. Poor postural stability with inability to recover from that instability. So again, once they start going, they just go. Trouble with curves due to difficulty with downward gaze. Some of the things they do, there's something called a four-square test that they might give to the patient, and they tend to look for like their writing reflex, like what do they do once they start to lose their balance. With multiple system atrophy, PTs might notice significant dysautonomic impairments, leaning forward or to the side, cold hands or feet, corticobasal degeneration, unilateral apraxia, alien limb syndrome, significant visual spatial issues, bladder issues, quite common. She said in PT, a lot of times the patients with CBD, they might present like they have a unilateral neglect. And so they often need a target just to kind of know where they are in space. They get tired easily. Mirror therapy is used with them, and then also fall prevention and recovery techniques. With Lewy body dementia, falling backwards is something that PTs might notice with that, and then difficulty with like obstacle navigation or climbing stairs, difficulty with curves, just needing more guarding than that would be expected with someone with Parkinson's disease. All right, so now team communication with the doctor and the patient. So in our clinic, usually what happens is we just kind of talk as a team. So it's like you see the red flags and you want to know, does anybody else see any red flags? Because sometimes PT and OT might see something and I don't see a thing, or I see something and they don't see a thing. So it's really helpful when you can kind of get multiple perspectives. Because again, a lot of this looks like Parkinson's on the surface. So you discuss it with the team. We use messaging, and we're like, hey, I did this task with so and so today, and they had trouble with it. Has anyone noticed anything? And then once as a team, you've kind of like said, hey, we think something's going on. Then the next step would be to communicate those concerns with the physician. How you do that is going to depend on your relationship with your physicians. Some doctors, want to know right away if there's some concerns, and others like to just kind of collect information, and maybe they will do further testing, maybe not. It just really depends on what your relationship is. But you definitely want to communicate this information. You want to document in a chart like anything that the patient is having difficulty with that seems out of character for their stage in Parkinson's. And I'm saying stage in Parkinson's because, again, most of these patients come to us initially diagnosed with Parkinson's. And then communicating with the patients, you want to encourage the patients to reach out to their doctor or follow up with their neurologist. Now, here's where you have to be really careful. When you're talking to patients, again, there's a lot of dynamics at play. It depends on how comfortable you are with having some of these conversations. It depends on what your relationship is with the patient, your relationship with the doctor. But you want to use a lot of caution when you're talking to patients when you think something is atypical. For one thing, you don't want to scare someone. So if someone comes to you with Parkinson's and you're thinking, I think this might be atypical, you don't want to say, you know what? I think you have multiple system atrophy. The problem with telling someone something that directly, first of all, we can't diagnose that. And also, they go home, they Google, and then they start looking at life expectancy, and we could scare the bejeebies out of someone. And it could be that they have Parkinson's, but maybe it's some other things going on that is happening at the same time. So you just want to be real careful. Also, you don't want a situation where it's like your doctor said you have Parkinson's, but I think you have such and such. We don't want to step on the physician's toes as far as diagnosis because, again, it's just not within our jurisdiction to create that diagnosis. But we don't want to tell the patient everything's fine and dandy either. So just as far as like what I have done in the past with the patient I mentioned earlier that came in just with voice, I did have the patient and the wife talk to the primary care, and because I was just like, something that seems like maybe it's more than just the voice. I'm kind of wondering if something's going on. I didn't say I think it's Parkinson's or I think it's PSP. I just said, I was kind of concerned as far as when I see the whole picture. I think we should just take a look. And at that time, the primary care, they saw the patient. They didn't do a neurology consult. So I really felt like this patient really needed to see a neurologist. So I did kind of push, and I'll just say, well, we've worked on some voice things, but things aren't responding the way I would expect. I would really, really like for you to see a neurologist. And if everything's fine, everything's fine. But it would help me to create a better plan of care if we just rule out that there's some other reasons why your voice sounds that way or why your posture looks that way. So there's that way to have that conversation. If somebody already has a neurologist, I'm probably not as aggressive about pushing them to talk to their doctor. I'll say, you should mention to your doctor, what we're noticing in therapy. We're not getting the maybe the benefit or the progress that we'd expect. But if they have a neurologist, then I feel like I can kind of dial back a little bit because I can go directly to the neurologist and say, hey, this is what I noticed. So like for me, it's the patients who don't have a neurologist that I push a little bit more for. Now we recently had a patient that PT and OT were suspecting had PSP. And so what they did was they were talking to the family member who was like saying, oh, he's doing this at home or that at home. And so they said, well, how about recording that and then sending to the physician? So it was recorded, it went to the physician along with the PT/OT concerns, and then the patient did get a new diagnosis, shifting from Parkinson's to a Parkinsonism diagnosis. So that's another way to get that, get those red flags, get those concerns to the forefront of who can do some further testing and do the diagnosis. All right, so our key takeaways for today. Atypical Parkinsonism conditions have symptoms in common with PD. They tend to have limited or no response to levodopa. They also show symptoms not typically seen in PD, such as falls, freezing, cognitive and swallowing changes in the early stages, severe autonomic dysfunction, visual changes, especially difficulty with the downward eye gaze. Identification of atypical Parkinsonism is challenging and often requires a team approach. Use caution when discussing suspicions with patients and care partners. Here's my contact information. You can find me on Instagram at MedSLP Mentor. You can email me at community@medslpcollective.com. If you are a member of the Medical SLP Collective, find me in the Facebook group under VL Gary. And if you want to know more about some of the resources we have, go to medslpcollective.com. So here's where you can learn more information. First, see the references. I tried to include as many open access papers as possible, so a lot of the papers are accessible. There's a free CEU course on atypical Parkinson's by the Parkinson Foundation. There's a podcast series on atypical Parkinsonism, also by the Parkinson's Foundation. The Michael J. Fox Foundation has a webinar on atypical Parkinsonism. And a website that I absolutely love, Cure PSP. It is a very comprehensive site with resources on PSP, MSA, and CBD. If you want to get some tutorials, go to the Healthcare Professionals Resource section and you'll find tutorials loaded with information and guidance to help clinicians. And there are the references. And now I'm ready to take any questions that you might have. And I want to thank you so much for attending this presentation. Right.
Hello.
I know, hey. So I know a couple of questions came through. Somebody was asking about the cortical basal degeneration phenotypes. And so we have the cortical basal syndrome, frontotemporal dementia variation, progressive non-fluent agrammatic aphasia, posterior cortical atrophy syndrome, and progressive supranuclear palsy syndrome. And there's a listing and description of those in the references. And somebody else asked about eyelid opening apraxia. So it's interesting because we see that with Parkinson's and we see that with PSP, but I actually have not had a patient with that diagnosis. So I don't have any direct experience. I know that medications are something that they do, and also sometimes surgical procedures. But like Botox, levodopa, other medications are the kind of standard course, but I don't have any direct experience. So were there any other questions though?
There are two in the Q&A.
Okay. Let me go into there. All right, so I answered the first one. Evidence of EMST for atypical Parkinsonism, specifically MSAP. Yeah, that's a good question. I don't know. I know that it's not necessarily contraindicated, and we kind of look at it is beneficial for people with Parkinson's. So in cases like that, I think I give it a try. I'll let the doctor know that's what I'm planning to do, but I don't know specifically if there have been studies done on that particular population. Right. And then someone asked, when helping patients communicate with their doctor neurologist, do you ever work with their nurses? I know outpatient does not typically involve nursing, but I work with nurses so closely and inpatient that I hold them in high regard for problem solving. So curious if they're a good route for outpatient too. So yeah, so in outpatient, the patients don't necessarily have nurses. It's usually the nurse practitioner that's part of the physician's office. But absolutely, and like inpatient rehab, acute care, skilled nursing, the nurses are ones that really see that patient from day to day, and they might be the ones that come to you with some of those red flags, especially, let's say, for example, with Lewy body, when someone's having those good days and bad days, or those periods of confusion. So yeah, so the whole team, yeah, I didn't neglect them on my slide because I don't work with them, but yes, the whole team is very important. Right. Were there any others? I don't think there were any others.
A question came through from YouTube. Could you share any insights if a caregiver is reporting to you that their loved one is with this diagnosis is maybe refusing help, like having bouts of increased isolation, how to navigate something like that?
Yeah, that's tricky. So, and this can happen with a lot of these conditions, like, especially when we think about apathy, which is a characteristic feature. Getting neuropsych, if you have access to that involved, can be helpful. Also, depending on what your kind of community resource, like how much help do you have within the family? Sometimes a family member or a neighbor that a patient likes, they'll listen to that person better than they'll listen to the spouse or the children. I have seen people have success with that because, again, it's the ones we're closest to that we don't listen to. So almost stranger can come through and say the same thing, but that's challenging. There's no real cut and dry answer. That you would take a team approach, but it's really important because when we think about the pillars of brain health, that engagement, that mental stimulation is extremely important. So even if we can't stop a decline, we can stop it from being extremely rapid if someone is isolated, that they're going to have probably a faster decline because of that.
Well, thank you so much, Valeria. I think a few more questions popped in if you have time to look in the chat.
Yes, I'll answer
Oh,
them in the chat. Yes.
awesome. Thank you so much.
All right, thank you.
I want to introduce our next presenter, Ashley McKellis.
Hi, can you hear me okay? Perfect. Give me just a second to share my screen. Hi, everyone. I'm Ashley McKellis. This is Navigating the Complexities of Long COVID, Advanced Strategies for Speech-Language Pathologists. A little bit about me. I graduated from Case Western Reserve University in 2010 with a BA in Communication Disorders and Science after switching majors from a vocal performance music education degree. I graduated then from the University of Wyoming in 2012 with an MS in speech-language pathology. I've worked in private practice schools, multidisciplinary clinics, inpatient rehabilitation, outpatient rehabilitation, and acute care. I've also previously been a visiting lecturer for Jacksonville University on craniofacial disorders in infant feeding and swallowing. Previously was an adjunct professor of voice disorders at the University of Vermont. And I'm now a lead mentor for MedSLP Collective, and I am the owner of Empowered Voice Rehabilitation, which is my own private practice specializing in voice swallowing, upper airway, and neurogenic communication disorders. Couple of disclosures. Financially, I am the owner of Empowered Voice Rehabilitation. I also am a MedSLP Collective lead mentor, so I get paid for that. Non-financially, I'm an ASHA member and a SIG3 affiliate, and I also received a Parkinson Voice Project 2024 grant. So some objectives for this presentation. We are going to list the unique challenges and manifestations of long COVID in speech and language function, including cognitive communication impairments, dysphagia, voice and upper airway disorders, through an exploration of current research and case studies, identify evidence-based assessment techniques tailored to identify and evaluate the multifaceted impacts of long COVID on speech, language, cognition, voice, respiration, and swallowing, enabling clinicians to develop comprehensive treatment plans, and describe advanced intervention strategies and therapeutic approaches for addressing the complex needs of individuals with long COVID, including interdisciplinary collaboration, cognitive communication rehabilitation, dysphagia management, upper airway management, and voice rehabilitation to optimize functional outcomes and quality of life. So let's start off with having a, whoops. Oh no, go previous. Let's have some fun. I want you to type in the chat your answers to some of these things. I just kind of want to get an idea from where we're at. So have you treated a patient with long COVID? Yes or no? Okay. What percentage of SARS-CoV-2 infections result in long COVID? Give your guess in the chat. What percentage of individuals with long COVID symptoms report brain fog or cognitive dysfunction? What patient-reported outcome measure or measures have you utilized for patients with long COVID? What assessment tools have you utilized for individuals with long COVID? And what do you want to know about long COVID that you don't already know? All of the things. I love that answer. Perfect. All right. Well, hopefully I can answer some of this today. And we can kind of go with this together. I'm going to teach you hopefully some techniques you can use in your treatment and some assessment tools. So we'll kind of chat about that as well. So let's review some of the current information on long COVID. In 2021, long COVID was defined by the World Health Organization as a condition that occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19 symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. So let's talk about the prevalence. Greater than 10% of all SARS-CoV-2 infections result in long COVID symptoms. The research out there reports anywhere from 10 to 60% of individuals that have had acute SARS infections result in long COVID. The research also shows that 35% of individuals with long COVID symptoms will be individuals that were not hospitalized during their acute infection period. 87% of those hospitalized during their acute infection showed persistent symptoms up to 60 days after discharge. And of those individuals, 55% had 3 or more symptoms. 35% of individuals failed to return to their jobs 14 to 21 days after testing positive for COVID-19. And 34% of people received a neurological or psychiatric diagnosis within 6 months of their acute COVID-19 infection. Over 500,000 people in the United Kingdoms alone have had long COVID for more than 2 years. So although we're not currently like in the thick of the pandemic, we are still seeing residual with these long COVID patients. So it is something that you can see on your caseload. I see it still quite frequently. And it's important to note that the symptoms of long COVID can be continuous or they can be relapsing. So we're seeing kind of relapsing symptoms as well. Risk factors for developing long COVID, sex. Women are twice as likely to develop long COVID than men. Age, the older you are, the more likely you are to develop long COVID. So those in the 50-plus-year-old age group are 47% likely, 35 to 49-year-old are 32% likely, and then 18 to 34 is 26%. Although if you take the number of people that have had an acute COVID infection and you kind of parse that out, that is still a huge number of people that are probably having long COVID symptoms. Another risk factor is the presence of 5 or more symptoms during the acute illness. And then people who have had multiple SARS-CoV-2 infections are also at higher risk. So some of the common symptoms of long COVID: brain fog or cognitive dysfunction is reported in 85% of individuals with long COVID. Fatigue is another one that's pretty highly reported, 31 to 58%. Speech and language issues, 32 to 55%. Headache, 44%. Attention deficits, 27%. And dyspnea, 24%. You can see that a lot of those particular common symptoms fall into our realm of care. As far as the most predictive symptoms. These most predictive symptoms during the acute infection for developing long COVID are identified using what's called an odds ratio, or OR. So if you see OR on my slide, that's what that stands for. An odds ratio is a measure of association between an exposure and an outcome. The OR represents the odds that an outcome will occur given a particular exposure, compared to the odds of the outcome occurring in the absence of that exposure. So based on that, the most predictive symptoms that they're seeing in the research for developing long COVID is during the acute infection if the patient is showing fatigue, headache, dyspnea, hoarse voice, or myalgia or muscle aches. Here is just a laundry list of additional symptoms, and I'm sure I've forgotten some on this list because it just goes on and on and on. Because long COVID patients present with such a diverse array of symptoms and symptom combinations, it can make assessment and treatment of these patients incredibly challenging. You can kind of see that there's still a lot on this slide that falls in our realm. I've kind of bolded and italicized the ones that kind of relate back to us more, or kind of the ones that kind of stand out to us on the chart. So as far as kind of how what is the current theory of mechanism, there's a lot of different research. And there's some possible proposed underlying mechanisms. Nothing has been completely agreed upon. So it's, again, kind of hard not knowing what the true proposed underlying mechanism is. But there have been a number of different proposals, including direct viral encephalitis, immune activation and systematic inflammation or cytokine storming, persistence of the virus or antigen reserves in the organism, possible existence of autoantibodies in that may act against immunomodulatory proteins, disrupting immune function, peripheral organ damage or dysfunction, particularly in the liver, kidneys, and lungs, cerebrovascular changes such as stroke or ischemia, mast cell activation disorders, vascular endothelium activation or dysfunction, microbiota dysbiosis, and reaction of Epstein-Barr virus or other latent viruses. And while we have all of these different kind of proposed mechanisms floating around in the research, the majority of the researchers have heavily impacted or implicated chronic hyperinflammatory response due to cytokine storming, so that immune activation one that's listed there second, as the proposed underlying mechanism for long COVID. Even though these additional hypotheses have been proposed, that's probably the one that stands out the most in the research. If you want to find out a little bit more about that, I did do a 2-hour webinar on long COVID back for the MedSLP Collective. So if you're a MedSLP Collective, you do have access to that. And I talk in depth on that, about that cytokine storming and what it is and how that is kind of implicated with long COVID. And if you're not a MedSLP Collective member, we do have open enrollment going on. So if you want to learn more about it, that is a webinar that is in our bank of resources. The literature also currently contains a rich data set on multisystem organ damage caused by mild to severe SARS-CoV-2 infection. And in many cases, the observations, which include brain volume changes, neuroinflammation, olfactory bulb, and cardiac changes. So again, we're looking at kind of like multi-system problems. There is also evidence that there may be subtypes or phenotypes for long COVID, indicating that there may be more than one underlying mechanism, which again just makes these treating and assessing these patients pretty complex and pretty difficult. Adingupu et al. In 2023 came out with an article that researched actually the hemoglobin in post-COVID participants compared to healthy controls, and they found lower levels of hemoglobin. These patients all had a neuropsych assessment, which showed significant impairment in the post-COVID-19 participants compared to healthy controls. They did the symbol digit modality test, oral, the control of word association test for both FAS words and animals. And then they did the paced auditory serial addition test. Additionally, they were looking at the relationship between the oxygen saturation of the patient and microvascular cortical oxygenation. And they concluded that approximately 1/4 of the people with long COVID had significant hypoxia in the brain, measured at least 7 months post-acute infection. So they proposed kind of based on the cytokine storming theory or underlying mechanism that there's also a hypoxic inflammation cycle that is occurring for individuals with long COVID. So what do we do, and like, how do we treat this and how do we assess it? Because it's so complex. You want in your assessment toolbox, motivational interviewing, collaborative goal setting with your patient, use of patient-reported outcome measures, and we're going to go over some of the ones that you can use, and then standardized assessment tools. So as far as patient-reported outcome measures, there are a lot of different ones out there that you can choose to use based on the symptoms or symptom groups that your patient is showing. So for example, if I have a patient that comes in with laryngeal hypersensitivity, I might choose to use the Newcastle Laryngeal Hypersensitivity Questionnaire or the Vocal Tract Discomfort Scale. If they also come in with dysphonia, I might throw the Voice Handicap Index 10 at them. So it's kind of just a mix and match of the patient-reported outcome measures that are already out there. So I've kind of picked out some of the ones that I have previously used with some of these patients, depending on what symptoms they have presented with, as well as some of the ones that are being used in the long COVID research by the researchers and by the people that are kind of looking at this. So for laryngeal hypersensitivity, we have the Newcastle or the Vocal Tract Discomfort Scale. For chronic cough, you might use the Chronic Cough Index or the Cough Severity Index. For dyspnea, you might use the Dyspnea Index or the Modified Medical Research Council Dyspnea Scale. For dysphonia, you might use the Vocal Handicap Index 10 or the Voice-Related Quality of Life. For cognitive linguistics, you might choose to use the NeuroQual or the Cognitive Communication Checklist for Acquired Brain Injury, the La Trobe, the Behavior Rating Inventory of Executive Function Adult version, the PROMIS Cognitive Function Short Form, or the Multifactorial Memory Questionnaire. And these are just some basic suggestions on kind of throwing things together for your patients. But you can also choose ones that are not on this list. These just happen to be the ones that I have used or that were present in the literature for these patients. And then dysphagia, you may do the Dysphagia Handicap Index or the EAT-10 or the SWAL-QUAL or the Reflex Symptoms Index. One major symptom that these patients all tend to show, or a lot of these patients have, is fatigue. So as far as patient-reported outcome measures for that, there is the Functional Assessment of Chronic Illness Therapy Fatigue Scale, or the FACIT-F. This is a 13-item self-report questionnaire that measures the severity and impact of an individual's level of fatigue during their usual daily activities over the past week. It ranges in score from 0 to 52, where a lower score indicates more severe fatigue. The cutoff score is anything less than 34, which is indicative of clinically relevant fatigue. It is available in multiple languages. There's no fee for use for the English version, but you do need to obtain a license. It's pretty easy to obtain, and it's on their website, so you can look into that. Licensing fees are typically not applied to investigator-initiated research, students, or clinical use. Besides the FACIT-F, you can also use the Modified Fatigue Impact Scale or the Mental Fatigue Scale. So those are just ones that you have in the toolbox for that component if you need it. As far as the FACIT-F, I do want to just point out it's not been validated for use of long COVID-related fatigue, but it has been validated and used with cancer, HIV, lupus, rheumatoid arthritis, psoriatic arthritis, anemia, COPD, Parkinson's disease, and post-stroke. And the fatigue measured in the Adingupu et al. 2023 research article that I pointed out earlier, they used the FACIT-F to measure fatigue for their patients in that study. And they found that fatigue measured using that particular patient-reported outcome measure was particularly severe in they're individuals with long COVID compared to their control group. There's also the EuroQual 5-dimension 5-level questionnaire that's been mentioned in the long COVID literature. It has confirmed responsivity, interpretability, feasibility, and partially verified reliability and validity. It's available in more than 150 languages and in various modes of administration. The current evidence in the research suggests that you can use the EuroQual 5-level for assessing health-related quality of life in long COVID patients. It can be easily licensed for commercial or non-commercial use. And there's also a youth version available for ages 8 to 15. So that's another one you can have in your toolbox if you don't already. And the last one that's specific to kind of long COVID is the post-COVID-19 functional status scale, or the PCSF. It's useful when examining patients' functional status after COVID-19 infections. It's easy and quick to administer. It's available in multiple languages. It's free to access and use. I have the link here. There's good inter-rater reliability, and construct validity has also been reported. Besides those, I want to kind of take you to the one that I use, which is one that I developed from a questionnaire that a group developed at the University of Vermont Medical Center when I was working there, when we were doing long COVID research. So this is kind of based on that. It's a departure from it, based on my own work with long COVID. So this is what I use. So we're going into what looks like, this is my EMR for those that are wondering. But this is the questionnaire that I use with my long COVID patients. Because there are often so many different things going on, I kind of want to get information on all of those things without overloading them with like 20 bajillion questionnaires. And so I like this one in that it gives you a rating of what's happening with these symptoms now versus where they were at pre-COVID. And so it starts off with breathlessness or shortness of breath, like at rest now versus pre-COVID, upon exertion now versus pre-COVID. Then it goes into some airway and voice stuff. And again, everything is like rated as now versus pre-COVID. Eating, cognition and language, mental health. And I use this as a screener too to kind of figure out if they need additional services beyond just me. Cardiovascular symptoms that may impact our treatment, vestibular or autonomic problems, musculoskeletal problems, and then overall health. So I tend to use that one just because it kind of gives me a baseline of all of the different things that they might be experiencing that maybe I need to either consider in my treatment, make a referral for, or kind of like figure out what I need to assess further. So let me go back to my other. Okay. So as far as assessment tools for language, if your patient is having language issues, the one that is mentioned the most commonly in the long COVID research for specifically word finding and recall is the COWAT, or the Control of Word Association for both FAS words and animals. That's great because we don't need any materials for it. We can just do it with a 1-minute timer. And the normative data you can easily find online. Additional ones that have been mentioned in the long COVID research are the Mount Wilga high-level language test. I've previously used the expressive one-word picture vocabulary test before. And then also language sampling is something that I use. I have had people tell me that they are using the Boston naming test for word finding. I do want to point out that according to Adingupu et al. 2023, 97% of individuals with long COVID obtained normal scores on the Boston naming test, despite reporting that they had word finding difficulties. So that may not be the best choice based on that particular report. As far as assessing cognition, you can use the brief test of attention, the repeatable battery for the assessment of neuropsychological status update, or the R-bands, the functional assessment of verbal reasoning and executive strategies, or the favors, the Click It Plus, the FEMAT 2.0 is another one that I love for this population because it's free. You can find it online, and it helps you kind of get an idea of what they can do functionally. So I really like that. You can also use something like the RIPA-G if they fall into that age category that it's normed for. For voice, as far as assessment tools, you can use video stroboscopy. Per research by Shacksand et al. 2022, video stroboscopy results showed laterally mobile vocal folds, non-irritant mucosal conditions, wide irregular vibration amplitudes, and incomplete glottis closure. So that's kind of what they are seeing. A lot of the patients that I see tend to have fairly normal video stroboscopy, but then their perceptual measures and acoustic measures are kind of like really funky. So for perceptual measures, you can use the CAPE-V or the Gorbasi, depending on which version you're using. Acoustic measures, your traditional ones like capsular peak prominence or the AVQI. Aerodynamic measures can be utilized. And then I always recommend vocal plasticity assessment with these patients because that can be really helpful in figuring out a direction to move, given the fact that the video stroboscopy tends to be at least somewhat normal. Not always, but that kind of tends to be my experience. As far as dysphagia, you can use FEES, MBS, clinical swallow evaluation if they're reporting any kind of swallowing dysfunction. So that's kind of our assessment toolbox. It's kind of parts, but it works. And if you kind of listen to your patient and assess the different symptoms that you need to assess. As far as intervention strategies, let's go over a few of them. The first one that I kind of want to focus on is dyspnea, because dyspnea tends to be kind of like the classic symptom that most of our patients with long COVID present with. So some of the things that I use as intervention strategies. The first is alternate nostril breathing. Are you guys familiar with alternate nostril breathing? Who knows about that? Who's used it? Okay, I'm seeing a lot of no's right off the bat. So let's go over this. So alternate nostril breathing is a technique where you have the patient breathe through their nose, but you're going to have them plug one side of their nose. They're going to breathe in. And then they breathe out through that side. And then you switch. And you want to have the patient breathe as slowly as possible, both on the inhale and exhale. And you keep alternating. So you keep plugging one side and just alternating the breath in and out. Okay. I'm hoping that you did that with me so that you could figure it out. Yeah, and it is used in yoga. So alternate nostril breathing has been shown to result in decreased heart rate, decreased respiratory rate, decreased blood pressure, as well as increased respiratory muscle strength, increased lung compliance, and reduction in airway secretions. It's also been shown to decrease anxiety through stimulation of the parasympathetic nervous system. So this can be a really good technique to target a lot of the different things that might be happening with these patients. And so that can be something that you can have in your toolbox. What I will tell you is that sometimes these patients, especially if they're experiencing dyspnea, will have trouble with alternate nostril breathing at first, or they may need to do very short breaths. And you might need to slowly build them towards a longer, slower breath. Okay, and then resonance breathing would be another one that you could have in your toolbox. Who's familiar with resonant breathing? So resonance breathing is going to be where you are teaching the patient to kind of breathe in what I kind of envision as a circle. The breath never stops. It just keeps going. Okay. And the top portion of the circle is going to be the inhale, and the bottom portion of the circle is going to be the exhale. So you want to match the inhale to the exhale. And so you're going to have them like breathe in and then breathe out and then breathe in, and it just kind of is continuous. And typically with resonant breathing, you're shooting for a count of between 5 and 6 seconds for the inhale, or 5 and 6 seconds with an exhale. That's kind of the number that you're shooting for. Your long COVID patients are not going to be able to do that off the bat. I will tell you that right now. I have patients that maybe do 2 and 2 to start, and then we work up from there. So kind of to talk about that a little bit more, there's research by Palisi et al. 2024 that indicates that resonant breathing may be an incredibly beneficial technique for the COVID toolbox. In their studies, patients reported improved sense of wellness, ability to focus, ability to breathe, ability to control stress, and sleep quality following use of this protocol that they did. Their patients participated in a 4-week progressive resonant breathing program and they used a 4 to 6 second cadence. So 4 for the inspiratory breath and 6 for the expiratory cycle. For an initial 10-minute period that then built up to a 30-minute period by the end of the 4-week program. I want to just kind of quickly go back to alternate nostril breathing because I forgot to mention something about that. There is research by Sinha et al. 2013 that suggests that dosing for alternate nostril breathing is best completed at 5-minute periods for a total of 6 weeks. So if you're thinking about dosing, that might be helpful for you. Then there is box breathing. So instead of the circle, now we're thinking about the breath in a box. And for that, you're going to do a breath in for a count. You're going to pause the breathing for a count, exhale for a count, and then pause the breathing again as you go along that box. Typically, you want these to be kind of similar in count. So if I'm doing a count of 3 or 4, let's start with 4. I might breathe in for 4 counts, pause for 4 counts, exhale for 4 counts, and pause for 4 counts. And so that is another one. Typically, you're shooting for about a 4 count to a 6 count with the breathing and the pauses. But most of the patients that I work with, we start at like a 2 count because they can't do like a 4 or 6 count. Okay. And then, another one that I use in intervention is for dyspnea is hypoventilation exercises from Buteyko breathing. So if you're trained in Buteyko, those can be really helpful. I've had to modify them a little bit to make them kind of more adaptable to my long COVID patients. but they have been really helpful, especially like breath pacing and moving things into exercise or into areas where they might have some autonomic dysregulation. So that's something else I use. Then for chronic cough, you might choose to use some of those cough suppression techniques that are out there. Again, I kind of reference back to our MedSLP resource library. There is a resource in there on the various different cough suppression techniques, so you can check that out. As far as dysphonia treatment, you may be working with indirect therapy techniques or some direct therapy techniques like semi-occluded vocal tract, resonant voice therapy, and then possibly some manual therapy as well. For dysphagia rehabilitation, it's going to depend on the patient's impairments based on their instrumentals and the clinical bedside swallow, but you may be using rehabilitation techniques or compensatory techniques. For language, we can use word retrieval strategies and then aphasia strategies for deficits in expressive language, receptive language, reading comprehension, and written expression. And then for cognition, we're typically doing metacognitive strategy training. And the one thing I don't have on here is we're typically also teaching the patient to deal with their fatigue levels. And so that I typically use something like spoon theory to talk to the patient about that. So that is something that's not on here, but should be. And I apologize for that. As far as anosmia, hyposmia, or parosmia, which is another common symptom for individuals with long COVID. Most individuals with COVID-induced olfactory loss recover within 4 weeks following the acute infection, but as many as 12% of people continue to experience a significantly decreased sense of smell or persistent hyposmia, anosmia for months to years after the acute infection. This is a question I get asked a lot in the MedSLP collective forum, which is why I wanted to just include this information for you guys today. Olfactory disruption can have a profound negative impact on nutritional intake, taste, enjoyment of eating, social interactions, and has been linked to social isolation, mood disorders, and cognitive decline. So it has an impact on our kind of scope of practice, even though it's not technically like within it. It does impact all of the areas that we treat as far as like swallowing, cognition, mood, and so it is important for us to kind of be aware of. Olfactory dysfunction also decreases a person's ability to detect hazards such as toxic odors, smoke, fire, or gas leaks, making it a safety concern, particularly in light of the concurrent cognitive issues that we know are seen so frequently with long COVID. So rehabilitation for olfactory problems can consist of olfactory training therapy, or OT, which consists of daily repeated intentional odor exposure over a period of several months to different products, different spices like oregano, cinnamon, thyme, things like rose, eucalyptus, lemon, or flowers, and trying to differentiate between them with the eyes closed and in different combinations. It's been used in long COVID rehabilitation in the research with some limited success, but it is often recommended due to the low risk to the patient. Additionally, some research has mentioned PRP, which is platelet-rich plasma, and it's been mentioned in the research to try to improve olfactory function in long COVID hyposmic individuals. However, the efficacy is limited for that. So there's not really any great solutions to olfactory training right now, but olfactory training is probably the least risk to the patient with the most promise at this time. So I want to go through a case study with you guys. This was a 70-year-old woman that I was referred to my private practice for outpatient speech language pathology services for a dysphonia evaluation and management, secondary to sudden profound voice problems. She was diagnosed by ENT and pulmonology with false vocal cord hyperfunction and dyspnea. When she came to see me, she did not have a diagnosis of long COVID. She reported symptoms of aphonia, wheezing, dry cough, shortness of breath, high heart rate following exertion, blood pressure issues, brain fog, anomia, and bilateral limb neuropathy. Now, as I was talking with this patient and trying to kind of do the patient interview and get more information about this, she told me that her symptoms started about 2 weeks following when she recovered from 2 acute respiratory infections, one of which was the flu, the other of which was COVID-19. This was not in her medical chart when I received her referral, so it's just something that she told me as we were kind of like digging into things. And all of a sudden, some of the symptoms that she was reporting to me made sense. So additional prior medical history for this patient, she was legally blind. She had depressive disorder, osteoarthritis, osteoporosis. She'd had 2 neck surgeries, 4 screws and a plate, hip surgery, a bulging disc in the lower back, and a history of reflux. Some additional information. She didn't work, but she volunteered a lot at a school where she had to use her voice quite frequently. She had recently started seeing the cardiologist because she was failing her EKGs. Pulmonologist recently switched her off of Symbicort and onto an albuterol inhaler, and she was not using a spacer with her inhaler. And the cardiologist had also recently put her on losartan. So I'm hoping that you guys can hear these. Let me know if you cannot. This is a sample of her voice from our initial evaluation. And it's not playing. Of course not. Let me see how I can do this. I'm going to pull it up for you guys another way. Hold on. Let me see if change my speakers. Of course, it's going to give me some technical problems here.
I can see if I can pull it up on my end, Ashley.
Can you? Let me, Casey, I'm just going to email them to you. Okay. Okay, Casey, I just sent you the initial evaluation ones. I'll send you the other ones that I'm going to play later in a separate email.
Okay, Joy actually just said if you take off your earbuds, it should work.
I did, and it didn't work.
Which would you like me to start with?
Can you start with the Cape V sentence? Did I send you that one?
Away a year ago.
Perfect. Can you go ahead and do the sustained ah and then the PB&J?
and out of the refrigerator peanut butter and jelly and spread them on the bread with a knife.
Perfect. So as you can hear, hopefully, the patient had a profound voice impact. I attributed this to COVID-19 with potential of long COVID symptoms based on her timeline and other reported symptoms, with losartan from the cardiologist. You remember she was just started on that as a possible causal or contributing factor to the patient's persistent dry cough, as that can be a potential side effect of the losartan. So we were kind of looking at that from the beginning. So let me share my screen again. So in treatment session 1, patient reports that she had gotten a spacer for her inhaler. We had kind of talked about that in our initial evaluation. I provided her education on vocal health and hygiene, healthy breathing, nasal and diaphragmatic breathing, and various nasal breathing exercises, including alternate nostril breathing, box breathing, and buteco hypoventilation exercise. I did do some manual therapy with her, and then we did some semi-occluded vocal tract was performed. We tried using just a regular straw into just a little bit of water, but it was triggering her cough significantly. So we modified it in a way that it would eliminate the cough trigger by making it very short. And then she was also at the point where she was kind of like whispering all the time. So she was assigned to try to use a confidential voice in place of whispering at this session. So that's kind of what session 1 looked like. Then session 2, patient reported that she was placed on 400 milligrams of gabapentin and was being sent for a brain MRI because of the brain fog. We did some modified box breathing exercises to a smaller count because the ones that I had assigned her in session 1 were starting to trigger a lot of dysautonomia with her. She also reported that the buteco hypoventilation exercise was triggering the cough. And so she was then educated on various cough suppression techniques. The semi-occluded vocal tract, the modified version that we were using, was no longer triggering a cough with bubbles in the water with just air movement. So we advanced it to including just a static pitch and some very short ascending and descending pitch glides. And then we also did some exercises with forward focus resonance, including the use of a tongue protrusion M, which really helped with that particular patient. In session 3, the patient came in reporting that she had failed her breathing test. She was being sent for a CT scan of her neck and chest by pulmonology. She also reported that she'd been having continued issues with dysautonomia, post-exertional symptom exacerbation, and dizziness. We discussed the pros and cons of adding respiratory muscle strength training into her treatment plan, given her dysautonomia, and decided that at that point in time, it was not safe to include that in her plan of care. And we would kind of put it on the shelf for later. Manual therapy was provided. She was instructed in a few laryngeal self-massage techniques, and we solicited a referral for cognitive communication evaluation due to the continuing reports of brain fog and word retrieval deficits. And at that point, session number 3, her dysphonia was almost completely resolved. Then session 4, the cardiologist placed her on metoprolol, 25 milligrams, and dropped her gabapentin from 400 milligrams to 300 milligrams because she was having some weird symptoms with the gabapentin, which we all know is one of those ones that can definitely do that. We talked a lot about breath pacing for exertion because she was actually doing fairly well at that point with the box breathing and with the alternate nostril breathing, but was having trouble with movement. And so we started doing that with movement and exertion. So for example, one of the ones that she was having trouble with is she would trigger her dysautonomia when she was bending over to get her plates out of her dishwasher and then standing up and putting them up into the cabinet to put them away. So we actually worked on the breathing during that functional activity and talked about how to breath pace that. She was able to utilize that technique to walk longer distances without triggering her shortness of breath. And then when standing up from a squat, she had a dysautonomic response that was resolved using various nasal breathing techniques that we talked about kind of earlier. And then further education was given on how she could complete the exercises during various ADLs, like making the bed or putting food in the microwave, which were both things that were triggering her dysautonomia. And then session 5, she reported that during a recent nursing visit, she was asked if she was aware that she also had been diagnosed with COPD. So this case just kind of gets more and more complicated as we go. She reports continued difficulty with dysautonomia and PESI, or post-exertional symptom exacerbation. She also questioned during this session whether she may already be sick with another new upper respiratory infection, either the flu or COVID, although she had tested for COVID right before I came and it was negative. But she was having a lot more problems. Rescue breathing strategies for ILO and EILO and breath pacing were introduced and practiced with a favorable response. Manual therapy techniques and SOVT were performed again. And then patient requested deferral of services for her cognitive linguistics at that point because she felt like her dyspnea was just such a larger priority at this point. And so we kind of put that on the back burner. And then session 6, pulmonology confirmed a diagnosis of ILO after being sent my notes. And the patient did have the flu the previous week. So she was right that she did have an upper respiratory illness again. She was continuing to have dysautonomia and post-exertional symptom exacerbation. She reported that once a coughing fit got started, the rescue breathing strategies did not seem to work, but if she implemented them prior to the coughing fit, at the initiation, they did seem to work. So we talked about kind of figuring out the timing for that. And then we discussed how to identify when to implement rescue breathing strategies and cough suppression techniques. Session 7, she reported that her new pulmonologist took her off the nebulizer and the inhaler and gave her and put her on fluticasone propionate and salmeterol twice a day. She reports that it made her cough worse. And she reported continued fatigue and dysautonomia. Her gabapentin was then upped again to twice a day. Her dysphonia had returned at this point, almost to the point where it was when we initially started. And she was complaining of focal neck tenderness and had visible external swelling. I recommended icing for 10-minute periods to her neck. And we placed a call to the pulmonologist to discuss the new medication and symptoms during her session, because she at this point couldn't really even talk. So she couldn't talk on the phone to them. So she had me call the pulmonologist and talk with them during this session. Session 8, patient reports that icing her neck seemed to help after our last session significantly with the swelling and with the focal tenderness. She also reports that she was able to walk around her entire complex using the breath pacing successfully for the first time. And due to the return of the dysphonia, we returned to manual therapy, SOVT, and resonant voice therapy. And then session 9, she reports that the pulmonologist finally did end up taking her off of the fluticasone propionate and salmeterol and put her on Trelegy instead. And she reports that she'd been doing much better on the Trelegy, but that she could feel it wear off around 22 hours into the 24-hour cycle. Her voice symptoms were once again resolved. Pulmonology had also finally cleared the patient for RMST. So we educated her on use of the EMST 75 Lite and the IA 150. And we talked about prioritizing the IA 150 over the EMST if doing both resulted in a long COVID crash. And patient felt really confident in her voice and her breathing toolbox at this point, and also reported that her brain fog and word retrieval deficits were at a manageable point, even without intervention, because her breathing and stuff was more under control. So at this point, she had requested a discharge from SLP services. So what I want to do now is I'm going to stop that. Casey, I'm going to send you the end result one, if I can find it. Let me make sure. I think this is it. Okay, I just sent those over, so hopefully you can play those.
Oh, just got them.
Okay.
We were away a year ago. Unwrapped bread. Put peanut butter and jelly on the bread and enjoy.
So as you can hear, huge difference from her pre-voice, which was pretty much non-existent. So she was very happy with that. It was, and I've actually messaged her back and forth since then, and she is doing phenomenally now. That we've got the medications figured out, and that she's doing the IMST and the breath pacing. She's just like made a lot of gains. Although I'm no longer seeing her, I do keep in touch. So that's kind of where that's at. And then let's see. So you got to hear that. Oh, come on. There we go. So some key takeaways. Long COVID symptoms can be complex, affecting various organ systems, including neurologic, respiratory, musculoskeletal, and psychological functions. The diverse array of symptoms makes assessment and treatment challenging, requiring personalized approaches and comprehensive evaluation. So here are the references. And then here's my contact information. If you have any further questions, you can ask those questions in the chat as well. And Casey, I don't know if we have time for questions. I know I probably ran a little long.
We might be able to take one, and I saw a few of the same. So I can
Okay.
definitely ask this one, and then if you want to pop into the chat and
Sure.
any others that come through. So one of the big questions that came through is how can we bill for this? What does that look like? Someone had specifically asked about dyspnea and like speech rationale. If you want to maybe talk a little bit about billing.
Yeah, so yes, you can definitely bill for this. It is something that is medically necessary and you can justify. Our scope of practice does include upper airway, which is, includes dyspnea and shortness of breath. And that impacts directly the voice and all kinds of other things. So this is definitely something you can bill for. As far as like goal writing and recommendations for that, let me see. I'm going to see if I can quickly pull up. Let's see. I'll give you an example. So how I wrote her goals was patient will learn and implement breathing strategies and techniques to manage symptoms of dyspnea and to improve respiratory drive for phonation. So if you can kind of like tie it back in to that phonation piece, that's definitely something you can do. Our patient will learn and implement various resonant voice techniques for improved coordination of voice subsystems as measured by clinician perception of vocal quality. So those are just some examples of the goals that I had for her. Okay, and I can pop into the chat and get out of your way so that you guys can get started with the next one, unless there's something else.
Another one that came through, who would we recommend a patient see for rehab for anosmia?
Ooh, so there's not like a particular person, which is kind of frustrating, right? But because it does tie into a lot of the things that we do, we can teach them some of the information about the olfactory training and then have them do it on their own. So it's not something I would do in their treatment session, but it's something that I might educate my patients on and provide them with the information on how to do it and then let them do it on their own.
Awesome. Thanks so much.
Yep, and I'll hop into the chat and just answer questions.
Everyone, we are going to dive into our first quick break, and then we will come back for our next presentation.
Please view important safety information, including indications and usage, at the end of this video. Meet Janie. She's a speech-language pathologist, and it's her first day at Excellence Medical Center. She's excited to be part of a top-tier institution and eager to help her first patient. As she prepares to do her first modified barium swallowing study, Janie's surprised to learn they don't use the standardized Veribar barium sulfate products. At the weekly staff meeting, Janie brings up her concerns about doing MBS studies without Veribar. She learns that her colleagues know about Veribar and thought it would be nice to have, but feel they're okay with how they do things now. Janie responds, "This is not a nice to have, it is a need to have." She goes on to explain that Veribar is the only line of contrast agents approved by the FDA for MBS studies. It was developed in conjunction with doctors Jerry Logeman and Joanne Robbins, who recognized the need for standardized viscosities. The staff insist that they all mix the same recipes and therefore are already standardized. Janie points out it's impossible to be standardized when you're mixing and modifying contrast agents that are not developed or formulated for the MBSS. It is also much more likely to result in human error. Janie asks, how many have had patients who've undergone repeat exams? Janie insists that as SLPs, our job is to ensure the exams are standardized and reproducible across the continuum of care. She continues by discussing problems with the GI barium products, most of which are designed to coat, unlike Veribar. Coating can be mistaken for residue and lead to potential false positives. After making her case, Janie asked her colleagues if they would be willing to try Veribar. When her colleagues agreed to try Veribar, Janie contacted Bracco to consult with a clinical specialist. After a trial, everyone agrees that the Veribar products should be implemented. However, they disagree on which Veribar products they prefer. Janie refocuses the staff on the science and reminds them that evidence, not opinion, should guide clinical decision-making. The staff expresses concerns that radiology won't allow the full line, and they begin to discuss which product they could forego if they needed to compromise. Janie responds, "We should not compromise when it comes to patient care. I will be happy to talk with radiology and present the literature." The next day, as Janie meets with the radiology administrator, she discusses the importance of using standardized materials and how it relates to patient safety, professional communication, and protection from liability. She also explains how the Veribar line is different from other GI barium sulfate products and how it meets the needs of the MBS studies. The administrator is impressed when he learns that only Veribar is FDA approved specifically for MBS studies and offers benefits beyond improved efficiency. From that day on, the only product line at the Excellence Medical Center used for modified barium swallow studies was Veribar. For more information on the Veribar family of products or to learn about our sampling program, email us at veribar@diag.bracco.com. Provide your name, location, and phone number, and the appropriate sales specialist will contact you. Please view important safety information, including indications and usage, at the end of this video. Meet Dave. Dave is getting ready for his annual trip to the Outer Banks of North Carolina for a weekend of fishing and fun. It's a tradition that Dave and his fraternity brothers have been doing for 25 years. Dave looks forward to this trip every year, catching up with friends, fishing, and eating. For him, it's a time to relax. But this year, he almost didn't go. You see, 6 months ago, Dave had a stroke. In the hospital, while taking his meds, he began to cough. His nurse made a note of it, and Dave was referred to a speech-language pathologist for potential stroke-related swallowing issues. Meet Sandy, Dave's first speech-language pathologist. Due to concerns about Dave's ability to swallow, Sandy recommends a modified barium swallow study, or an MBS study. Sandy has been conducting MBS studies for years, so preparing the different contrasts is nearly automatic for her. First, Sandy prepares the thin liquid. She pours about 3 ounces of liquid EasyPake into a cup. But EasyPake is a little bit thick. It pours more like a nectar than a thin liquid. So she adds about 3 ounces of water to thin it down. perfect. Sandy's happy with her thin liquid mix. Next, she prepares the nectar thick liquid. Looks about right, she thinks to herself. Now Sandy is preparing a honey thick liquid. Sandy's done this countless times and quickly eyeballs the right amount of thickener. Next is the puree. Sandy mixes easy paste with pudding, the way she's accustomed. Finally, Sandy prepares the solid by spreading some easy paste onto a cookie. Sandy is confident with her work. The nectar thick liquid wasn't exactly to her liking, but she quickly dismisses any doubts and begins the test. She hands Dave the thin liquid and instructs him to take a small sip to begin. After the test, Sandy meets with Dave to discuss the results. She tells him about the upcoming therapy. When she lets him know about food restrictions and modifications, it really hits home. After 4 weeks of therapy at the rehab hospital, Dave is on his way to take a second MBS study. Meet Kim. Kim is Dave's current SLP and has been working with him at the rehab hospital. They're both excited with his progress over the past 4 weeks, and Dave is hopeful he can return to a normal diet. He wants to enjoy his trip to the Outer Banks, and this includes cooking and eating all the fish they catch. Kim has prepared more MBS trays than she can remember and has always done it the same way. Kim wonders if this is really a reproducible assessment. As Kim reviews the results with Dave, neither one can believe it. How could it appear that Dave's condition hasn't improved compared with Sandy's test? Later that day, Kim remembers a conversation with a colleague about Veribar, the only standardized contrast approved for MBS studies. Kim contacts Bracco for information about Veribar and requests samples. The Bracco dysphagia specialist explains that not all barium products are alike and schedules an online education session to explain the science. After receiving the samples and retesting Dave, Kim finds that the results are consistent with her initial expectations. Dave is both relieved and excited because he really has improved. He's also excited about going to the Outer Banks and enjoying his regular meals the way he's accustomed to.
Veribar barium sulfate. Veribar thin liquid barium sulfate for oral suspension. Veribar thin honey barium sulfate oral suspension. Veribar nectar barium sulfate oral suspension. Veribar honey barium sulfate oral suspension. Veribar pudding barium sulfate oral paste. Indications and usage. Veribar thin honey barium sulfate oral suspension, Veribar nectar barium sulfate oral suspension, and Veribar thin liquid barium sulfate for oral suspension are indicated for use in modified barium swallow examinations to evaluate the oral and pharyngeal function and morphology in adult and pediatric patients. Veribar honey barium sulfate oral suspension and Veribar pudding barium sulfate oral paste are indicated for use in modified barium swallow examinations to evaluate the oral and pharyngeal function and morphology in adult and pediatric patients 6 months of age and older. Important safety information. For oral administration, this product should not be used in patients with known or suspected perforation of the GI tract, known obstruction of the GI tract, high risk of aspiration, or hypersensitivity to barium sulfate products. Rarely, severe allergic reactions of anaphylactoid nature have been reported following administration of barium sulfate contrast agents. Aspiration may occur during the modified barium swallow examination. Monitor the patient for aspiration. Please consult full prescribing information for Veribar products. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Veribar is manufactured by EZM Canada Inc. for EZM Inc., a subsidiary of Bracco Diagnostics Inc., Monroe Township, New Jersey 08831. Veribar is a registered trademark of EZM Inc.
Welcome back, everyone. I am going to share our next presentation. It was pre-recorded by Dr. Kristen West. She will actually be available in the chat to answer any questions throughout the presentation. So please feel free to drop your questions in the chat and she will answer them there.
Hi, everyone. I'm Dr. Kristen West. Thank you for joining me for the Management and Treatment of Children with Complex Feeding Needs, a case study for the MedSLP Collective Summit today. My disclosures: I am a salaried employee of Penn West University here in Western Pennsylvania. I'm a contractor for the MedSLP Collective. My non-financial disclosures are I'm a volunteer for ASHA and Feeding Matters. A little about me: I'm an assistant professor and the assistant chairperson at Penn West University. I have my EDD from Slippery Rock University in Pennsylvania. My focus is on pediatric feeding and swallowing services, and also looking at implementation of services for children with complex medical needs in the public school setting. I do have my CCC SLP, and I've experience working as a pediatric SLP before coming into higher ed across the continuum of care. So NICU, PICU, CICU, early intervention, home-based services, outpatient, and I do still see clients in the clinic at the university. So learner objectives: after watching this presentation, you, the participant, will be able to identify airway comorbidities that negatively impact feeding and swallowing, describe interventions to transition infants and children from modified diets and liquids, and identify opportunities for interprofessional practice in the management and treatment of children with complex feeding needs. So this case study, we are going to review a case study that really had a complicated feeding diagnostic process, and really kind of go through what happened in this case study. This case study is based off of a real life client, but I did de-identify and change some of the details just so they couldn't be identified as we discussed this case. But this is a pretty common clinical presentation. We're going to discuss the case, discuss their management, discuss what was found through the clinical arc of care. And then at the end, we're going to go ahead and review evidence-based resources. What does the literature say? What do we know? How maybe could we have improved things in the care of this infant? And what kind of actionable items can we as treating speech language pathologists take away from this case as learning opportunities for growth in our clinical practice and even programmatic development for us where we are treating and seeing children? As we know, pediatric dysphagia is a problem, a clinical diagnosis that really crosses disciplines, right? We as pediatric speech language pathologists or as medical speech language pathologists are very likely to see children that have dysphagia. We are also very likely to see children who have pediatric feeding disorder, the new diagnosis that was published in 2019, a Gaudet et al. Article that really highlights that interdisciplinary impact or the multiple factors that can impact feeding and swallowing for infants. So if you're not familiar, the pediatric feeding disorder criteria looks at the medical domain, the nutritional domain, the feeding skill domain, and the psychosocial domain. And it talks about how each professional has their own role, right? We have the role in feeding skill, being oral sensory or oral feeding skill-based needs. But we really have to be aware of the other domains, the psychosocial domain. There's a lot of stress for families and caregiver burden that there comes along with having a child that either has a diagnosed feeding and swallowing need or is going through the diagnostic process to figure out what is causing the feeding problems for their infant. Some children who have maybe had a complicated feeding history can have anxiety, can have avoidance behaviors that would be in that psychosocial domain. That's going to impact their ability to develop feeding skills potentially. We also know that having feeding skill deficits can negatively impact nutrition, because if you can't get enough food and liquid in, then you don't have enough calories or energy to grow. If you don't take in oral intake safely, you may not be able to stay healthy, right? You may have pneumonia. You may have then developed a negative association with feeding. So we really know that pediatric dysphagia, and more broadly thinking about pediatric feeding disorder, that this is a clinical problem that really is going to cross discipline. So although I'm going to speak to it from a speech language pathologist perspective, we really have to keep in mind that the bar or the standard for high quality management and treatment of complex feeding and swallowing needs is best done in an interdisciplinary manner. So these children are typically going to need to be seen by pediatric otolaryngology, GI, pulmonology, also speech language pathologists, OT. There is a role in pediatrics, which is different than adults, for an occupational therapist to help support feeding and swallowing. You may even think about lactation consultants, immunologists, allergists. So really there's a myriad of providers and different factors that we have to consider when we are trying to get to the root of what is this child's feeding and swallowing need. And so there are a lot of trips to medical professionals along the way to land on the diagnosis for why. Why is there dysphagia? What is causing these feeding programs? Best practice, really, again, interdisciplinary holistic care, using that family as part of the team, being that true expert on their child. So I'm going to take you through this potential case study, like I said, and navigate the challenging diagnostic and institutional processes that can really impact a family's arc of treatment, but also talk about some areas that, what do we know? How can we improve quality of care? So first and foremost, let's just go over the case study. This is patient Stacy. They are a 4.5-month-old infant that was born vaginally with a normal vaginal delivery at 39 weeks and 1 day. So 40 weeks gestation being term rate. So we're at term infant. From a family perspective, they're the firstborn child of Emily and John living in a suburban area. So they do have, from a social determinants of health perspective, access to family, access to healthcare, a middle-class family. So we have, some positive indicators there for this family. Stacy's birth and developmental history are typical for her newborn to, about a 4.5-month-old child that was delivered full term, typical vaginal birth, no complications. She has easy access to medical care, but the concerns here is that really her family has identified that since birth, she has had feeding concerns and challenges. She had intermittent refusal to breast and bottle feed. Her family's choice has been to bottle feed her. That was their choice, but she has intermittently refused to feed. She has signs of discomfort during feeding. Her parents have reported to the pediatrician that she has squeaky breathing, squeaky sounds during eating, and things that they think are consistent with episodes of gastroesophageal reflux disease. And this is confirmed by the pediatrician. He's witnessed those in the office. And he said, yes, I see some red flags for GERD here. And, I do hear that squeaky noisiness with breathing, which makes me think we should make a referral to an ENT. So this family was referred to an ENT, but due to scheduling issues and high demand, they have an 8-week wait. So kind of while they were waiting before that scheduled ENT appointment, Stacy was at home and had a brief episode of apnea during feeding. So had, kind of was eating, was squeaking, was showing those typical signs of reflux and their typical feeding concerns that the parents had. And there was a brief period of cyanosis, like just some perioral cyanosis. We saw some loss of color and apnea. They resolved kind of quickly. The family called the pediatrician with concerns, and the pediatrician said, hey, I want you to take your child to the emergency department. So they did. They took the child to the emergency department. They didn't go via ambulance. It was, it was frightening and scary, but she returned to baseline pretty quickly. They had one of those outlet socks where they could check her pulse ox and everything was fine. So they went ahead and said, hey, let's take her to the hospital, via our car. When she went to the hospital, she did not go to the children's hospital. She went to the nearest hospital. And so in that ER, they did have pediatric providers. And at that emergency room, there was a diagnosis of BRUI, which is a brief resolving unexplained event, if you're not familiar with BRUI. So BRUI is a brief resolving unexplained event, which essentially means that this child had a brief event that resolved, very quickly. So they returned to baseline very quickly, and it was unexplained. They don't really know what caused it, but they're suspecting, based on what the physicians in the emergency department have told the family, that they think this is an episode that probably is related to her diagnosis of reflux, I mean. So they kept her overnight to observe her. They put her on a monitor. There were no more events when she was eating. She didn't see a speech language pathologist. She just was kind of monitored on the floors for an observation stay. And they discharged her home. They contacted GI because they said, we think this is reflux. And the GI said, okay, go ahead home. We'll squeeze her in early. We'll get her seen in 2 weeks. She still should keep the ENT appointment as well. And they put her on a cancellation list. So when she was seen at outpatient, it was recommended based on their concerns that she had reflux, based on her symptoms. Oh, she must have, had an episode where she had reflux. It came up from her stomach into her esophagus, into her pharynx, maybe entered her airway. And she aspirated reflux, which caused a protective airway response, which then caused that apnea. And so, based on that information that they had, they wanted her to transition. She was on thin formula. They wanted to transition her to an anti-reflux formula or an AR formula from that standard thin formula due to this diagnosis of GERD. And now that she had this BRUI event, that brief resolving unexplained event where she didn't breathe, they said, okay, let's do that. And let's also prescribe her a proton pump inhibitor. That is a little bit, debated by providers, whether or not that is helpful. But in this case, that was what the provider decided. And they said, okay, let's go ahead, ENT, still keep it on. We no cancellation, keep moving forward. So at home, after this GI appointment, they changed to an anti-reflux formula, hoping to help manage some of the reflux symptoms. They're waiting for the ENT follow-up. And after about 2 weeks of using these thickened anti-reflux feeds, or those AR feeds, and the PPI medication, the family kind of called the gastroenterologist back and they said, listen, we gave it some time, but these thickened feeds are worsening her stridor, that noisy breathing that we're hearing. And she's starting to refuse feeding now. Like, she was uncomfortable before, but we had ways to manage this discomfort. She might spit up or she might squeak, she might calm, we could give her a break, we could give her a pacifier, calm her down, she would go back. But now at this point, she's starting to refuse, and everything just sounds worse than it did before. And so the GI at this point said, okay, we need to get you in for a feeding evaluation. Let's go ahead and get you scheduled for an outpatient feeding evaluation with the speech language pathologist at the Children's Hospital. So luckily in this situation, they triaged these reports and this child was able to get in relatively quickly. At the outpatient feeding evaluation, the speech language pathologist saw this client, and it was noted that the mom was feeding Enfamil AR, so the anti-reflux formula, with the Dr. Brown's level 2 nipple. The SLP who evaluated the child made note that there was stridor, that stridor was impacting the ability of the infant to coordinate, suck, swallow, breathe. So they weren't able to suck, swallow, take a breath. They were really, sucking, swallowing, trying to take a breath, but there was stridor that was negatively impacting their ability to coordinate breathing and eating. This physician, or this speech language pathologist, after receiving the referral for the child from the physician, from the GI, tried multiple strategies. So tried pacing, so tried strict pacing, every 2 to 3 sucks, tilting the bottle, trying to give Stacy more time to coordinate her breathing and eating. But that didn't work. They tried putting her in elevated side lying, holding her more upright, both maybe as a way to either address maybe what might be reflux, give her more positioning, that would help her coordinate her breathing and eating, and it didn't improve. They tried to slow the rate down to a level 1 nipple with an AR formula. She appeared to be inefficient by the point that was trialed in an eval. When you do a lot of changes in an eval, sometimes you tire out the child. So, it's hard to say if it's a true inefficiency, or if it was just there was a lot going on and at the point it was trialed, it wasn't effective. But either way, it wasn't effective at that point. So the SLP said, well, we're thickening for reflux at this point. We don't know about this child's swallowing status, but when assessing dysphagia, and your report is that these thickened feeds are making the child's feeding worse. So let's go ahead and trial thin liquids with a level 1 Dr. Brown's and a preemie, and let's see if there's any difference. And really, there wasn't any change when we went back to thin liquids, tried a slower flow, tried positioning, pacing. Nothing was really showing great improvement. It was noted that Stacy sounded wet, gurgly, like when she would cry or fuss. They could hear concerns for aspiration throughout. So a swallow study was ordered. A VFSS was ordered. And the SLP said, I need a swallow study. I'm calling your ENT that you haven't even seen yet, but letting them know. I'm calling GI and saying, this is my findings, that I'm really concerned for aspiration, given your history of Stacey's history of having a period of apnea with feeding, having this clinical diagnosis of reflux. We need to get a swallow study. Everybody agreed. A referral was made. And so here's what happened. During the swallow study, Stacy was diagnosed with severe pharyngeal dysphagia. She had silent aspiration of IDSI level 0, 1, 2, and 3. She had a poor succal breathing coordination, delayed swallow initiation to the level of the piriform sinuses. She had consistent swallow penetrations on more than 70% of swallowing that essentially led to aspiration. It was very consistent. It wasn't like this one-off aspiration. It was consistent penetration that eventually led to aspiration due to succal breathing coordination that was noted. And really, when we also took a deeper look at this, what they saw was that sometimes she was coughing, which is not always expected. Some infants are silent aspirators, but when she coughed, it wasn't effective. Additionally, when this aspiration was noted, the pattern of aspiration did not look typical. It looked atypical, and it was really concerning for some laryngeal pathology anatomy concerns. And so at that point, there's concerns for laryngeal anatomy that is a variant, right? Something that's not typical or expected. The child was not able to consume anything safely without aspiration. They're highly symptomatic for feeding challenges. They're starting to refuse. I didn't put this in there, but you also have some concern for slowed weight gain. So they're starting to not be able to gain weight. We're starting to see these refusal, like I don't want to eat, that sucking reflux by 3.5 months has integrated. And so now we're seeing this baby refusing, likely due to some sort of pain or discomfort. And we have a documented aspiration. Now knowing in the history, she had this period of apnea, she definitely needs a further workup. So it was the team made a decision at this point, because of the severity of this dysphagia, because of the clinical course, the ARC here, they made the decision to directly admit Stacy to the hospital. Okay, the pediatrician, the ENT, the GI were all in agreement. ENT had said, I haven't even seen this child yet, but we need to see them absolutely. The quickest way to get this worked up is to go ahead and admit her to the children's hospital, and we will go ahead and place an NG, and we will make her MPO until we do a medical workup to figure out why she has such severe dysphagia. So really just highlighting the importance of our role as a speech language pathologist here, right? We are at this point really providing the information that helps those physicians rethink their original diagnoses of there's something more here than just reflux. So while Stacy was in the hospital during her inpatient admission, she underwent first and foremost an upper GI. And they did this using her NG tube, since she had been deemed unsafe to eat by mouth at this point due to aspiration. They were not going to perform this as an oral exam. So they did an upper GI using her NG. Everything on the upper GI was normal. She had a pressure esophagram because they were looking for a tracheoesophageal fistula, seeing is there something there going on, something, in the esophagus. It was normal. There was no anatomical concerns in the esophagus. So they did then recommend a triple scope with ENT, pulmonology, and GI. So A triple scope by definition is three scopes, three procedures done under sedation in the OR. The first scope is called a direct laryngoscopy and bronchoscopy. That's where our ENT is going to use a rigid endoscope to assess the structures and overall function of the larynx and the airway. And that's an ENT assessment. The second scope is a flexible bronchoscopy with a bronchoalveolar lavage, sometimes called a BAL. That's going to use that flexible endoscope to assess the structures and the health of the lower airway and lungs. So again, that's going to be our pulmonologist. And in both the direct laryngoscopy and bronchoscopy and the flexible bronchoscopy, we can also see what will happen is pictures will be taken and videos. And so that'll help them kind of image those structures. During that BAL, like you probably are aware, there's going to be that lavage of the lower airway with the saline solution, which is then suctioned out, and then those specimens are sent off to the lab to look for any sort of abnormal bacteria or growth that might require treatment. And then the third scope is an EGD, which is using that flexible endoscope to visualize the structures and the health of the esophagus, the stomach, and the small intestine by the GI. So this comprehensive sedated assessment of her upper lower airway and her digestive tract was performed. And as a result, what they saw was that ENT said she had mild laryngomalacia and tracheal malacia, mild. What they did find in her airway, though, was a significant amount of bubbling of secretions. So many bubbling secretions that they saw in the airway that typically tells you she's aspirating her secretions. So, that's a significant indicator of dysphagia. We also saw not me, but the physician team saw was structures that were consistent with a type 1 laryngeal cleft. And they also saw signs of reflex changes and irritation. So a laryngeal cleft is a congenital defect where there is communication between the larynx and the pharynx. And really what we are seeing is that, in neuroembryological development, the airway and the esophagus originate from a common tube called the foregut. So way back in interuterine development, there is a common tube called a foregut. In early and embryological development, the airway separates from the esophagus and forms what's called a tracheoesophageal septum. And so when this foregut is just kind of pinching off and making two, something goes awry or is aberrant or does not happen correctly. And it's really thought that this tracheoesophageal septum that is supposed to form and then help split off the airway from the esophagus, the septum is not thought to be completely developed in children who have laryngeal clefts, which then can create varying degrees of severity of communication between the airway and the esophagus. We also may see, and so this is another part of a diagnostic process when we think about this client, is that we do see sometimes that if a child has a laryngeal cleft, it can also be associated potentially with other midline diagnoses or defects, such as a tracheoesophageal fistula, a cleft lip and palate, or heart defects. So for our specific patient here, what we find is there's no cleft palate, there's no tracheoesophageal fistula. She was already worked up for that and confirmed again through this diagnostic process. And then she did go through a congenital heart disease screening, which was negative, just was seen by cardiology, just to make sure. And she had no history, no murmurs, nothing there. But that is something to be aware of for us as speech language pathologists. So what we see with a type 1 laryngeal cleft is it's more mild. It is one of the more mild forms. Sometimes you can have what's called a deep entorhytenoid notch, which is kind of a debated diagnosis for some, being more widely accepted now. But in Stacey's case, she was diagnosed with a type 1 laryngeal cleft, which means that there's that abnormal opening between the larynx and the esophagus, which the food is now passing through and ending up in her airway. She had the mildest form. And so what we really see is that there is this communication between the interytenoid muscles, but the cricoid cartilage is spared. This is typically defined as a gap between the larynx and the esophagus to the level of the true vocal folds. You can also have more severe clefts, type 2, 3, and 4 laryngeal clefts, but she was diagnosed with type 1. Just for some frame of reference, reported incidence of laryngeal cleft is about 1 in every 10,000, the 1 in every 20,000 right now in the literature. But the incidence in patients that also have dysphagia. So we think about Stacy, she had dysphagia. What is the incidence in dysphasic pediatric population? It can be as high as 7.2%, is what the literature is telling us. That's most recently from a study in 2021 by Wineski. And so, just for kind of a frame of reference here, she's diagnosed with laryngeal cleft, right? Sometimes and this was happening after a swallow study that had very significant dysphagia. It is possible for a child to have a laryngeal cleft and not immediately go to surgery, but she had such significant dysphagia that her medical team, took her to the ER and said, hey, or took her to the OR and said, hey, let's do this scope. And they made this diagnosis. So once this diagnosis was made, her team decided to go with surgical repair. And they decided to go with surgical repair because more conservative treatments weren't going to be available to her. Conservative treatments are things like, can we modify her diet? Can we thicken her liquids to address the dysphagia? If she had something safe to consume, we could continue that with, a little bit more dysphagia management protocol, treating her acid reflux, and also really seeing, if that helped improve her swallowing. In this case, she had already had anti-reflux medication and thickened feeds for reflux, and then had a swallow study where no modified diets were found to be safe. So she wasn't able to do this more conservative management of laryngeal cleft, which we might see in some other patients with the type 1 laryngeal cleft. We should just be aware that conservative treatment can vary in terms of its efficacy. Some people, some infants can have a laryngeal cleft, treat the reflux, have a modified diet, and then be able to kind of slowly transition off of that as they grow. And we'll see improvement. And then for some, it's not effective. So based on her type 1 laryngeal cleft, because more conservative management had been tried, even though we didn't know it was laryngeal cleft initially, they had tried GERD and GERD formula and PPI management. She had a swallow study where they couldn't recommend anything she couldn't eat. So now she has an NG tube. They're going to go ahead and put her in for surgery. So that was kind of the clinical decision-making there. They decided to do a suture repair. So you can sometimes have management of a laryngeal cleft where they are going to do a gel injection where the notch is, if it's a deep notch, or in a type 1 where there's a true cleft, they can inject a gel. But the ENT team decided in this case, we are going to do a surgical or suture repair. A suture repair is viewed sometimes as a more permanent solution, a more permanent repair. Sometimes the gel injections can wear off and wax and wane. Because of a significant amount of dysphagia that she had, it was felt by the ENT team that a suture repair was best for her. So she was fed via her NG tube post-operatively, had a repeat BFSS 24 hours post-op, and they continued to manage her reflux as well. And so once we had this surgical repair, they opted to repair her laryngeal cleft. Her Malaysia was mild, so they did not opt to do something like a supraglotoplasty. They felt that the laryngeal cleft was the bigger issue that was causing her dysphagia based on a review of the swallow study and seeing her, her scope findings. So that was the plan of care. They did order from speech language pathology a post-op swallow study. And what's found in this swallow study was she, with IDC 0, so thin liquids, 2 different flow rates, level 1 and preemie, Dr. Brown flow rate, And these flow rates, just for reference, are based off of the literature that we have coming out from Dr. Britt Pados's lab and published research about the flow rate of commercially available bottles. But so that's kind of how the structure is here. We're seeing aspiration. She is having penetration to the level of the vocal folds on a high percentage, more than half swallows, almost 70%. And then she has an ineffective cough with a level 1 nipple. With a preemie nipple, she had one smaller, what we would sometimes call trace amount of aspiration during the swallow. It was the first suck. And so they let her kind of take that bottle and that liquid a little bit longer to say, okay, well, it was the first suck. Sometimes there's a thought process that, is this really representative? But based on the fact that she had such deep, consistent penetration, she had had an aspiration with an ineffective cough with level 1, had trace aspiration, no cough with Dr. Brown's preemie, and then this consistent deep penetration, it was felt this wasn't a safe option for her, given how severe her dysphagia had been on the preoperative swallow study. So then they did IDSI level 1. She had some improvement in her swallow function noted. So she didn't have that delayed swallow initiation to the piriforms like we were seeing on IDSI 0 or that we were seeing on the pre-op swallow study. But she still had ongoing delayed swallow initiation, frequent penetrations that were not quite as deep. They were more intermittent. So some were very deep and some were shallow, but it still did not, it was so consistent that they still did not feel that this was the safest route. Her medical team really wanted to be quite conservative in her dysphagia management and in their tolerance of risk for aspiration, given what she had been through, given some concern for the fact that she was starting to refuse. There was some, emerging weight gain concerns for her. And so at this point, the guidance from the medical team was be more conservative. She's very newly post-op. We're just trying to see if there's a safe diet to get her started on, and then we can reassess the plan from here. I should note that the aspiration that was seen was in a more typical pattern. So it was no longer looking like, oh, there's, some laryngeal anatomy reason, like laryngeal cleft repair was sufficient. This was just more true dysphagia, which may be related to her more mild laryngomalacia. Although it should be noted, when she was post-op, she had significantly reduced stridor, looked much more comfortable during feeding, and it was just really mild, occasional, very intermittent, a stridor that was being heard. So really that laryngeal cleft repair seemed to be very effective in addressing the etiology or the reason for a lot of her feeding needs, but she was still having dysphagia. So what ended up being recommended was that she was going to be on IDSI level 2. With a Dr. Brown's level 3, the level 2, she wasn't very effective with. So because of this improved extraction, they were using a level 2 IDSI level and a Dr. Brown's level 3 because she was more efficient with her extraction level 3 than she was with level 2. And there's really no change in the penetration between the level 2 and level 3. She was just more efficient with the level 3 post-op. So they landed on this because of the request for conservative management, also thinking about the fact that they saw improved swallow function, less frequent penetrations. It was only 40% of swallows, and the depth of the penetration was less. So what they ended up doing at this time, the recommendation was they were using rice cereal. Thickening agents are something that are hotly debated in the management of pediatric feeding and swallowing. Gel mix versus Purothic once you're over age 1. Some institutions don't want to use rice cereal because of arsenic, and they'll use oat cereal. Some will use things like Simply Thicken a Term Infant or gel mix or some other brand thickeners, depending on a risk assessment for GI. So you may have questions about this. This was just institutional preference policy by the physicians, really discussing what they felt. There was a need for more consistency in her thickener. There's obviously some concerns with, using rice cereal long-term arsenic, consistency. There's a lot of research from Dr. Memory-Gosa on this. It's not an exact science. But to the point here, this was what they used at this point at that hospital. So this is what was recommended. So she went home on an IDSI level 2. Their recipe was rice cereal, 9 teaspoons per 6 ounces using a Dr. Brown's level 3. She also had seen purees via spoon on this swallow study, and there was no penetration or aspiration. By this point, it had been like a month since she had already been seen from that original referral where she was 4.5 months. It's almost been a month now at this point. So she's closer to, between 5 and 6 months. And so introducing spoon feedings was something that they wanted to assess on the swallow study to make sure that she, was safe and there was no other oral or pharyngeal phase dysphagia. She had been kind of exploring some taste of that before, just for fun and pleasure before she ended up in the hospital. But at this point, given her age, she is in that transitional feeder period where we're thinking about introducing complementary foods. And despite the fact that she has an airway anomaly, we want to, or did and has dysphagia, we want to limit her dysphagia's impact on her overall developmental trajectory. And so assessing and ensuring safety with purees was important. It also gave another way for us to, because remember, she's still NG tube fed, to really think about how can we work on doing a very child-directed or infant-led approach to cue-based feeding for the bottle, where she's had a pretty negative experience historically with feeding. And she was starting to show some signs of negative association with feeding and swallowing, or aversion. Some might call it aversion, but that learned response. And rightfully so, because she was aspirating and it felt uncomfortable for her. So thinking about that, we want to make sure we are giving her positive feeding opportunities that will follow that expected developmental trajectory if she's ready. She's a neurotypical infant that can sit up with support, hold her head up. She's showing interest in food. And so she's, leaning towards it, looking interested. And so this was assessed. Her first feeding was not in a swallow study, but because we don't really want their first exposures to a food to be in a swallow study. That's not ideal. But since she was interested in spoon feeding, had those prerequisite skills for it, she was assessed. And that also gave us another way to work on targeting her feeding skill development, another way to think about getting nutrition and hydration into her. As we look at, how we're going to wean this NG tube over time in the future, if she's not able to very quickly transition to getting it removed. And so what we really see here is, highlighting the importance of making sure in pediatrics too, just because they have dysphagia, we don't want to stunt their overall developmental growth as it comes to other feeding norms. And so we're balancing that. Let's teach this skill, this next developmentally appropriate feeding milestone for her, while still addressing her dysphagia with liquids. Just to kind of, recognize that post-op instrumental assessment, timing, coordination, management plans can vary institution to institution. And so if you have experience in this might be slightly different than your timeline, and you may have questions of, well, was this dysphagia related to, being 24 hours post-op? Would it have been different if we waited 48? There is variability there. But all in all, there was improvement in her swallowing pre-op to post-op once they did that surgical repair. And so what we really do kind of see from the research is that if a child has a type 1 laryngeal cleft, we do see after some interventions that we can see, statistically, some research tells us more than 50% of kids will have some degree of improvement after they've had an intervention for type 1 laryngeal cleft. Some will say that it's 60%. Some say it's maybe even as high as 75%. So it really kind of depends. One thing I think that probably impacts that, do we expect to see post-op improvement after a type 1 laryngeal cleft intervention, is the potential to have other airway and medical comorbidities. You know, an improvement does not necessarily mean that they're going to have expected swallowing after surgery. She had improvement, but she still was not able to take thin liquids at this time. And so just being aware that the more medical comorbidities a child may have, the more challenging it may be for them to show swallowing improvement. So if they have a neuromuscular condition, if they have, you know, developmental delay, you know, for some diagnosis or some diagnosis we're still looking to work up, some genetic condition potentially, that could negatively impact a more positive outcome as it relates to their feeding and swallowing post-operatively. If you compound it with something like congenital heart disease, cleft palate, again, something else to be considered. But all in all, from Stacy's perspective, she did show improvement. We were able to start spoon feeding. She was able to now start consuming thickened liquids. And so what we were really seeing whenever we saw her from this repeat swallow study was that she was more efficient. No suspicious aspiration pattern for laryngeal pathology was found, right? That cleft repair seemed to be patent or seem to improve her swallowing as it relates to an atypical aspiration pattern. She still had dysphagia, but the stridor and signs of symptoms on aspiration on the modified diet were gone. And so it was an effective intervention. She was discharged home on her modified diet, PONG, of taking about half and half by mouth, half NG tube on a bolus kind of schedule. And she was scheduled for an outpatient feeding visit 2 weeks after she left. The 2-week follow-up, she was consuming about 70% of her calories orally, a combination of that modified bottle feeding and also purees. Her parents reported, and it was confirmed by the outpatient visit, she had improved suck, swallow, breathe coordination. She was increasingly efficient with oral feeding on level 2 and Dr. Brown's level 2 IDSI and Dr. Brown's level 3 nipple. And so she was just really doing quite well. Then she was able to go to 1 month, 100% PO. They actually decreased her flow rate to a level 2 nipple. She was getting so much more stronger with her efficient extraction that they felt they could actually slow her down because they felt she was kind of gulping and just the flow rate was a little too fast. So they dropped her down a flow rate. No real like aspiration because there was just a parent preference and it was fine. They took her NG tube out 6 weeks post-op when she really just kind of was showing, and that was a medical decision by her team. There was improvement in suck, swallow, breathe coordination. She had improved stamina. Stridor was really eliminated. We didn't see it. She was gone. And they had done an ENT and office scope that said, we're not really seeing as much concern for airway edema, signs of reflux anymore. Reflux management seems to be going well. She's sitting up. She's taking purees. We don't hear as much. We don't hear any stridor and we don't see as many signs. She was spoon feeding twice a day as well. So at this point, we work towards just kind of doing cue-based feeding, modified diets, compensatory strategies to help improve her dysphagia, which was no longer thought to be related to the laryngeal cleft. She was able to transition off of the NG tube. And what we really see here now is that she was able to consume a full modified diet orally. But as we talk about in adults, and we also are really, driving this home in kids, we don't want to stop at just compensatory interventions. If we can continue to work on active improvement, right? We want to do active interventions so we can improve swallowing, just not compensate for the deficits. There had been a discussion about repeating a swallow study for her. Do we want to do a repeat VFSS to see what her swallowing looked like? When they did I didn't put this on the slide, but when they did an in-office follow-up at the aerodigestive clinic, and they didn't see any concerns for any more laryngeal laryngomalacia, there was no more stridor. They tried to do a quick fees on her, a fees in a younger child, 6, 7 old, not exactly always able to be the most effective depending on their participation and how upset they are. but a quick, couple sucks and swallows of thin liquids were tried, and there was no aspiration, despite the fact she was screaming and crying. And so the thought process was, she's pretty low risk. She's had a lot of imaging and workup, because they did do a complete workup on her just to make sure they weren't missing anything from a developmental standpoint. She was ruled out for cardiac conditions. They felt it was not, as a medical team, there was a discussion of providers of, might not be best for her to exposure to radiation for repeat swallow study. She's neurotypical, no other medical comorbidities. Her airway anomalies are addressed appropriately. The repair is holding, there's no other concern. She's pretty well managed. She's showing improvement in sucking strength, we're seeing continued development. And so it was decided, interdisciplinarily, a systematic thickener weaning would be something worth considering. So once that NG tube was removed, she had some of those follow-up visits. She was eating all by mouth. They said, okay, now we've removed an NG tube. We've eliminated one aspect of this, caregiver burden, which can impact her childcare and all those kind of things. She's now able to orally eat. Let's see if we can work on actively and systematically improving her swallowing and weaning her off of this thickener. And so, systematic thickener weaning is something that was published in the literature by Woltzer et al. In 2019. And so that approach was what was landed on by the care team, with the thought that if we see any concerns, we know what her red flags are for aspiration. We know how she presents, what she sounds like, it can be stridor. She sounds congested. She has this intermittent cough that we've, captured on a VFSS if she aspirates. We know what those signs and symptoms are. So let's go ahead and use those to guide us as we work on a systematic thickener wean. Because at this point, we're also thinking about, we're getting to the point where we want to work on a cup. We want to start working on a straw, and we can do that with a thickened liquid. But if we can wean her off of that on a bottle and then start offering those thinner liquids from a cup, that's going to help kind of bring her feeding and swallowing back on track for that expectation. And so that was really what was decided. And she had such a prolonged history that again, this is what was decided. So the NG tube was removed, and they did a thickener wean. It was according to the protocol that you see in the Woltzer et al. 2019 article, which really says every 2 weeks, you do a 10% reduction in thickness. So, her recipe was 9 tablespoons per 6 ounces. And so then that was reduced by 10%, which is essentially 1 teaspoon. So you're we did cut the amount of cereal and keep the amount of liquid same approach. So it was 9 ounces per 6 ounces, or 9 teaspoons per 6 ounces of formula was her thickener. Then we did, our first cut was 8 teaspoons per 6 ounces. We wait 2 weeks. Her caregiver was provided extensive education, but they were really good at understanding that on overt signs that she had before and more subtle signs that we might see, because she may have changed, developed, and grown. So talking about that. So we held that 8 teaspoons per 6 ounce steady for 2 weeks. There was no concerns. And then the family weaned again, right? So it said, okay, we went to 8 teaspoons. Now that one was fine. There's no concerns. You go to 7. 2 weeks later, you go to 6, 5, 4. 4 gets us, between 5 and 4 gets us to like half strength. Then we get to 3 tablespoons per 6, 2, 1, and then 0. While we did that, we dropped the flow rate as well. And essentially we're able to have her monitored. This is really, thinking about interprofessional practice. They were doing this at home. She was identified in this community being a high risk diagnosis qualifies you for early intervention. So she was able to get an SLP and EI who had a background in feeding and swallowing. So they monitored her wean. And then she came back every 6 months for a checkup, an outpatient feeding team follow-up at the hospital. And so she was able to kind of wean herself down to IDC 0, so thin liquids with Dr. Brown preemie nipple. And that's kind of where we went, just to be conservative. And then once she had held there for about 2 weeks, we went up to level 1 nipple, no respiratory concerns, no issues. transitioned to offering thin liquids from a cup. She was able to learn to drink out of a straw cup and an open cup, no issues. Her outpatient, or not her outpatient, her EI therapist did that in conjunction and collaboration with the outpatient hospital to just talk about timing and what that looked like. And she was really able to, kind of make that transition. There was no, follow-up ENT visits. There continued to be no respiratory concerns, no concerns regarding the repair for her. And so really, when we think about systematic thickener weaning, most kids, if they have trouble, they're going to have trouble within, 4 months of doing so, more likely to have trouble with systematic thickener weans or be unable to complete it and get down to thin liquids if they have neuromuscular conditions or other genetic comorbidity. She was very low risk statistically for not being successful. Another reason why this was picked. But just to kind of slowly step her down and think about motor learning principles, slowly drop her down bit by bit and get her acclimated to taking thin liquids. Also working again, improving her ability to take purees as she got closer to 9 months, soft solids, getting into meltables, transitioning to cup drinking, straw drinking. And then by 1, she was on a regular diet, an expected 1-year-old diet, soft foods, table foods cut up into small bite-sized pieces, drinking from a cup from a straw, and really did not need any feeding and swallowing intervention anymore. And so she was a very successful candidate for the management of her feeding and swallowing needs. But there is something for us to really think about when we think about her arc of care. Maybe, where could some identification potentially have happened sooner? Where was she potentially, can we use this as a modality or as a kind of way for us to consider how can we improve patient care? What is our role of SLPs in this interdisciplinary framework? And what are some evidence-based considerations for us? So, very successful case study, but let's kind of dissect it a little bit, talk about evidence-based practice or EBP considerations, some things we can learn from this case. So brief resolved unexplained events, BRUIs. They used to be called ALTs back in the day when I first started working in pediatric acute care. They were called ALTs, or apparent life-threatening events, which if you kind of think of the connotation of that word, it's kind of negative. It feels like a little bit like replacing blame. And apparent kind of means, well, we didn't see it, so did it really happen, right? So it's not really holistically descriptive enough. And so it's been changed to BRUI. And when we think about BRUI, it's brief resolving unexplained events. And we have some literature that already discusses, well, what do we know about BRUI? And how is BRUI related to dysphagia? As we know, and as we saw in Stacey's case, she was diagnosed with BRUI. Actually, not a diagnosis that really fit her because it wasn't a brief resolved unexplained event. She had apnea during feeding, and we did have a cause that could explain it. It was her laryngeal cleft, and she had laryngomalacia as well, right? She had airway anomalies that were causing her feeding challenges. In hindsight, perhaps institutionally, if there was not such a high demand and a high wait list for an ENT appointment, there had been some way to push for a more urgent follow-up. She may not have had this event that landed her in the ER. However, once she had it, potentially, hindsight is 2020, thinking about having an SLP as part of that initial assessment for a BRUI in that hospital system, because remember, that was a community hospital, wasn't the pediatric hospital, that could have improved the quality of her care when we think about process improvement. And so, thinking about what is our role in the management of BRUI, we are knowing that there are some children who may get a diagnosis of BRUI, but actually they have underlying dysphagia. So best practice is really for us to think about advocating for our role as a provider that has useful and relevant information and high quality skills that we can bring to the table to help in the differential diagnosis of BRUI. So again, kind of zooming out, Brewy, if you're not familiar, changed from ALTI. It really was changed from ALTI to clarify the brevity and the absence of a clear reason for an event to have occurred. Like I said, that actually wasn't the case with Stacy. There was a reason, it just wasn't identified. To have a brewery, you have to be under 1 year, and it has to last less than a minute. Usually it's 20 to 30 seconds. That's the understanding of the word brief. She was misdiagnosed as brewy because, again, we didn't have adequate ENT assessment for her. And to be brewy, the cause can't be explained. We did have a cause for her, so that was actually a misdiagnosis. Brewy, by definition, though, is going to have cyanosis or pallor, absent, decreased, or regular breathing, or a period of apnea. They can have hypertonia or hypotonia, even maybe appear to have some level of responsiveness that becomes more reduced. But then after the event, the infant returns to baseline or it resolves. So that's where the resolving piece of it comes in. What we know from the literature, okay, is that many infants remain symptomatic after a brewy hospitalization. So this case that we had with Stacy, where she was diagnosed with a brewy, they thought maybe it was reflux related. They sent her to ENT and it just continued to get worse. That's not uncommon. It's up to 2/3 of families. This is coming out of the research from Boston Children's Hospital, where they're really looking at, it was Dr. Duncan and her team, including Cara Larson at Boston Children's, where they really looked at brewy and said, well, is it really brief and resolved, right? Is there actually this one and doneness to this event, or are families still worried? From that study, they found, many of these infants are remaining symptomatic after their brewy hospitalization. Up to 2/3 of these families are still worried about their child, and their child continues to have symptoms, so they continue to be worried. So going back to that pediatric feeding disorder framework, like psychosocial caregiver burden, it's still present after a brewy. And then retrospective studies have revealed that 10 to 28% of patients, so these infants under 1 that have been diagnosed with a brewy, are potentially requiring some repeat hospital evaluation after brewy. Like they had a brewy, they kind of get sent home, they have to come back to the hospital if something else happened. So again, thinking about Stacy, she fits this mold. Interestingly enough, still talking about brewy, no studies have really shown that gastroesophageal reflux events or GERD events are the primary cause of brewy episodes, but it is the most frequent diagnosis or explanation given to families and other providers for why this brewy happened. So depending on where you look in the literature, about 1/2 of families, some studies will say it's up to a half of families are told, hey, your child's brewy is related to reflux or GERD. Let's go ahead and address that. However, for us, again, highlighting the importance of advocacy and our involvement in the care and initial assessment of brewy, dysphagia and aspiration, as we know, has identical symptoms and presentation to GERD. And so these children who are being told, oh, your child probably has reflux causing a brewy, may truly have dysphagia and aspiration, and there may be a medical etiology that's underlying this that we haven't diagnosed. So again, just highlighting how complicated it is, how brewy is not really always something to just brush off. But a lot of times we aren't getting looped into that care circle early on at the initial event of a brewy. We are getting pulled in to these follow-up visits like that are coming back, and they're like, well, I had this history of a brewy, and then, so something for us to advocate about. And thinking about process and procedures and order sets that we might want to put in our healthcare systems. Infant had a brewy, auto consult for speech, just like we would do in the NICU, born below X weeks. Okay, we're going to have an auto consult. Just some things to consider from Duncan et al.'s 2022's findings. All subjects that had brewy symptoms that ended up having documented aspiration did have silent aspiration. So we can't rely on that cough. And this really demonstrates why clinical feeding evaluations alone, why those alone aren't sensitive enough to definitively diagnose and treat aspiration and other related medical conditions. And so it's only really 50% sensitive for us to be able to pick up aspiration. So when you're thinking about advocating for our role in BRUI assessment, likely stopping at just a clinical feeding assessment is not enough. If we go back to Stacy's case, clinical evaluation, we saw red flags. So it was in that 50% piece where we saw, okay, there's enough going on here. Let's do a swallow study. But a clear clinical assessment of these children's feeding and swallowing is likely not enough. If they've had an event where they've had apnea, they've had, those red flags or those diagnostic criteria of BRUI, we likely should be considering a swallow study. Even if the concerns are mild, even if we don't see anything in a clinical assessment, we should really think about a swallow study, because we should be advocating for consults for these patients so they get earlier diagnoses, and we can really look to see, is this dysphagia? And if it's dysphagia, is there an underlying medical condition, something like a laryngeal cleft potentially, or laryngomalacia or something else that might actually explain these events so they don't remain unexplained in this kind of catch-all diagnosis. Just some information about systematic thickener weaning. Again, Walter et al.'s 2019 article is a great one. It's something to consider for your children that have dysphagia, that don't have other high frequency or high likelihood of developmental delay or neuromuscular challenges. They're highly likely, if they fall in that criteria like Stacy did, it's highly likely that this will be effective. It reduces the exposure to radiation. Again, we kind of went through what that looked like, but we know that if we use that stepwise, systematic, slow reduction, it's going to follow that motor learning principles that we all know help us to develop motor skills. And in kids, it's habilitative. We're not typically rehabilitating things. We are looking at learning. So we really need to think about that. It is evidence-based. There is a very consistent protocol. I highly recommend that you look at this article if you're looking for more treatment resources. So as we finalize here and wrap up, some key takeaways: interprofessional collaboration is key. We know that these kids who have laryngeal clefts may have more complicated medical history. We know children that are diagnosed with BRUI may have underlying conditions such as dysphagia or airway anomalies, which might require more assessment. We have to consider the medical etiologies for things like BRUI or aspiration or dysphagia, and really considering that earlier identification, diagnostic, and treatment lessens the long-term impact. And really, we should advocate for our space at the table because we are experts in this domain. Once again, I just want to thank you to the MedSLP Collective and all of you for attending today. And here are my resources. I hope to see you inside the collective.
Thank you so much, Kristen, for that presentation. And thank you for responding to questions throughout the presentation. If anyone has any final questions, please pop them in the chat and Kristen can respond to those. And we are going to move on to our next presentation. Okay, our next presentation is by George Barnes. He did pre-record this, but he will be available for a quick live Q&A at the end.
Hi everyone, my name is George Barnes, and today I'm going to be doing a short talk on medically complex decision-making. Thank you to the MedSLP Collective for hosting, and thank you to all of you for attending. So this is not going to be a talk about perfecting the way that we make decisions. Of course, I make mistakes, you make mistakes, everyone makes mistakes from time to time. It's not a matter of eliminating mistakes from happening completely, but minimizing some of the errors that result from common mistakes that occur frequently. So we'll be developing a decision-making process. We'll be looking at some key components of what makes a high-quality decision, and we'll ultimately be improving our decisions to do what it is that we seek to do. improve outcomes for our patients. My disclosures. And so first, I want everyone to close their eyes and picture that they unfortunately had to go to the hospital. They had a headache, they were feeling a little bit dizzy. All of a sudden, the next thing they know, they're not allowed to eat or drink for hours. In fact, it's been almost 12 hours since they've had anything to eat or drink. And then all of a sudden, someone comes into the room and asks them to drink water and eat a cracker as fast as they can. Whole bunch of water and a whole cracker. Well, it's been 12 hours since you've had anything to eat or drink. Your mouth is dry, so you clear your throat a little bit when you take a drink of water. And the cracker is so dry, it crumbles in your mouth and it makes you cough a bit. Well, the next thing you know, the food you're receiving comes in mounds on the plate and everything looks the same. You have to spoon feed everything, including your liquids, because they're too thick to drink. Now, no one explains to you exactly why this has occurred, why you need this food or liquid, and nobody has given you the choice or the option. No one has even talked through what other options might be available to you. And so over time, you get hungrier and hungrier, thirstier and thirstier, and weaker and weaker. Now, unfortunately, this is a reality for a lot of the patients that we see, which has motivated me to try to figure out a better way to approach our decision making. And this is not going to be a talk about finger pointing or blaming or taking anything personally. We've gotten to a place in the field where we should feel comfortable reflecting on the way that we do things in order to improve how we practice moving forward. And so that is what this talk is about. On the agenda, we're going to talk about recognizing common mistakes when they do occur. We're going to see how to minimize some of those errors, and then I'll demonstrate using some of those techniques in a case study. And a little bit about myself before we get started. What's motivated me to focus so much on clinical decision-making is that I tend to see patients with a lot of risk for aspiration pneumonia, risk for choking in the critical illness recovery and acute care hospital environments. I also run a mobile fees company. I write, I mentor, I teach, but where I spend most of my time is in that critically ill facility where I'm seeing patients that are on trachs and vents, and so every decision we make is high stakes. And that has forced me to look inward to how I'm making decisions, what information I'm using, who I'm bringing into that decision-making process. And ultimately, how do I improve that process to improve the outcomes? So it's been years of studying my own decisions and trying to improve upon them. I started a decision journal a few years back, and I've been tracking all of the decisions that I make. I study the variables that I utilize when I'm making a decision, and I go back after an outcome has become apparent on that decision a couple of weeks later and figure out how I can change my process to improve the outcomes that I see with my patients. And I'm going to share with you some of what I've learned in that process. The stakes are high when we make decisions. Like all healthcare professionals, we are making decisions about people's lives. And so when we make a decision, it could change their trajectory for the better or for the worse. And biases, cognitive biases, and heuristics exist in healthcare. Whether we want to admit it or not, we tend to make a lot of errors based on these sort of harmful patterns of thinking. They're sort of mental shortcuts that we use on a daily basis. And they're not always harmful. In fact, they can be good when we need to make those gut instinctual reactive decisions in the moment. But unfortunately, when we have to be thoughtful, take a step back, and be as cognizant as possible, that immediate knee-jerk reaction can lead us astray. And so biases do exist in healthcare. In fact, A study done in 2016 did a large review of all sorts of medical decisions and found that cognitive biases existed in 77% of the decisions studied. 77%, that's most of the decisions that we're making are somehow tainted with some cognitive bias. And that's when errors occur. And medical errors account for close to 100,000 deaths. That's like 300 commercial airplanes going down each year. So the stakes are high, and the decisions we make have outcomes that matter. And I'm going to tell a quick story before we get started on the rest of this presentation. So when we are talking about things that we've done in the past, I want us to focus on how, when we look toward the future, how we can look back at what we're doing now and think, oh my goodness, how was I doing what I was doing back then? What was I thinking? And that's called progress when we're doing that. And it's an inevitable part of growth. And so we can't see and look at what we're doing today as how our practice is going to be permanently. Because if you think 100 or 200 years ago, we were doing some wild things in medical practice. We were engaging in things like bloodletting, where we would actually bleed patients out because we thought it would rid them of their disease. We would burn holes in their body, starve patients. And of course, at this point, many years later, we have realized, after utilizing evidence-based practice, that these are not evidence-based practices. And so what this story tells us is that we need to first learn so that we can know better, and then over time, we practice with the current evidence to get better and better at achieving the outcomes we're trying to achieve. So we want to be looking backwards at what we do today, say in 20 years, and think, oh gosh, I cannot believe how much we were modifying diets and thickening liquids when all we had to be doing was this, this, and this, because all this research now points in the other direction. So first, recognizing errors. How effective are we at making predictions? Well, Philip Tetlock and Daniel Gardner did a study in 2016, and they found that after studying a whole bunch of expert decision makers, that we are no better at forecasting how those decisions are going to turn out than a dart throwing monkey. That is to say, we're not very good at all at determining how well our decisions are going to turn into what we want them to turn into. So another study told us that when we're 90% sure that we're right about something, when we're so confident we're absolutely positive, turns out we're actually wrong half the time. So how confident we are is not a good indicator of how well our decision is going to do. Yes, it does happen from time to time. But when does it happen? Turns out we make mistakes most often during unfamiliar circumstances or when short on time and feeling rushed, which begs the question, when was the last time you were not short on time and feeling rushed at work? And for us who work in per diem, where we bounce from facility to facility and we're constantly seeing new kinds of patients and new environments with new teammates, we want to be extra careful because those unfamiliar circumstances can certainly make us more prone to error. Biases and heuristics. Can't correct a mistake you don't know you make. So let's see how we make mistakes first. Turns out we're actually even biased about our own biases. A study was looked at where they asked individuals, first they told them what a bias and heuristic is, and they educated them, and they realized, okay, yes, these harmful cognitive patterns exist. We tend to make mistakes this way and that way. I understand that. And I even understand that most people fall victim to these sort of cognitive patterns. But me, myself, I do not fall victim to them. Everyone else, yes, but me, I'm immune. And so this tells you how strong these biases and heuristics are, because not only do we fall victim to them, but we don't even realize they're happening. And we'll talk about some of them so you have an example of what they look like. Here's 4 that we're going to start with, and we're going to start with availability heuristic. Have you ever thought about maybe going to the beach or going to the mall, and then all of a sudden you read about a shark attack, or you were watching Jaws on the television? Or maybe you were deciding between 2 places to go on vacation, whether you were going to drive to the closest beach or you were going to sail overseas, take a flight overseas, and maybe go to a different country. Turns out, when you, and if that happens, say you read that a plane had crashed in the newspaper. Now, how likely are you, if you say were watching Jaws on TV or you read about a shark attack, how likely are you to go to the beach? Well, not very likely. You probably want to go to the mall. And how likely are you going to want to take a plane if you just read about a plane crash? Even though these are 2 highly unlikely incidents from, that actually occur in the real world, when it's available in our minds, it becomes real and it becomes hard to forget. So memorable events have a greater impact on our decisions than unmemorable events. And in dysphagia management, we might think, how important is an aspiration event? Well, with a patient that's completely functional, maybe not very important. Say if you cough every now and then when you take a drink. But if that patient who is functional is coughing on liquids and you see them and everyone around you is in the room seeing it, it becomes a very memorable event. It becomes something available in your mind, highly prevalent when you're making decisions. Anchoring. When we hang on to the first piece of information we get. Picture yourself walking into a room and you're about to do an assessment, and the first thing you see is the patient coughing. You go, okay, this patient has some trouble. But the rest of the test goes perfectly fine. Compare that with the patient that you start out with, looks perfect, and then at the very end they cough. Who are we going to be more conservative with? Who are we more likely to make a conservative recommendation with? Probably that person that coughed in the beginning, because we're anchoring onto that information, even though the test itself was identical, 1 cough in each. Confirmation bias, what is called the mother of all biases. It's when we pay attention only to the results that support our theories. So this might be a patient that comes into the hospital with right lower lobe pneumonia. Now all of a sudden a light goes off in your head and you think, oh, dysphagia, aspiration pneumonia, right lower lobe, it's got to be what it is. And so you're going to be looking for, and you're eventually going to find some difficulty, whether it's there or not. You're going to look for that dysphagia and you're going to find it, whether it's there or not. Base rate neglect. A base rate is an individual characteristic that can tell us a lot about a patient based on what the research says. So, for example, we may have the base rate of aspiration pneumonia within the whole of all pneumonias. So say a patient comes into the hospital and we want to know what the likeliness that this patient has actually acquired an aspiration pneumonia when they've been diagnosed with a general community acquired pneumonia. And that base rate is actually between 5 and 15%. So it's relatively low. And that tells us that it basically gives us something to anchor to. And we can adjust that percentage based on other individual characteristics, but that one characteristic can tell us a lot in terms of the type of risk that we're looking at. And if we don't look at the research, if we don't understand the base rate, our judgment can be thrown off incredibly. And one example of this is taking a person and trying to figure out if that person is more likely to be a librarian or a salesperson. Now, you get individual characteristics about that person, and you are not aware of the statistics, what the research tells us. And these individual characteristics are that the person wears glasses, they love to read books, and They spend pretty much all day looking up their next book that they want to read. So you might think, oh, of course, this person's more likely to be a librarian. But this, of course, neglects the base rate, which is that there are way more salespeople than librarians. And so no matter what the individual characteristics are, by statistics, given the statistics, that person is more likely to be a salesperson. So yes, we're all susceptible to biases and heuristics. These are harmful patterns of thinking, often harmful, I will say. At times they can be extremely beneficial, but in certain circumstances, they can lead us astray, especially when we have to sort out lots of different variables and lots of different risk factors when we're looking at a patient with medical complexity. Now, recognizing these patterns is the first step towards ultimately conquering them. We can and will address these biases and heuristics through a decision-making process that I'm going to introduce later on. Okay, so minimizing errors. First, let's think about thinking, right? There are two main ways that we think when we encounter a problem. We have system one, which is what Daniel Kahneman has called fast thinking. It's automatic, it's reflexive, and it's great for things like when we're driving and a deer runs in front of our car and we have to move out of the way very quickly. In fact, it's almost like we're not thinking at all. Our instincts come into play. Now, compare that with system two. System two thinking is deliberate. It's calculated. It takes time. We have to sort out variables and bring in team members to help us fill in the gaps. They're two very different processes. And when it comes to dysphagia management, system two is almost always going to be the preferred system. But system one can be beneficial as well, especially if we have a ton of experience seeing the same kinds of patients, getting immediate and timely feedback, and we're in the same kind of environment with the same team members. And we are able to stay humble. We can get and utilize the feedback in a timely manner and change the way that we make decisions based on the outcomes that we're seeing that are occurring with those decisions. So over time, we're able to adjust the way that we make decisions based on the feedback that we get. Then we can start to rely on our instincts a bit more, our intuition. And so I'm going to introduce a decision-making process. There is nothing unique about this process. This is something that I've taken from a number of sources, but you can already see that it mimics the scientific method a bit. What's important is not using this specific process, which you're more than welcome to. What's important is using a decision-making process so that we can make the process transparent for ourselves and so that we can go back to it after we receive feedback on our decisions and make notes and change things so that we know we're looking at the most important variables every single time. Identifying the problem. This is when we gather data, not just any data, it's got to be high quality data that we get from the chart, from interviews, from the clinical swallow evaluation, preferably with a standardized measurement. Then we make a hypothesis based on other patients that we've seen with a similar status. What do we think is going to happen here? What's our projection? And then we test it. We test the likelihood of them having difficulty or having a certain level of dysphagia or aspiration pneumonia with preferably an instrumental study or a standardized measure at bedside. And then we make a diagnosis. And we need to figure out how that diagnosis is meaningful for the patient, right? Because we're going to say maybe mild, moderate, or severe dysphagia. And then we make a decision based off of that diagnosis. So it's the discussion component that becomes very important here, because once we make that diagnosis, we need to figure out what it means for the patient so that we can make a decision that's meaningful for them. Because there's a difference between a good decision and an accurate decision. An accurate decision might be reducing the risk, for example, of aspiration, whereas a good decision is going to, say, reduce the risk of aspiration pneumonia. or improve quality of life, or get the patient discharged as soon as possible if that's their goal, or getting them home as soon as possible, or achieving them to have the ability to eat and drink their favorite food. Whatever is most important to that patient, if our decision gets them closer to that point, we have made a good decision. And then we identify the factors. And so I've separated the most important factors for most of the decisions that I make in terms of dysphagia management in the critical illness recovery hospital into these patient risk factors that we see on the left and the patient factors that we see on the right. Now, we can, of course, put in any type of risk factor or patient factor that we feel is relevant in the moment. That's not important. What's important is that we identify them and we assess them. And the way that I've done this, which is, of course, just one way, it's very subjective, there's nothing formal about this, but the way that I've done it is I have basically provided numerical values to each one of these factors. And you can see the ones on the left are ranked from 1 to 5, and the right from 1 to 10. And what this does is it balances out each one of these categories so that we can ultimately see how liberal or conservative we're going to be based on the factors that are presented to us. Because if, say, the patient factors are through the roof, the patient preferences, goals, and expectations, and their risk tolerance are 10 out of 10. So we have 20 out of 20 on the right side. No matter how high the risk is on the left, if we were to take more of a conservative approach and maybe start modifying diets and consistencies against the will of the patient, that would be devastating to the patient, no matter how much risk it reduces. And so this sort of gives us a little bit of a point on a spectrum to determine how conservative or liberal we might choose to be with a given patient and with a given decision. Similarly, when we're generating an approach, we want to talk about costs and benefits, right? And so this is one way that I have found to be helpful to actually numerically weigh those costs and benefits, to quantify them. And so you can see the costs are very specific to the setting that I work in, as are the benefits. You can change these however you want, but I do think quantifying them in this informal way does help us get a better puts our finger on exactly what we're looking at and takes those biases and heuristics a bit out of the equation as we start to quantify things and try to make them as objective as possible, even though this is not a perfectly objective task. And then we think about alternatives. Now, people typically get stuck on one intervention or one way to evaluate a patient. But remember, there can be any endless combinations of potential options, which is why it's so important to list them out while we're making a decision. Not only to see and choose from in the moment, but also to come back to later if, say, we're going to be adjusting our plan of care, which is actually the next step. But if you have trouble with this step, you can often think to yourself, what if my number one intervention, say, thickening liquids, was not available? We couldn't do it, wasn't allowed. Then what would I do? And thinking of two or three other options in the moment can be extremely helpful to fall back on if, say, your first approach is ineffective or is not possible for whatever reason. And then, of course, we adjust. We're going to be changing our course based on how the information changes in the future. Remember, patients are dynamic. They're constantly changing from day to day and even within each day. So we want to try, inevitably fail, because we're not going to be perfect on the first try, and then we analyze, adjust, and try again. And we can think of this like sailing a ship. When you sail a ship, if you were going to stay in the same direction the entire time and not adjust at all, you would end up 1,000 miles away from where you're trying to go. But instead, you adjust over time, right? You change direction, you change your course based on the wind, the weather, and that's how you get to your destination, not by staying on track the entire time, but making small adjustments. And that brings me to the concept of bullets before cannonballs. So excuse the sort of violent analogy here, but it's a good way to think about how we make decisions when the stakes are high. What we want to do is basically ooch forward with our decisions. We don't want to start with everything that we have and be as aggressive as possible off the bat, especially if the risk is high. Instead, what we want to do is we want to move forward slowly. And so we can use the analogy of bullets before cannonballs. Picture yourself hundreds of years ago in a pirate ship, and you have an enemy ship that's coming towards you. Now, you only have enough gunpowder for one cannonball. Do you shoot off the cannonball and hope for the best? Probably not, right? You'd first send out a bullet. See where the trajectory is on that bullet. You send out the first one and it's 50 feet over their head. Okay, that was way off. Let's lower it down a little bit. Next one was 10 feet. All right, we're getting closer. Next one, bullseye. And then you use the gunpowder that you have left to shoot off the cannonball. So what we're doing here is ooching forward. And what this might look like for a patient who, say, is NPO on a feeding tube is not starting with a regular thin liquid diet, no matter how confident we are, but starting with bullets before cannonballs, maybe starting with ice chips, then a pleasure diet, then a puree diet, and so on and so forth until we ooch forward to a regular diet, all the while monitoring and making changes as necessary. Be objective. In God we trust, all others bring data. Now, the more that we quantify things, the more likely we are to try to rid ourselves of some of those cognitive biases and heuristics. And when we talk about dysphagia management, we have to realize that it's all about managing a probability. You might ask yourself, what are the chances that this patient is going to eat safely, choke, aspirate, so on and so forth? And the way that we find this is by using statistics, the base rates, finding out what the research tells us about the patient. So we don't want to test someone unless we know their norms first. And a good example of this is, say, that we are seeing someone that is 90 years old and has presbyophagia. Now, we may not realize this if we haven't done our research and understand that the likeliness of airway penetration is quite high with patients with laryngeal penetration. Excuse me. And so if we did a modified barium swallow study on someone, we notice persistent penetration, we may be more likely to take a conservative measure and not realize that this is a completely functional and normal status for someone who is 90 years old. And so that base rate is incredibly helpful, but without it, we can be led astray. And so once we get that base rate, we can adjust based off of that. So in the example of the patient that comes into the hospital with a pneumonia, and we say, okay, what's the likeliness that this is aspiration pneumonia? Again, go back to the base rate. It's between 5 and 15% likely. That just tells us one specific statistic based on the research that we know. But we can adjust that number based on other individual characteristics. Say if the patient had a history of a stroke, or if they've had a history of aspiration pneumonia, then we start to inch that percentage up and up. But at least it provides us with a starting point. Using scales and measurable tests can be another great way to get ourselves out of our heads and away from cognitive biases and heuristics. So the more that we use that we can measure, the better. And you don't know what you don't know, but you can consider it. And so there are unknown unknowns that are often should be at least taken into account. And the way that I do this in my practice is I basically make a prediction that a patient is going to, for example, get aspiration pneumonia. And I'll put that prediction into a range. And what that does is a couple of things. Number one, it helps me realize that I don't know for sure what is going to happen. Number two, it gives me a starting point to work off of that will tell me if the risk is relatively high or relatively low. And then I can come up with management strategies to try to lower that risk as much as possible. And of course, all of these using statistics and numerical values and quantification and all these scales and measurements might lead us to believe that the field of speech pathology should be a robotic practice, and we should just punch in a bunch of numbers into a computer and get out what the most effective decision is. And of course, that would be missing one of the most important aspects of what we do as humans when it comes to making decisions. And that is the ability to empathize, to understand what's most important to the patient. The only way to do that is to use the human skills that have evolved over hundreds of thousands of years, and to be a human being, to empathize, to understand, and to get on the same emotional wavelength as that patient. If we can't get on that wavelength, then we have no chance of making a good decision for them. Okay, teamwork. Now, picture a bunch of team members blindfolded, and they're all touching different parts of an elephant trying to figure out what it is, but nobody is talking to each other. Now, one person grabs the trunk and they say, oh, it's a hose. Another person grabs the tail and says, this is definitely a rope, can't be anything else. And the last person grabs the leg and says, oh, it's a tree trunk, of course. Now, no one's talking to each other, so they're thinking these are entirely different things. But if they spoke to each other and provided their information to others, they can see the whole picture. And that is what working with a team is all about. And there's two ways of approaching decisions with teams. One is confirmatory thought, and the other is exploratory thought. Now, confirmatory thought is when we essentially come into a decision that we have to make, and we say, hey, I want to do this. I think this is the right choice. I'm 100% sure that this is what we're going to do and this is going to work. Are you on board? And they'll say, oh yeah, sure, that sounds good. But an exploratory mindset is much different. It is when we, of course, explore, and we might come to that same person and say, hey, I'm concerned about this patient. What do you think is going on? Assuming they're familiar with the case and they're familiar with the variables. And that way we can ask questions, we can remain curious, and we can explore based on someone else's perspective and use that to fill in the gaps in our own understanding. So we want to get people not only to talk to and work through these issues, but to disagree with us, so that we're not doing the same things over and over with the same patients. We want multiple perspectives. The more, the better in most cases. There was a study done on the effectiveness of utilizing in Who Wants to Be a Millionaire, asking the audience and phoning a friend. And so asking the audience, obviously, we're using the aggregate of a number of independent insights and expertise. Whereas phoning a friend, you're just using one. When we ask the audience, we're actually about 90% likely of getting the right answer. Whereas when you phone a friend, you're only about 60% likely. So huge gap there. And finally, studying our mistakes. Coming back to decisions after we've made them and seeing that something went astray is a great opportunity to come together as a team and figure out what happened. What did we miss? What might we do differently next time? This is an interesting research study that found out that the value of team discussions is 6 times the value of gathering and analyzing information. And so it's not to say that our swallow studies and our clinical swallow evaluations provide no value at all. It's just to say that those exams alone provide very little compared to taking the information we get from those exams, bringing it to the interdisciplinary team, including the patient and family, and making use of it. How is it meaningful to the patient? How does it inform our judgment when it comes to making a decision for what's best for the patient? And we want to understand the reasoning behind an approach, why we're doing a certain something. So if someone challenges us and asks why, and we can't come up with a basic direct answer, that might be a sign that we have to go back to the drawing board, either do some more testing or analyze the results that we already have and understand what it means for the patient. And of course, doing and getting involved in an in-depth discussion about that data sometimes is the best way to bring that reasoning to light or to find out that your reasoning is flawed. A decision journal is what I started talking about in the beginning. And it's essentially jotting down a decision that happens in as you're making it in real time. So you might say that using an Excel spreadsheet, you might have your patient information, remaining HIPAA compliant, of course, and then in the row and then in all the columns, you have all of the most important variables that you're looking at. So OHAT score, PAS score, so on and so forth. And then you know that you've used all of this information to make a decision. And then you have that decision in one of the columns, and whether it's a certain diet that you put the patient on, certain diet consistency, whether it is a certain intervention that you've utilized, whatever it is, you track it down. And then you come back to that decision a couple of weeks later when the outcome has become apparent. How did the patient do? Did they continue to do well? Did they develop aspiration pneumonia? Did something happen? Did something change? And if it was a negative result, we can go back to that decision and figure out what happened. What was I thinking in the moment? I was looking at this variable, all these variables, but was I focusing on this? How did I completely miss this? And that helps you improve over time. So what a decision journal does is it helps you, number one, avoid hindsight and confirmation bias. We're laying out all the reasons for our decision ahead of time so that we can't come back afterwards and say, oh, I knew that was going to happen all along. Because oftentimes we'll flip a coin, and this will be like flipping a coin and saying, heads, I'm right, tails, I'm not wrong. And so we manipulate whatever happened in our heads to make it seem like whatever we did was the best thing that we could have done. And maybe that's true, and maybe it's not, but a decision journal forces us to be honest about it. Also, the process of doing a decision journal helps us uncover some unknown unknowns. It helps us identify some of those near misses, some of that information that we wouldn't have thought about otherwise. And that alone can be worth its weight in gold, because just the process of going through the variables, studying the way that we're making decisions, being metacognitive about this helps us avoid some of those biases and heuristics that we all too often fall victim to. And of course, we're learning as we go here. We're studying our own reasoning. We're changing the way that we make decisions to improve upon them over time. Does a bad result always mean we've made a bad decision? Of course not. And the vice versa is true as well. A good result doesn't always mean we've made a good decision. There are lots of complexities that happen when we are treating a patient and managing risk factors. There may be a patient that we've made a decision with that ended up in an adverse outcome, and that could have happened inevitably, whether we made that recommendation or not, or it could have been the cause of it. What's the point here is that we cannot point our finger directly at ourselves. There are lots of different variables flying around, which is why doing this process is so important, because it brings some of these variables to light. And after the outcome has become apparent, we don't blame ourselves, but maybe we can blame the process. And we can look at that process and say, hey, I didn't consider this, which ended up being really important. Maybe I'll incorporate this into my decision algorithm going forward, so that for every single patient going forward, I'm always paying attention to this, because this tends to be a really important factor. Okay, now we're going to do a case study that talks about some of these approaches. Okay, Derek, 67-year-old male, respiratory failure, COPD exacerbation. He had ARDS and a cardiac arrest, had some complications, eventually got pneumonia, and was intubated for 11 days and had a trach vent placed. He had an extensive history, including CVA. Okay, initial assessments. He's on full support via the vent on day 1. Glasgow Coma Scale is within normal limits. His oral health assessment tool, 0. And on day 2, he's on trach collar. His blood oxygen saturation level is a little bit low, but he tolerates the speaking valve for an hour. We don't push him just to be sure. And then the next day, he actually has a bit of a dip. Only tolerates the speaking valve for about 5 minutes, and he drops down to the high 70s with his blood oxygen saturation level. They do an ABG to make sure everything's okay, and it's within normal range. On day 4, he does great. He's tolerating the speaking valve now for 3 hours and up to 95% blood oxygen saturation level. So we're already getting a sense that Derek is a little bit unstable. He's medically complex, and we're not really sure what we're going to get from day to day. So the first thing we do is we look at the base rates. We want to know what the likeliness is of something occurring if we were to assess. Okay, so what's the likeliness of Derek having dysphagia based on what we know? Well, he was intubated, had an 11-day intubation, which is definitely extended. And the research tells us that dysphagia is about 50% likely. Okay, and how about his trach status? What does that tell us about his base rate? Well, his base rate of the base rate of silently aspirating with a trach is 81%. Okay, so we anchor onto that information, and then we adjust based on other information that we get. This is a chart that can inform us what the likeliness is of Derek developing aspiration pneumonia. We have 3 categories: the likeliness of aspirating, being able to clear out that aspiration, and being able to fight off an aspiration that cannot be cleared out. It's aspiration, clearance, and immune response. And what's important here is acknowledging that Derek has risk factors in all 3 categories. And you need risk factors in all 3 categories to have an elevated risk, which he does. Okay, now we start asking questions. What questions are we trying to answer here? Touch base with the team, and we want to know, is he stable enough for a swallow evaluation? Should we move forward? And the team feels like, yes, he is. We need to keep an eye on him, but we do want to move forward with eating and drinking, given his cognitive status, his motivation, and his willingness to move forward. How should we evaluate the swallowing? That's the question, and that's going to fall on us. Do we want to go straight to an instrumental study, or do we want to do a clinical swallow assessment at bedside? How is he trending medically? Well, he's sort of having these ups and downs, but does as a whole appears to be getting better. Can he maintain adequate blood oxygen saturation? That is yet to be seen. He is having these episodes where he dips, so we're going to have to keep an eye on that. And what are the risks involved with PO intake at this time? They are high, right? We looked at that risk chart, and we're seeing risk in every single category. So we come up with a hypothesis. We're thinking moderate to severe dysphagia with high risk of dysphagia-related aspiration pneumonia. And so how are we going to test here? We do a cranial nerve assessment, seems within normal limits, but we're going to save PO trials for a FEES. And the best way to determine that is through an algorithm. This is one that I have developed that helps me with these tough decisions, determine what's best. And so when should I recommend an instrumental study? Are there concerns of dysphagia? Yep. High risk? Yep. Clinical swallow evaluation with high suspicion of dysphagia? Yep, just based on his trach status alone and his long intubation time. Does the dysphagia impact his condition? Yes, he's NPO with a feeding tube. And so we move forward with a swallow study. Another way of looking at this is, what should I recommend at bedside? This is another algorithm that I created. And as you can see, one of the first options is if the patient has a trach or vent, they're automatically high risk, a swallow study when possible. So that makes that decision a bit easier. So we do a FEES. He has moderate edema. His mastication is functional. Yale residue scale was moderate in the vallecula, mild in the piriform sinuses. Murray secretion scale of a 3, that's secretions in the airway, in the laryngeal vestibule. and a penetration aspiration score of 5. Timely closure, but minimally incomplete, probably secondary to incomplete epiglottic retroflexion. Dysphagia outcome and severity scale of a 3, moderate dysphagia. Okay, so we can see the study here. Look at it briefly. You can see the swelling there at the epiglottic folds. You can see the pooling at the posterior commissure. We tried most consistencies here: puree, nectar, ice chips, thin liquid, and puree. I don't think we tried solids on the first one. And the swelling and the incomplete propulsion does cause a bit of a risk of aspiration, as you can see there. I won't bore you with the whole thing, but just so you get a sense. And so here's our summary. We have incomplete airway closure, increased secretions, moderate pharyngeal residue, deep penetration, but he does have an improvement with these compensatory strategies. And so let's lay out his weaknesses and his strengths here. We have decreased base of tongue retraction, posterior pharyngeal wall stripping wave, cricopharyngeal segment opening, and incomplete epiglottic retroflexion. Possibly decreased hyolaryngeal elevation excursion and decreased sensation with a weak cough. His strengths are that he's motivated. He's able to follow directions, and he has great support from his wife. And he has improved clearance and protection with the compensatory strategies we mentioned. Okay, so you might pause the video here and think what you would do with this information. What kind of recommendation would you make? Then you can compare it to what I did. I started with ice chips, just a small amount with the speaking valve and the strategies as we noted, and then to monitor closely, of course, promoting oral care and the exercises of effortful swallows and EMST. And now we're going to go through all of our processes. So our whole decision-making process here. So the problem is a moderate pharyngeal dysphagia, increased risk of decline. We're identifying our factors, we're quantifying them numerically and seeing that the risk factors inch out just a bit over the patient factors. And so we're going to be a little bit more on the conservative side, which is why we went forward just with ice chips, which the benefits highly outweigh the costs. And then we come up with alternatives just in case we need to fall back on them or change them in the moment. And I'm frozen here for a second. And then we adjust based on new information as needed. We come up with a bunch of different outcomes that are possible and our expectations. This is when we make a projection. We measure the uncertainty and say that we're thinking there's a 20% chance that he is going to develop an aspiration pneumonia based on other patients of similar status that we've seen before, and altering that based on his current presentation right now. Okay, and so here are some management strategies that we can use to reduce that risk as much as possible. And we repeat the fees a few days later. And we're seeing significant improvement from a moderate now to a mild laryngeal edema. No change in the Yale residue scale or the Murray secretion scale. PAS score now of 2, that's transient penetration. And his DOS score has improved a notch, now to mild to moderate range. And you can see the improvement here visually. You can see the swelling has come down. There's a bit less in terms of that posterior commissure residue. He's able to clear that out. And whatever the penetration is that kind of lands in there, I think we can see it a bit here. Sorry, it's a bit foggy. I probably already cleared it out, but he gets a little bit of trace penetration down to the vocal folds and then clears that out eventually. So in summary, he's now with improved airway closure, decreased bolus propulsion still, increased secretions, and now with moderate pharyngeal residue and trace deep transient penetration. Of course, the alternating solids and liquids and eliciting multiple swallows is decreasing the residue and the penetration. And the weaknesses now are similar to the last assessment, but with less edema and possible improvement in hyolaryngeal elevation excursion. He has minimal improvement in his sensation and cough, and the strengths remain the same. So again, what would you do with this information? You can pause the video and try to answer for yourself. And I've decided to move him forward, but all the while thinking about bullets before cannonballs, and a pleasure diet is what we start with so that we can monitor closely. Now going back to our problem, now with a mild oropharyngeal dysphagia. Here are our factors. We're now moving closer to a heavier, the patient factors being a bit heavier, and so we're going to be a little bit more liberal, try to move him forward. The benefits significantly outweigh the costs of advancing the diet. Here are our alternatives, our outcome range, and our expectations are now decreasing. 50% uncertainty, 50% likeliness of an adverse reaction. And then we adjust. And unfortunately, a couple of days later, he does have increased CO2, change in mentation. He was impulsively eating and ended up aspirating what we think was a bit of puree, pudding. So we adjust based on this information. Going back to the problem, now he has hypercapnic respiratory failure. He returns to the vent. Our factors now are going to be heavily weighed on the risk side. So we're going to be as conservative as possible. Costs are going to heavily outweigh the benefits. And so we make them strict NPO. Our uncertainty is growing. We think about alternatives, outcome range, but then a few days later again, he's liberated. We now do capping trials and his ABG stays normal. So you can see we're adjusting based on how the patient is changing. Eventually, he continues to improve, and we continue to do bullets before cannonballs, slowly advancing from pleasure puree to full trays to a regular diet. He weans from the peg and continues to need vent at night to relieve the CO2 from building up. And so we learned that, taking the long road, using objective information, and looking at the decision that we made to start with the pleasure diet and seeing that he declined. Could we have just been unlucky when that happened? Sure. We had not taken into account the fact that his mentation would have declined so much and he impulsively would have been eating and drinking. And so would I have done anything differently knowing what I know now? Yes, and I do. When patients first come off of the vent now, they're always required to have close supervision while they're eating and drinking out of a concern that the CO2 may build up and they may be a little bit more unstable than I think they are as I'm doing a clinical swallow eval or a FEES. And so getting that direct supervision, tracking their cognition closely, and consistently looking at the CO2 to make sure it's not building up is something I do regularly when patients are first coming off the vent. So big takeaways here. Biases and heuristics may significantly impact the quality of our decisions. There are effective ways we can address these limitations, improve decisions, and improve outcomes for our patients. And using decision guidelines and quantifiable measurements is extremely valuable when we have to look at all these very constantly changing factors and variables and when there's a high amount of medical complexity. And outcomes improve when we utilize a team approach with multiple insights. A clinician can only be judged by the quality of the decisions they make. Better decisions, better outcomes. That's my presentation. I'm looking forward to answering some of your questions. Thank you so much to the MedSLP Collective, and thank you so much to all of you. I'll talk to you soon.
Hey, George.
Hey, how's it going? Can you hear me okay?
I can.
Can you see me?
I can.
Perfect. How's everyone doing?
Pretty good. So we do have some questions that have come in. Not sure if you saw some of them yet.
Yes, I did.
Okay.
Yeah. So I don't know. Can I share my screen by any chance?
You can.
Okay. What do we have like only 5 minutes, right?
Yeah, we're gonna try and keep it to 5 minutes if we can.
Okay. So I just wanted to show everyone that I know there was one question about the decision journal, and it's difficult to talk about it without showing a visual of what that is. So I'm just going to pull that up. It's loading right now. taking longer than I thought it would. So while that loads, let me get to another question. So should I just read through? Does that work?
Yeah, or if you want, do you want me to pull some?
Yeah, if you see anything that looks interesting.
Yeah. All right. Can you monitor on, can you expand on monitoring of ABGs and CO2?
Yes, that is, it's a very basic part of an arterial blood gas, which is a blood test that is done to get the CO2 levels and the oxygen levels. That's way more accurate than taking an SpO2, a blood oxygen saturation level. And it's frequently done when patients are either approaching decannulation or if they have some sort of change in respiratory status. So it's sort of part of a normal panel that the pulmonologist would look at. It's not an unusual recommendation. And it tells us a lot in terms of, what we can't see with our eyes. So we can see if a patient's declining, if they're improving, and you can make clinical recommendations based off of that information. Otherwise, you'd really have no idea if the patient's retaining CO2 other than them becoming a little bit lethargic. Sometimes they get confused, but sometimes you don't have any symptoms at all. And I have this up now. So
Perfect.
let me just, before we run out of time. Okay. You guys see my screen?
Yep.
So this is my decision journal. I have a patient column and then all of the patient information in HIPAA compliant patient information. And then in each row, in each column, we have all of these different variables that I have found to be important in examining the risk of aspiration pneumonia. And you can include any kind of variables that would be relevant to something that you're looking at, but I'm asking the question, what's the likeliness of this patient having some sort of adverse reaction to PO intake? So you can see I have age, neurostatus, penetration aspiration score, cough, GCS, OHAT, what their respiratory status is, secretions, family support, and then I make a projection based on what I know about this individual and based on what I know about all of the patients that I typically see in this environment, the base rate, so to speak. And then I put down a date, and usually 2 weeks later, I review it, and then I come up with the outcome and what I learned about it. And you can see here, I kind of have been analyzing how often an adverse reaction occurs. And so I have 47 cases that I've evaluated and I've reviewed. And that leaves us at 10.6% of these patients that I'm seeing are developing some sort of what appears to be aspiration pneumonia from, usually within 2 weeks after starting PO intake. So I hope that clears it up a little bit.
One question that came through is, when you document, do you refer to this within your documentation or include like any quantifications of risk benefit, costs, patient goals, etc.?
I do, yes, I do talk about costs and benefits, risks, risks and benefits. Specifically, I try to detail the conversations I have with the interdisciplinary team, the patient, the family members as much as I can. I don't include anything about the decision journal. This is, I won't even call it research. It's more just a log of what I see and something that helps me personally. It may turn into research one day, but it's nothing that I would include in a formal documentation.
Got it. Do you, in your formal documentation, do you ever like add literature or citations?
I used to. I don't anymore. Certainly, I think that's preference. I think it does not hurt to put in. I don't know how helpful it is. I think that some other members of the interdisciplinary team might see it and sort of get overwhelmed by it and get kind of confused as to what it means and how it connects to the current case. So I'm sure that there's an effective way to do it. And I know, and I have heard of clinicians doing it, and I myself have done it before. But I feel like what suffices is to put down what the conversation was, what your rationale is, what information you're working off of, preferably an instrumental study or some kind of standardized measurement that has given you the reason for making the judgment that you're making.
For this particular case study, what was the primary source of nutrition until he resumed PO?
Peg tube.
All right. I think that's all the time we have, and I think we caught most of the questions. I'm not sure if you have time to hang around and see if any more pop in.
Yeah, for sure.
Awesome. Thank you so much.
Of course. Thank you.
All right, everyone, we are going to move into our longer break before coming back and starting. We're going to probably start about 5 minutes late, and we will jump into our next presentation in 30 minutes.
Please view important safety information, including indications and usage, at the end of this video. Meet Janie. She's a speech-language pathologist, and it's her first day at Excellence Medical Center. She's excited to be part of a top-tier institution and eager to help her first patient. As she prepares to do her first modified barium swallowing study, Janie's surprised to learn they don't use the standardized Veribar barium sulfate products. At the weekly staff meeting, Janie brings up her concerns about doing MBS studies without Veribar. She learns that her colleagues know about Veribar and thought it would be nice to have, but feel they're okay with how they do things now. Janie responds, "This is not a nice to have, it is a need to have." She goes on to explain that Veribar is the only line of contrast agents approved by the FDA for MBS studies. It was developed in conjunction with doctors Jerry Logeman and Joanne Robbins, who recognized the need for standardized viscosities. The staff insist that they all mix the same recipes and therefore are already standardized. Janie points out it's impossible to be standardized when you're mixing and modifying contrast agents that are not developed or formulated for the MBSS. It is also much more likely to result in human error. Janie asks, how many have had patients who have undergone repeat exams? Janie insists that as SLPs, our job is to ensure the exams are standardized and reproducible across the continuum of care. She continues by discussing problems with the GI barium products, most of which are designed to coat, unlike Veribar. Coating can be mistaken for residue and lead to potential false positives. After making her case, Janie asked her colleagues if they would be willing to try Veribar. When her colleagues agreed to try Veribar, Janie contacted Bracco to consult with a clinical specialist. After a trial, everyone agrees that the Veribar products should be implemented. However, they disagree on which Veribar products they prefer. Janie refocuses the staff on the science and reminds them that evidence, not opinion, should guide clinical decision-making. The staff expresses concerns that radiology won't allow the full line, and they begin to discuss which product they could forego if they needed to compromise. Janie responds, "We should not compromise when it comes to patient care. I will be happy to talk with radiology and present the literature." The next day, as Janie meets with the radiology administrator, she discusses the importance of using standardized materials and how it relates to patient safety, professional communication, and protection from liability. She also explains how the Veribar line is different from other GI barium sulfate products and how it meets the needs of the MBS studies. The administrator is impressed when he learns that only Veribar is FDA approved specifically for MBS studies and offers benefits beyond improved efficiency. From that day on, the only product line at the Excellence Medical Center used for modified barium swallow studies was Veribar. For more information on the Veribar family of products or to learn about our sampling program, email us at veribar@diag.bracco.com. Provide your name, location, and phone number, and the appropriate sales specialist will contact you. Please view important safety information, including indications and usage, at the end of this video. Meet Dave. Dave is getting ready for his annual trip to the Outer Banks of North Carolina for a weekend of fishing and fun. It's a tradition that Dave and his fraternity brothers have been doing for 25 years. Dave looks forward to this trip every year, catching up with friends, fishing, and eating. For him, it's a time to relax. But this year, he almost didn't go. You see, 6 months ago, Dave had a stroke. In the hospital, while taking his meds, he began to cough. His nurse made a note of it, and Dave was referred to a speech-language pathologist for potential stroke-related swallowing issues. Meet Sandy, Dave's first speech-language pathologist. Due to concerns about Dave's ability to swallow, Sandy recommends a modified barium swallow study, or an MBS study. Sandy has been conducting MBS studies for years, so preparing the different contrasts is nearly automatic for her. First, Sandy prepares the thin liquid. She pours about 3 ounces of liquid EasyPake into a cup. But EasyPake is a little bit thick. It pours more like a nectar than a thin liquid. So she adds about 3 ounces of water to thin it down. Perfect. Sandy's happy with her thin liquid mix. Next, she prepares the nectar thick liquid. Looks about right, she thinks to herself. Now Sandy is preparing a honey thick liquid. Sandy's done this countless times and quickly eyeballs the right amount of thickener. Next is the puree. Sandy mixes easy paste with pudding, the way she's accustomed. Finally, Sandy prepares the solid by spreading some easy paste onto a cookie. Sandy is confident with her work. The nectar thick liquid wasn't exactly to her liking, but she quickly dismisses any doubts and begins the test. She hands Dave the thin liquid and instructs him to take a small sip to begin. After the test, Sandy meets with Dave to discuss the results. She tells him about the upcoming therapy. When she lets him know about food restrictions and modifications, it really hits home. After 4 weeks of therapy at the rehab hospital, Dave is on his way to take a second MBS study. Meet Kim. Kim is Dave's current SLP and has been working with him at the rehab hospital. They're both excited with his progress over the past 4 weeks, and Dave is hopeful he can return to a normal diet. He wants to enjoy his trip to the Outer Banks, and this includes cooking and eating all the fish they catch. Kim has prepared more MBS trays than she can remember and has always done it the same way. Kim wonders if this is really a reproducible assessment. As Kim reviews the results with Dave, neither one can believe it. How could it appear that Dave's condition hasn't improved compared with Sandy's test? Later that day, Kim remembers a conversation with a colleague about Veribar, the only standardized contrast approved for MBS studies. Kim contacts Bracco for information about Veribar and requests samples. The Bracco dysphagia specialist explains that not all barium products are alike and schedules an online education session to explain the science. After receiving the samples and retesting Dave, Kim finds that the results are consistent with her initial expectations. Dave is both relieved and excited because he really has improved. He's also excited about going to the Outer Banks and enjoying his regular meals the way he's accustomed to.
Veribar barium sulfate. Veribar thin liquid barium sulfate for oral suspension. Veribar thin honey barium sulfate oral suspension. Veribar nectar barium sulfate oral suspension. Veribar honey barium sulfate oral suspension. Veribar pudding barium sulfate oral paste. Indications and usage. Veribar thin honey barium sulfate oral suspension, Veribar nectar barium sulfate oral suspension, and Veribar thin liquid barium sulfate for oral suspension are indicated for use in modified barium swallow examinations to evaluate the oral and pharyngeal function and morphology in adult and pediatric patients. Veribar honey barium sulfate oral suspension and Veribar pudding barium sulfate oral paste are indicated for use in modified barium swallow examinations to evaluate the oral and pharyngeal function and morphology in adult and pediatric patients 6 months of age and older. Important safety information. For oral administration, this product should not be used in patients with known or suspected perforation of the GI tract, known obstruction of the GI tract, high risk of aspiration, or hypersensitivity to barium sulfate products. Rarely, severe allergic reactions of anaphylactoid nature have been reported following administration of barium sulfate contrast agents. Aspiration may occur during the modified barium swallow examination. Monitor the patient for aspiration. Please consult full prescribing information for Veribar products. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Veribar is manufactured by EZM Canada Inc. for EZM Inc., a subsidiary of Bracco Diagnostics Inc., Monroe Township, New Jersey 08831. Veribar is a registered trademark of EZM Inc.
Please view important safety information, including indications and usage, at the end of this video. Meet Janie. She's a speech-language pathologist, and it's her first day at Excellence Medical Center. She's excited to be part of a top-tier institution and eager to help her first patient. As she prepares to do her first modified barium swallowing study, Janie's surprised to learn they don't use the standardized Veribar barium sulfate products. At the weekly staff meeting, Janie brings up her concerns about doing MBS studies without Veribar. She learns that her colleagues know about Veribar and thought it would be nice to have, but feel they're okay with how they do things now. Janie responds, "This is not a nice to have, it is a need to have." She goes on to explain that Veribar is the only line of contrast agents approved by the FDA for MBS studies. It was developed in conjunction with doctors Jerry Logeman and Joanne Robbins, who recognized the need for standardized viscosities. The staff insist that they all mix the same recipes and therefore are already standardized. Janie points out it's impossible to be standardized when you're mixing and modifying contrast agents that are not developed or formulated for the MBSS. It is also much more likely to result in human error. Janie asks, how many have had patients who've undergone repeat exams? Janie insists that as SLPs, our job is to ensure the exams are standardized and reproducible across the continuum of care. She continues by discussing problems with the GI barium products, most of which are designed to coat. Unlike Veribar, coating can be mistaken for residue and lead to potential false positives. After making her case, Janie asked her colleagues if they would be willing to try Veribar. When her colleagues agreed to try Veribar, Janie contacted Bracco to consult with a clinical specialist. After a trial, everyone agrees that the Veribar products should be implemented. However, they disagree on which Veribar products they prefer. Janie refocuses the staff on the science and reminds them that evidence, not opinion, should guide clinical decision-making. The staff expresses concerns that radiology won't allow the full line, and they begin to discuss which product they could forego if they needed to compromise. Janie responds, "We should not compromise when it comes to patient care. I will be happy to talk with radiology and present the literature." The next day, as Janie meets with the radiology administrator, she discusses the importance of using standardized materials and how it relates to patient safety, professional communication, and protection from liability. She also explains how the Veribar line is different from other GI barium sulfate products and how it meets the needs of the MBS studies. The administrator is impressed when he learns that only Veribar is FDA approved specifically for MBS studies and offers benefits beyond improved efficiency. From that day on, the only product line at the Excellence Medical Center used for modified barium swallow studies was Veribar. For more information on the Veribar family of products or to learn about our sampling program, email us at veribar@diag.bracco.com. Provide your name, location, and phone number, and the appropriate sales specialist will contact you. Please view important safety information, including indications and usage, at the end of this video. Meet Dave. Dave is getting ready for his annual trip to the Outer Banks of North Carolina for a weekend of fishing and fun. It's a tradition that Dave and his fraternity brothers have been doing for 25 years. Dave looks forward to this trip every year, catching up with friends, fishing, and eating. For him, it's a time to relax. But this year, he almost didn't go. You see, 6 months ago, Dave had a stroke. In the hospital, while taking his meds, he began to cough. His nurse made a note of it, and Dave was referred to a speech-language pathologist for potential stroke-related swallowing issues. Meet Sandy, Dave's first speech-language pathologist. Due to concerns about Dave's ability to swallow, Sandy recommends a modified barium swallow study, or an MBS study. Sandy has been conducting MBS studies for years, so preparing the different contrasts is nearly automatic for her. First, Sandy prepares the thin liquid. She pours about 3 ounces of liquid EasyPake into a cup. But EasyPake is a little bit thick. It pours more like a nectar than a thin liquid. So she adds about 3 ounces of water to thin it down. perfect. Sandy's happy with her thin liquid mix. Next, she prepares the nectar thick liquid. Looks about right, she thinks to herself. Now Sandy is preparing a honey thick liquid. Sandy's done this countless times and quickly eyeballs the right amount of thickener. Next is the puree. Sandy mixes easy paste with pudding, the way she's accustomed. Finally, Sandy prepares the solid by spreading some easy paste onto a cookie. Sandy is confident with her work. The nectar thick liquid wasn't exactly to her liking, but she quickly dismisses any doubts and begins the test. She hands Dave the thin liquid and instructs him to take a small sip to begin. After the test, Sandy meets with Dave to discuss the results. She tells him about the upcoming therapy. When she lets him know about food restrictions and modifications, it really hits home. After 4 weeks of therapy at the rehab hospital, Dave is on his way to take a second MBS study. Meet Kim. Kim is Dave's current SLP and has been working with him at the rehab hospital. They are both excited with his progress over the past 4 weeks, and Dave is hopeful he can return to a normal diet. He wants to enjoy his trip to the Outer Banks, and this includes cooking and eating all the fish they catch. Kim has prepared more MBS trays than she can remember and has always done it the same way. Kim wonders if this is really a reproducible assessment. As Kim reviews the results with Dave, neither one can believe it. How could it appear that Dave's condition hasn't improved compared with Sandy's test? Later that day, Kim remembers a conversation with a colleague about Veribar, the only standardized contrast approved for MBS studies. Kim contacts Bracco for information about Veribar and requests samples. The Bracco dysphagia specialist explains that not all barium products are alike and schedules an online education session to explain the science. After receiving the samples and retesting Dave, Kim finds that the results are consistent with her initial expectations. Dave is both relieved and excited because he really has improved. He's also excited about going to the Outer Banks and enjoying his regular meals the way he's accustomed to.
Veribar barium sulfate. Veribar thin liquid barium sulfate for oral suspension. Veribar thin honey barium sulfate oral suspension. Veribar nectar barium sulfate oral suspension. Veribar honey barium sulfate oral suspension. Veribar pudding barium sulfate oral paste. Indications and usage. Veribar thin honey barium sulfate oral suspension, Veribar nectar barium sulfate oral suspension, and Veribar thin liquid barium sulfate for oral suspension are indicated for use in modified barium swallow examinations to evaluate the oral and pharyngeal function and morphology in adult and pediatric patients. Veribar honey barium sulfate oral suspension and Veribar pudding barium sulfate oral paste are indicated for use in modified barium swallow examinations to evaluate the oral and pharyngeal function and morphology in adult and pediatric patients 6 months of age and older. Important safety information. For oral administration, this product should not be used in patients with known or suspected perforation of the GI tract, known obstruction of the GI tract, high risk of aspiration, or hypersensitivity to barium sulfate products. Rarely, severe allergic reactions of anaphylactoid nature have been reported following administration of barium sulfate contrast agents. Aspiration may occur during the modified barium swallow examination. Monitor the patient for aspiration. Please consult full prescribing information for Veribar products. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Veribar is manufactured by EZM Canada Inc. for EZM Inc., a subsidiary of Bracco Diagnostics Inc., Monroe Township, New Jersey 08831. Veribar is a registered trademark of EZM Inc.
Welcome back, everyone. I would love to introduce our next presenter, Brett McCardle.
Hey, thanks so much. Can you hear me okay?
Yep.
Okay, perfect. I'm gonna go ahead and share my screen and the sound. And go to slideshow. All right. So, hey everyone, thank you so much for coming. My name is Brett McCardle, and today we have crunched the numbers, acalculia, and aphasia. So to begin with, a little bit about me here. I'm an SLP and the owner of a private practice called Archways Aphasia Rehabilitation Services, which primarily serves people with aphasia. I'm also a mentor for the MedSLP Collective, and I provide mentorship in the areas of aphasia, apraxia, and primary progressive aphasia. I am a big proponent of the life participation approach to aphasia and love getting to make my therapy immediately functional and relevant for my clients. And I hope that this presentation gives you some ideas on how we can take theoretical models and evidence-based techniques and apply them in a way that makes our therapy worthwhile and meaningful, and really helps our clients get back to participating in and enjoying the life activities that they want to do. I also wanted to highlight a couple of different professional memberships that I'm a part of that you might consider joining as well. So both Aphasia Access and the Academy of Neurologic Communication Disorders and Sciences are fantastic organizations that offer tons of resources for clinicians who work with aphasia. So you might consider checking these out if you're interested. For my disclosure statements, I am receiving an honoraria from MedSLP Collective for this presentation. And again, I'm the owner of my private practice called Archways, and I've also done some consultative work with Tactus Therapy in the past, and I'll be providing links to some of their resources later in this presentation. And for my non-financial relationships, again, I'm a member of these two professional organizations that I just highlighted, Aphasia Access and ANCDS. So here's a general outline of what we'll be reviewing in this presentation. We'll start by talking about what acalculia is and the different symptoms that may be seen, as well as talk about different acalculia subtypes that have been identified in the research literature. We'll then go over different assessment tools and resources that you can use as part of your evaluation, along with different treatment approaches you might consider using with your clients. We'll then talk about how you can incorporate a life participation approach to acalculia management and make your treatment sessions really functional and meaningful for your clients. For the learning objectives, after watching this presentation, you'll be able to identify at least 2 assessment approaches for acalculia, identify at least 2 treatment approaches, and describe how a life participation approach can be used in acalculia management. In terms of the sources used, everything in this presentation is up to date as of April of 2024, and any therapy ideas and treatment suggestions were created by me using the evidence presented here, along with clinical experience and expertise. So with that being said, let's dive in and talk about what acalculia is. So acalculia is an acquired neurological disorder that can cause impairments in any of the 3 subdomains of the numerical system, and that includes number processing, calculation, and problem solving. This is different from developmental dyscalculia, in which a person experiences significant difficulty in the ability to normally develop numerical skills. Acalculia is typically the result of focal or diffuse brain lesions of different etiologies like stroke or head injury, and spontaneous recovery is possible within the first few months of onset, but it can be a chronic condition that has a significant impact on daily functioning and quality of life. So what are some hallmark symptoms of acalculia? Every person with acalculia will have their own unique set of strengths and weaknesses, but general symptoms seen across the disorder can include difficulties estimating and understanding numbers, having impaired knowledge of mathematical facts, having trouble performing calculations. One really interesting one is that there might be different performance depending on the numerical format used. So there may be drastically different performance between using Arabic numerals, spoken number words, or written number words. And there might also be specific deficits or specific preservations in terms of mathematical signs and operations like plus, minus, and multiplication. I also want to highlight a video here from a woman named Rebecca, who's been journaling her stroke recovery on her channel, My Disordered Brain on YouTube. And she has great videos on the impact that acalculia has on her ability to do everyday things like follow a recipe or write down numbers. So I'd really recommend checking out her YouTube channel to kind of see a real life example of the psychosocial impact that acalculia can have. I also want to say too that this presentation is primarily focused on acalculia and aphasia, but there have been specific error patterns and relative weaknesses observed in other neurological conditions like ALS, Alzheimer's, and primary progressive aphasia. And for these other conditions, the work from Cappelletti and Palmieri is going to be really helpful resources. So let's dive into some of the impacts that acalculia can have on overall quality of life. Unfortunately, acalculia management is an often overlooked area of clinical care, and it's estimated that acalculia impacts between 30 to 60% of stroke survivors. And this is comparable to aphasia, which impacts about a third of stroke survivors. Now, there's a lot of support relatively for aphasia, but why not acalculia? And the answer to this is likely multifactorial, with the first factor being that there's a pretty sparse evidence base for assessment and treatment purposes, and there just isn't as much work that's been done when compared to the aphasia literature. Another factor that may be impacting this is the potential social stigma that comes with math. It's been reported in the research literature that reporting difficulty with math is more acceptable than reporting difficulty with reading. So there may not be as pressing of an urge to address this issue compared to other issues following a neurological event. There's also a generally low level of numeracy skills in the general public, and this includes highly educated individuals and healthcare professionals. So again, this may lead to other areas being more highly prioritized. So looking at the chat right now, let me see if I need to readjust myself. Casey, how do my slides look to you?
I can see the slides, fine, they're big, and then you're in the right-hand corner. And I can
Okay.
see you as well.
All right, so it looks like things are all good for the most part. All right, so going on, people with chronic acalculia experience significant negative impacts on their ability to function in daily life. And it can make it difficult to complete daily life activities like telling the time, communicating details about events, or reading figures on documents. And what's really interesting is that some researchers actually suggest that having poor numeracy skills is even more debilitating than having poor literacy skills. But regardless of this, acalculia can lead to a negative impact on quality of life with reduced autonomy. Now, there's a really great recent qualitative study from Ben and colleagues that focuses on the psychosocial and emotional impact of acalculia. And I wanted to share some quotes from participants in this study. A lot of participants report feelings of vulnerability, shame, and frustration, with one participant here retelling a story about feeling ashamed at a restaurant for trying to pay for his girlfriend's meal, but having trouble figuring out how much he needed to pay, which then led to an embarrassing moment for him with the waiter. A lot of other participants in the study talked about the lack of professional awareness and services that are available for acalculia management, with these two quotes at the bottom here highlighting that the professionals they were seeing for therapy, like SLPs and OTs, had no training in acalculia and weren't able to provide any meaningful intervention or referrals to other professionals for help with this issue. Now, acalculia symptoms are commonly seen in aphasia, and because of this, it's worthwhile to briefly touch on the relationship between math and language. Now, numerical knowledge and processing is largely independent of other types of knowledge in the brain, like language and memory. And several studies do suggest that there's a dissociation between aphasia and acalculia. In fact, Roser and colleagues reported a case of severe aphasia who answered simple addition, subtraction, and multiplication problems correctly, and even performed multi-digit operations without any issues. Some neuroimaging studies also suggest that there are distinct non-linguistic cortical regions for mathematical knowledge, and I'll talk more about the neurobiology of math soon in some upcoming slides. But that being said, language and math may share cognitive resources depending on the task, and we see this is especially true in math tasks that are more verbal in nature, such as digit transcoding, where a person's asked to read aloud the written Arabic numeral that they see on a page. And this kind of task relies on a lot of different cognitive skills, including language, visuospatial, memory, attention, and executive functioning. So because of this, it's been suggested that acalculia symptoms are commonly seen in aphasia because of the involvement of the left hemisphere in verbal processing of math problems that you might encounter in real life. To go more into detail on how number processing is represented in the brain, number processing is supported by a really vast system of brain regions spanning across the cortex. And researchers have found that parietal lobe areas play a significant role in the calculation and processing of numbers, while frontal lobe regions play an important role in the recall of numerical knowledge and working memory. So even though it would be an oversimplification to say that one brain region alone is responsible for a particular aspect of numerical processing, the following regions on this slide represent some of the many areas of the brain that are thought to support numbers and calculation. So the intraparietal sulcus is thought to be the primary neural correlate of what's called the approximate number system, which is the ability to estimate the magnitude or the amount of something. The right inferior temporal gyrus is thought to be the primary correlate of the visual number form area, which is the ability to process Arabic digits. And then the left inferior frontal gyrus is really important in processing verbal number words and the processing of simple numerical tasks. So neuroimaging techniques continue to be developed and refined, and this is leading to a more nuanced understanding of the neural correlates of number processing. And the following references on this slide regarding the neurobiology of number processing may be really helpful to clinicians who are considering lesion location in their acalculia evaluations. Now let's talk a little bit about the history of acalculia as a clinical entity and the different classification systems that have been proposed for it. So the very first published case of an individual with severe calculation disorder without linguistic impairments comes from Lewandowski and Stadelman in 1908. And the term acalculia itself was coined in 1925 by Hentgen and Schaller. A year later, in 1926, Berger introduced a distinction between primary acalculia and secondary acalculia. So in primary acalculia, there are fundamental impairments in understanding numerical concepts and performing mathematical operations, while other cognitive functions remain intact. But secondary acalculia, on the other hand, is difficulty with numerical abilities that are secondary to cognitive impairments like language and attention. Now, in 1940, Gersman introduced a clinical entity known as Gersman syndrome, where primary acalculia exist alongside agraphia, right-left disorientation, and digital agnosia, where someone has difficulty recognizing fingers. And Gersman syndrome is a pretty rare condition, but it's been highlighted in the neuropsychological literature because of its really unique profile. Now, there's been a variety of acalculia classification systems developed throughout the years, but the most current and comprehensive system comes from Ardilla and Rosselli in 2002. Ardilla and Rosselli's classification system divides acalculia into two camps depending on the reason for mathematical difficulties. We've got primary acalculia and secondary acalculia. So primary acalculia is just a single entity, sometimes referred to as anarithmetria, while secondary acalculias can include aphasic, alexic, agraphic, dysexecutive, and spatial acalculia. And we're going to go into detail on each of these and the kind of error patterns that we might expect to see. But I do want to heavily emphasize that overlap can exist between these different subtypes, and not everyone is going to fit nice and neatly into one of these classifications, and that's okay. So the first classification we'll talk about is primary acalculia, again, also sometimes referred to as anarithmetria. And put simply, this is an impairment in understanding how the numerical system is organized. And there are fundamental calculation deficits in both oral and written modalities. Primary acalculia is associated with left posterior parietal lesions, especially lesions involving the intraparietal sulcus or the left angular gyrus. And symptoms can include difficulties with numerical concepts, understanding number quantity, understanding mathematical symbols, and even tactile enumeration, which is being able to count by touch. Now, primary acalculia can be present without language impairments, but it is significantly correlated with aphasia. So in these cases, you have a person with aphasia who has difficulty with numbers because of the verbal interference from the aphasia, as well as fundamental disruptions in the numerical concepts that we just talked about. Aphasic acalculia is characterized by calculation difficulties that come from linguistic difficulties. And the types of errors seen here can include semantic errors, where 100 might be read as 10, syntax errors, where people have difficulty understanding how place value within words is represented. There can be morphological errors, where 15 might be read as 50, lexicalization errors, where 163 might be written as 100603. And then what's called decomposition errors, where 632 might be read as 63-2. Now, what's something interesting about this is that there's a stark difference in the types of calculation difficulties that are seen between fluent and non-fluent aphasia profiles, where Broca's aphasia encounters more difficulty with syntax of mathematical operations, while Wernicke's aphasia observed to have more difficulty with lexical understanding. And what's also interesting is that improvement seen in calculation parallel the improvement seen in language recovery for this profile. Going on, alexic acalculia is characterized by calculation difficulties that come from reading difficulties. And one way to help with the differential for this type is that mental calculation skills will be stronger than written. So for people with this kind of profile, digit by digit reading may be observed. So 359 might be read as 359. And people will also have trouble reading longer digit spans. Additionally, some clients with visual integration problems may resort to kinetic writing, where they're tracing numbers with their finger on a surface or in the air. And this is similar to how clients with pure alexia or letter by letter alexia may compensate. They can't visually make out the number, but if they trace it with their finger and get it in their mind's eye, then they can recognize the number that way. Agraphic acalculia is characterized by calculation difficulties that come from writing difficulties. And again, mental calculation skills are typically going to be stronger. And there will likely be issues with writing to dictation tasks and number transcoding tasks. And the types of errors we may expect to see here would be number omissions, fragmentation errors, where 25 might be written as 25, and poorly formed writing because of motor impairment. Now, dysexecutive or frontal acalculia is characterized by calculation difficulties that come from executive functioning difficulties. So if there are any attentional impairments, this might result in difficulties maintaining focus on a task. And a real hallmark symptom of this profile is that complex mathematical concepts will be significantly impacted, even though number processing and fundamental math skills may be preserved. And lastly, spatial acalculia is characterized by calculation difficulties that come from spatial neglect. So here, mental calculation skills will be superior to calculation involving reading or writing. And the types of errors you might see could include the exclusive overuse of one half of the page, There might be digit iterations where the person's writing the same digit over and over. There might be feature iterations where the number itself has extra features added to it. So for instance, the number 3 might have extra loops. There might be difficulty maintaining horizontal direction when writing. There might be spatial disorganization. And there could also be writing over segments of the page that have already been used. Now, these classifications we just went over are a really helpful way to categorize patients depending on the types of specific symptoms that we're seeing. But like we just said, not everyone's going to fit neatly into a specific classification. And even within classification types, everyone's specific strengths and weaknesses are going to be different as it pertains to mathematical abilities. So with that being said, one really helpful way to better capture your client's specific math abilities is through neuropsychological models. So models of numerical processing are really helpful tools for better understanding the types of mathematical errors made by people with acalculia. And this is helpful because errors can be seemingly random upon first glance, but these theoretical models really provide a framework for recognizing why certain errors are made and how we can really tailor our treatment to be individualized to best fit the unique needs of our clients. Now, due to time constraints, I won't be able to go super in depth on these models, but I do want to at least introduce you to two really popular models. And these include McCloskey's model of numerical processing and the triple code model. So the first model of numerical processing that we'll look at is McCloskey's model. And this model was developed by drawing on data from cognitive neuropsychological case studies from the research literature. And this model says that there are 3 core components that all work together for mathematical skills to work. The first component is a number processing component. And this involves identifying and producing numbers as either Arabic numerals, written number words, or spoken number words. And that's reflected on the left and the right-hand side of this model. The next component is known as the abstract internal representations, or the semantic system. And this allows insight into the quantity of a number. And then lastly, there are the calculation mechanisms components, which allows for the quick retrieval of math facts and the ability to do more complex calculations. So overall, these 3 components all work together to allow for number processing and calculation. Now, the big feature of this model is that any number processing task must use the semantic system. There is no way that anything with numbers can be done without semantics. And this is in stark contrast to our next model. So a model that's been developed as an alternative to the McCloskey model is the triple code model by Dehaene. And this model says that there are 3 mental representations or codes in which numbers can be processed. They can either be processed as analog magnitude representations, where we're thinking of the quantity of a number. They can be processed through an auditory verbal code. So these are number words in spoken and written forms. Or they can be processed through a visual Arabic code. And what's interesting about this model is that specific calculation mechanisms are tied to certain codes. So for instance, being able to do multi-digit operations is housed within the visual Arabic code, while multiplication tables are housed within the auditory verbal code. But the big difference in this model from the McCloskey model is that there are asemantic routes you can take to perform specific math functions. So semantics is not central in this model. So again, the big difference in the triple code model is that you do not need to use semantics when processing numbers. So again, a stark contrast to the McCloskey model. So again, I won't have a lot of time to go any further in depth on these models, but I'd really recommend reading more about these models with the references on these slides, because they're a really helpful way to conceptualize the mathematical strengths and weaknesses of our clients. And each model can complement each other and give us a more holistic view of our clients' number processing. So now that we've talked about ways to conceptualize acalculia in different classifications, let's talk now about acalculia assessment. To start off with, let's talk about a few considerations to keep in mind when assessing acalculia. So according to Rosselli and Ardilla, acalculia assessment has three primary objectives. We want to confirm the presence of acalculia. We want to determine the type or classification of acalculia. And then we want to get a clearer understanding of our client's mathematical strengths and weaknesses for us to develop a really individualized treatment plan. Now, as part of your evaluation, you want to be sure to obtain information about the patient's mathematics education and daily use of numbers before the onset of their symptoms, so that you can compare this to any post-onset difficulties and changes in mathematical functioning. And this is going to give you a better idea of what your client's mathematical baseline was before they acquired acalculia and help with setting appropriate goals. Assessment is going to be really helpful in determining whether the underlying deficit for your client impacts the numerical system, the calculation system, or both systems. And during assessment, it'll be helpful to focus not only on impairment-based tasks that look solely at math abilities, but we also want to use assessment tools that are participation-based and give us a better idea of our clients' numerical activities of daily living. And of course, we'll also want to collect some quality of life assessments to determine psychosocial impacts that acalculia might be having on our clients. So by incorporating all these different assessment tools, we can get a really holistic view of how these acalculia symptoms are impacting our client as a whole. And what's also really helpful is that Eroska offers suggestions on testing accommodations for severe language production difficulties. And this can include verification tasks using gestures or yes/no visuals, and then also allowing your client to choose a correct answer from a written set of numbers that you provide. Additionally, when performing your assessments, error analysis is going to be really helpful to get a clear view of your client's specific strengths and weaknesses. And common types of errors that you might see include digit errors, where someone's substituting or omitting a number, place-holding errors, where someone is misinterpreting a number value, borrow and carry errors, where someone is incorrectly performing borrowing or carrying operations, algorithm errors, where someone is not following all the steps correctly of a mathematical procedure, basic fact errors, where someone is incorrectly retrieving a simple plus table or times table fact, and then symbol errors, where someone's either having problems producing or understanding the different computational signs of addition, subtraction, multiplication, and division. So in terms of tools and assessments and resources available for acalculia assessment, it is limited, but there's a small variety of assessment tools that exist for us to use as part of an acalculia evaluation. Some tools are more impairment-based, and they examine mathematical processing through tasks like number transcoding and solving math equations. And examples of these tools include the Johns Hopkins University Dyscalculia Battery, the EC301 battery, and the number processing and calculation battery. Oops. Other tools are participation-based and provide objective measurements of math-based activities of daily living, such as telling the time or measurements for cooking. And an example of that would be an assessment called the Numerical Activities of Daily Living, or the NADL. And then we've also got some patient-reported outcome measurements that can be helpful to use with structured interviews to get a better idea of how acalculia is impacting quality of life. So the ASHA FACS is an assessment that includes some math-related questions. And there's also another great tool called the Subjective Numeracy Scale that we can use as well. So let's dive into a couple of these assessments and look more in depth as to what they offer. So I'm going to really focus on just one impairment-based tool for this presentation, and I'm going to be working on the number processing and calculation battery. So this assessment is designed to be applicable towards both McCloskey's model of numerical processing and the triple code model. And this is a battery that's made up of 35 different subtests and was created as an alternative to other acalculia assessments due to criticisms that they're not reliably assessing all calculation performance tasks. It's been normed on a sample of 282 adults without brain injury, and the full battery is available from the appendix of Delazer et al. And you can find this article on ResearchGate to be able to download a free copy. Now, examples of the kinds of tasks seen on this battery include magnitude comparison tasks, where the client's asked to identify which of two numbers is larger across multiple modalities. There's also transcoding tasks, where the client's asked to convert numbers from one form to another, such as going from Arabic numerals to spoken verbal words, or spoken verbal words to written verbal words. There's also operational symbol and word comprehension tasks, where you're examining the comprehension of operation symbols, like the plus sign and the minus sign, and also the comprehension of operation words like addition and multiplication. There's written arithmetic tasks, which probes the retrieval of arithmetic facts and the execution of calculation procedures. And then there's also oral arithmetic tasks, which are looking more specifically at the retrieval of mathematical facts. There will also be number sequences where your client's asked to produce a sequence of numbers counting by ones, threes, tens, and also counting backwards. And enumeration of dots task, where you'll ask your client to count the number of dots on a page. There will be calculation approximation tasks, where you're going to give your client a math problem with 4 answer choices, and they're asked to estimate the result without actually calculating it. And there'll also be number line task, where you're asked to place a variety of numbers on a number line as a way to probe number comprehension. And what's unique to this number processing and calculation battery is that they break down some of their tasks to be specifically focused around arithmetic rules and arithmetic principles. So in arithmetic rules, we're probing the understanding of different rules, such as the fact that anything times 0 is equal to 0. While arithmetic principles, on the other hand, is looking at different mathematical principles, such as this question here, which is highlighting that the order of numbers in an addition task doesn't matter, and that the result will always be the same no matter which way you order them. And then lastly, there is also a section devoted entirely to text problems. And text problems are going to be particularly helpful for our clients who have frontal lobe damage, because that's an area of vulnerability for those people. So let's now touch base on a couple of different participation-based assessments that can be helpful for acalculia. And the main one I'll be focusing on is an assessment called the Numerical Activities of Daily Living, which is designed to provide objective measurement of math-related ADLs. So it has 4 components. It includes a patient interview and a caregiver interview that asks about the impact that acalculia has on daily routines, as well as an informal test, which looks more at ADLs, and a formal test, which looks more at impairment-based processes. There's also a financial version and short form of the battery available as well. But the big caveat to this assessment is that this was not developed in the United States. So any questions related to measurement and currency are in units that we don't use in the US, like the euro or the kilogram. But this is still a really helpful test for us to use in order to modify these questions and then use this assessment more for qualitative purposes. Now, the interviews of the NADL are designed to get the perspective of both the client and the caregiver on the impact that these acalculia symptoms have. And these interview questions are focused around 6 different areas. You've got a general question that asks about confusion with numbers, a question about time that asks about punctuality for appointments, and then questions that also relate to measurement, money management, transportation, and communication. Now, the informal test of the NADL is where we can really start getting a good look into the math-related ADLs and have your client complete tasks and answer questions about these same domains from the interviews. So as examples here, we're starting to get a look into how number problems are impacting the person's ability to function in daily life by asking them to tell us the time, how much pasta they need to cook for dinner, what their phone number is, and how much something on sale at the store would cost. And then lastly, the formal test of the NADL is a collection of impairment-based tasks that we've just gone over in previous slides. These tasks are not as extensive as the ones in the previous battery we just looked at, but they can be a nice screener to see what areas need to be further assessed more in-depthly. Now, I also want to highlight some tools that can be used as either patient-reported outcome measurements or as quality of life assessments. So again, the ASHA Functional Assessment of Communication Skills, or the ASHA FACS, is an assessment that has a few questions specifically related to mathematical abilities. But one tool that I really like using is called the Subjective Numeracy Scale. And this is a self-report questionnaire that looks at the ability to perform different numerical tasks and also ask your client their preference for how they receive numerical information in terms of what modality do they like to use, Arabic numerals, spoken, or written number words. And again, it's really important that we can consider quality of life assessments so that we can get a more holistic view of our clients and have tools that we can use as outcome measurements to help us see what impact our treatment sessions are having. And they can also let us know if we need to either keep on going with what we're doing in treatment or if we need to change course and try something different. Now, there's one more assessment I want to highlight, and it's actually one that's currently in development. The working title is called the Functional Numeracy Assessment for Adults with Aphasia. And so far, it looks like a really cool test that gives really good insight into specifically how people with aphasia manage math-related ADLs, as well as exploring the psychosocial aspects of acalculia. So I've left a YouTube link here for a video abstract of the assessment, and hopefully we get to see a completed version of this test in the near future. So that was acalculia assessment, and let's now dive into treatment approaches. So the treatment literature has largely focused around 3 different areas for treatment. This is number transcoding, mathematical fact retrieval, and calculation. We'll start out with number transcoding treatments, and there are 4 major treatment studies that I'll highlight here. The first study is a study by Lamanasier and colleagues that was recently published last year, and they developed 3 different protocols designed to target 3 different transcoding processes. So it targets spoken number words to Arabic numerals, transcoding written number words to Arabic numerals, and transcoding Arabic numerals to spoken number words. Now, all 3 of these protocols are what you might think of as a multi-component approach, where different aspects of number processing are all targeted within the protocols. And the tasks in these protocols include things like reading numbers, copying numbers, transcribing numbers, and demonstrating understanding through the use of tools like base 10 sets. This approach also emphasizes the use of different types of number supports like visuals, such as colored folding digits or base 10 sets. And what I also really like about this approach is that it incorporates a metacognitive aspect to helping your client build awareness of their difficulties and what supports are helpful, and how you can use that in real life contexts. So again, there are several different types of visual supports incorporated in this treatment approach, and these can include cards with written number words on them, cards with Arabic numerals, colored folding digits where each color represents a different place value, and as well as a place value table. But the biggest support in this treatment is probably the base 10 set. And this is a set of blocks that visually represent numbers using colors. And I've put a link here on this slide to a virtual base 10 set that I've been using with my teletherapy sessions in case you're interested in checking it out for yourself as well. So here's a table that lists out each of the transcoding tasks and all the steps within them. And to show how this treatment works, I'm going to show a video of me working with a client and doing the spoken number word to Arabic numeral protocol. So here's a video of a client of mine, and we are working on her ability to write down the number 23, which is the number of her apartment. She's been having some trouble with this, and it's getting in the way of things like shopping online and writing down where things should be delivered. So she wanted to target this in her treatment sessions. The number we're working on is 23. Oh, the sound's not working. Hold on just a sec. I might
All right,
get out
so the number is 23. Go ahead and make
slideshare
that
and
with
see
the
if the
base
sound
10
works
set.
this way.
Sounds working.
Oh, it was. Okay. Sorry. We'll do it this way then.
The number we're working on is 23. All right, so the number is 23. Go ahead and make that with the base 10 set. All right, great. So 23, there are 2 10s and 3 1s. All right, now with our place value table, go ahead and make 23, putting the 2 and the 3 in the right spots. All right, go ahead and read the number we have on the screen now.
23.
All right, now go ahead and read the number aloud and point to each number while you say it.
23.
All right, show me the tens digit. Great, the 2 right there. And show me the ones digit. That's correct, the 3. All right, so we've got our base 10 set here of 23. Go ahead and drag 2 10s to the middle of the page for me. Great, so there's the 2 10s for 20. And go ahead and drag 3 1s to the middle of the page. Great, so 3 1s right there for 3. So we have 23. Okay, now we've got our base 10 set right here. Go ahead and put the numbers that go with each part of the base 10 set underneath to make 23. Great, so again, 2 10s and 3 1s for 23. Go ahead and write down 23. Yeah, very nice, 23.
All right, so that is a step-by-step of that treatment right there. Let's get back to our slides here. Oh, let me actually do this way. Hold on. Stop share and reshare. All right, Casey, can you see slides okay?
Yep, I can.
Okay. All right, so a couple of other things I want to mention about this treatment approach is that there is a structure to how the types of numbers are trained, where you start with simple structures, then move to numbers containing a final 0, and then training numbers that have what's called an intercalary 0, or a 0 in the middle, and then complex numbers and specific numbers. And again, this treatment really emphasizes metacognitive aspects. So you as the clinician are going to help your client identify the most common errors they tend to make and help your client build awareness around that. You'll then brainstorm with your client in order to identify situations in daily life where this specific type of task you're working on is required, and ideally what the most effective supports are for your clients, and talk about how, when, and why to use these supports. Another number transcoding treatment comes from Ablinger and colleagues in a 2006 study where they designed a series of protocols to transcode Arabic numerals into spoken number words. And targets in their treatment were trained with gradually increasing complexity, starting with one-digit Arabic numerals, and then going on to tens, teens, hundreds, thousands, and then five-digit numerals. So for their one-digit numeral protocol, you start by presenting your client the target Arabic numeral and asking your client to name it. If they're unsuccessful, you then provide a phonetic cue with the initial sound of the target, or you have your client write down the first letter. If they're still unsuccessful, then the next cue you provide will be the written word for the target, and you ask your client to read it aloud. And if this is still a challenge, the last cue you'll provide is an overlearned number production cue, such as the number comes after blank. The other protocols in the study for larger numbers follow a similar pattern. However, in the tens, teens, and hundreds protocol, there will be an emphasis on morphological markers within the written words. And for the thousands and five-digit numerals protocol, there's an emphasis on using colored number frames to help with the syntax of your numbers. Another approach towards number transcoding comes from Deloche and colleagues in 1989, where they explicitly teach step-by-step transcoding rules. So for example, let's say that you're training two-digit numerals. The rule you might explicitly train is to use the decade name for the digit on the left and the unit name for the digit on the right. Once your client's gotten this down pretty well, you'll then teach the exception to this rule. So in the example here, the exception might be the number 50, since that's a number where 0 is not said as part of the units. And throughout this protocol, you'll again be using different color frames to help with syntax of the number. The last number transcoding treatment I'll review is a number one from Deloche and colleagues, and they tried what they called a covert and overt approach to number transcoding, specifically when it comes to grammaticality judgments. So in the covert approach, your client completes grammaticality judgments without any specific training on the grammar we use for numbers, while in the overt approach, the client was specifically taught different rules for how numbers are said. What's kind of interesting is that both approaches resulted in improvements for trained and comparable non-trained items. However, the covert approach resulted in stronger item-specific effects, while the overt approach resulted in stronger rule-specific effects. Now, when it comes to treatment approaches for mathematical fact retrieval and calculation, there are two types of approaches that have generally been used. There are drill-based approaches where mathematical facts are targeted through intensive repetition, and there are conceptual approaches where principles are taught and backup strategies are trained. So again, drill-based approach is when you are targeting through intensive repetition. We've got several studies here that took this idea and applied it towards treatment. So Claros Salinas did this for all four basic operations through a computer program. Hittmeyer Delazaire decided to target this with multiplication through intense drill. And then Domas trained multiplication facts through the use of color cues. Now, the conceptual approach is where you're teaching mathematical principles and then also teaching backup strategies. So Garelli explicitly taught certain arithmetical principles to help facilitate math fact retrieval. While Domas targeted multiplication through conceptual training, that multiplication is essentially repeated addition of the same number. A couple other approaches I want to also emphasize here. We have one from Fossati that looked at mathematical word problems, in which the word problem is translated into a series of correct operations. And then Prince has a really cool protocol here for targeting fractions through an errorless learning approach. So here there are figures corresponding to fractions presented with parts of the figures colored. So for instance, a square divided into 4 parts, where one part is colored for the fraction 1/4. And the client is then given blank figures and asked to fill in these figures to correspond with the presented fractions. So a lot of the treatment techniques we've talked about so far have been more impairment-based, which is to say that we're actively trying to improve number processing. But let's shift gears a little bit and talk more about how we can incorporate these impairment-based techniques to be more participation-focused. And a really amazing framework for doing this is called the life participation approach to aphasia. So when we're thinking about delivering person-centered care in aphasia, this model here is called the Living with Aphasia Framework for Outcome Measurement, or the AFRAM. And this model highlights that living with aphasia does not include just the language impairment. It also includes the personal identity, attitudes, and feelings of the person with aphasia, their participation in life situations, and their communication and language environment. So with all that being said, here's an example of how this might look like in practice. So let's say that you have a client, and in terms of participation in life, they want to be able to follow the steps of a baking recipe to complete with their granddaughter. In terms of the severity of their aphasia, they have real strengths in reading and auditory comprehension, but there's difficulty with transcoding Arabic numerals into spoken number words, and they also have problems with fractions, which gets in the way of their baking. For personal identity, they want to share these family recipes for holidays with their grandchildren. It's very important to them. And then in terms of the environment, we can make note that the stove and the kitchen uses Arabic numerals. So when we're then using the AFRAM model to think about our treatment and think about all the domains from that model, in terms of the severity of aphasia, we can use evidence-based techniques like the Lemana protocol for number transcoding and the Prince protocol for fractions to directly try and improve numerical processing. And we can also use assistive technology like talking kitchen scales as tools to help return to participation in the life activity. When it comes to personal identity, we can counsel our patient regarding their feelings and identifying what parts of baking are the most stressful for them. And in terms of their environment, we can brainstorm environmental modifications, such as rewriting recipes to feature visuals for each step, or modifying measuring tools as needed. When it comes to assistive technology, there are several tools we can consider using. Tools that have been made for vision loss that talk aloud can be particularly helpful. These include things like talking watches, talking kitchen scales, or phones that speak aloud digits. Of course, there's also calculators available to us and smartphone accessibility features, specifically text-to-speech and speech-to-text. But if you have a client who is either trying to return to school, or maybe they are in an occupation that revolves a lot of math, two really cool apps you can look into are called Photomath and MyScript Calculator. And they really do a nice job of breaking down more complex math equations and kind of showing step-by-step ways to arrive to a correct answer. So those are really cool ones to look into. In terms of apps for treatment sessions, apps we can use in treatment sessions or as part of a home exercise program. Tactus Therapy has a really amazing number therapy app. Constant Therapy also has some arithmetic tasks that can be really great to target. And there's also an app currently in development at University College of London called the Swan app, Sequences and Words and Numbers. And that one looks really promising as well. Now, lastly, I also want to touch base on some cultural considerations when it comes to acalculia treatment. It's important to keep in mind that not all languages structure their number systems on the base 10 or decimal system. In fact, some languages have number systems that only express approximate or inexact numerosity, while other languages have more direct number naming systems than English. So for instance, 11 and 20 in Japanese are said as 10-1 and 2-10 respectively. So if you're working with a client who speaks a language other than English, it'll be helpful to do some research to see how that language's number system is set up. And when we're working with clients from other cultures and backgrounds than us, it can be helpful to practice from a standpoint of cultural humility, in which we're practicing self-awareness, openness to learning from others, and continually learning from the people we work with. Some concrete ways to incorporate cultural humility can include collecting life stories in order to better understand our clients' journeys, observing how language skills are used in the context of daily life activities, involving our clients in the goal-setting process and our rationales for treatment options, being aware of pre-morbid language and math skills, and providing accessible educational materials for health literacy. So this was a lot of information all at one time, and I thought I'd end by highlighting what my personal go-tos are for acalculia assessment and treatment. I also included some research articles that are fantastic overviews of acalculia and ways to approach assessment and treatment. And then, of course, I put the AFROM model in the very top corner as a way to remind ourselves that everything we do in treatment is best tied around some sort of functional and meaningful task that our clients want to get back to doing. So overall, I hope that you're able to walk away from this talk with some new tools and resources to help address the number processing needs of our clients with aphasia. This is an area of aphasia management that our clients really do want to work on and address in their sessions. So hopefully this gives you a starting place to do so with your own clients. So with that being said, thank you so much for attending, and I will answer questions for whatever remaining time we have.
Thank you so much, Brett. If anyone has any questions, please drop them in the chat or the Q&A.
And I'll say too, if anyone is having trouble finding assessment tools or treatment protocols, definitely reach out to me. I'm happy to help provide author emails or track down materials to help you get access to these tools.
Thank you. I don't see any questions so far.
Okay. I'll hang around in the chat then while the next person's been going.
Awesome. Thank you.
Yeah, thank you.
Okay. Our next presenter is Isabel Lawton.
Hi.
Hello.
Can you see me okay?
I can.
Great. Wonderful. Hi, everybody. Let me go ahead and pull up my... Okay. Casey knows this is the part that always fumbles me. It's the, like, just getting it started. So bear with me here. Okay. Share screen. There we go. Hopefully that.
Yep. We see it.
Wonderful. Perfect. Okay, great. And then I just need to make this bigger. So, because multitasking is not always a strength of mine. Casey, will you help me keep an eye on the chat in case anything?
Yeah.
Perfect. Okay, great. Well, welcome everybody.
Do you want me to give them to you as they come, or do you want me to save them? The question, any questions?
Totally your judgment. If it's like appropriate with the topic, you know, we're talking about it already kind of organically, that's perfectly fine with me.
Awesome.
Thank you. Okay, great. Welcome everyone. As usual, giving a presentation and not being able to stare lovingly into your eyes is a little tricky. So please be active in the chat. Let me know if you have questions, if I can clarify anything. But I do have sort of like an interactive component to today's talk. The whole idea is to walk you through a case, and we'll do it together. So let's get started. My name is Isabel Lawton, and these are just some of my disclosures really quickly. I will receive an honorarium for this presentation, and I do also collect a salary from some local hospitals here where I PRN in my local town, and I am also the owner of a private practice called the Growth Therapy Co. And then those are just my non-financial disclosures, so not much has changed. These are my sources to check out. And then a little bit about me. I don't know if any of you have seen me chat before. If you have, then you probably recognize these cuties, but these are my two kids. Speech pathology is my second career. I used to be like in the sales world, and I have a degree in international business and marketing and kind of like decided that wasn't working for me. So I learned about speech pathology, and it's been a really good change for me. I am multilingual. I speak Spanish fluently. I can do what I say. I like to defend myself in Portuguese. And I was a specialist. I really was a true med SLP across the lifespan for many, many years. But having that medical speech pathology background with pediatrics turned me into a little bit of a generalist because I found that everything just kind of intersected. So these are my areas of interest here. There are many. I'm like what I like to say, multi-passionate. And then moving on. So our objectives today, we are going to basically, my goal is that after our talk today, you're going to be able to create a treatment plan for a patient with a disorder of consciousness. It seems like a lofty goal, but I think we've done a good job of sort of delineating what that should look like. And hopefully you'll have a lot of inspiration if you work with this type of population or if you feel like you might in the future. Additionally, we're going to identify areas of collaboration for optimal care. This is going to be kind of woven into the presentation as we go. So try to make note of that as we come along. And of course, if you have any questions, let me know. And then lastly, we're going to describe the benefits of treatment for this population. And so treatment in general can kind of be a little bit of a debated term, because some people will say that, you know, when a patient is in a disorder of consciousness, they're not truly like rehabable, or we're not doing traditional treatment. And there is some truth to all of that, but it's kind of like this dynamic ongoing process of dynamic assessment used therapeutically. So you'll see what I mean, but let me know if that doesn't make sense. Okay, so this is a little flashback. I did a talk like this last year, part 1. It was like an overview at a really high level, and we got really great feedback. And essentially, people seem to want more. So I'm back in on this summit to dive a little deeper into how we treat this population. So I am going to spend just a little bit of time reviewing some of the most important pieces from that last presentation, because, you know, kind of in the last few weeks, we had people saying, oh, I didn't watch the first one. So if you didn't watch the first one, do not worry. I'll do a quick overview and you'll have enough information to get us going for this part 2. Okay, so really briefly, quick, I don't know if like showing hands is a thing, but I want to get a sense for how many of you have worked with a patient with a disorder of consciousness, or would like to, or may in the future. Let me see what we've got going here. Oh, yay. Okay, quite a few so far. Awesome. Okay. Oh, I see someone works at the Shepherd Center, so you probably know most of this stuff already. Great, fantastic. Okay, so I see some of you have clients right now that you're working with. Good. So hopefully this will be helpful for all of you. So really quickly then to recap, a disorder of consciousness is defined by the NIH as a prolonged altered consciousness, the state of altered consciousness where there is kind of like the diagnostics are based on neurobehavioral function. And so there's 3 main categories. There are some subcategories, but the 3 main ones are going to be coma, unresponsive wakefulness, which used to be called vegetative state, and minimally conscious state. Okay. So the reason we're going to spend some time here, it's really important to have a good understanding of these different levels of disorder of consciousness so that you can accurately identify what prompts you should be using with your patient. Okay, so this is a little chart that I made for all of you, and I think we're going to be releasing this as a resource here soon. So if you are not already a member of the collective and you're thinking about joining, this will be available to you very soon as a resource. But basically, this chart does a nice job of breaking down the differences between the levels of consciousness. And so you'll note there's a subset of a disorder of consciousness called covert consciousness. Are any of you familiar with that diagnoses? Let's see, no for some. Okay, so covert consciousness just really quickly has been likened to locked in. And so some people use the term interchangeably, but they're not technically the same. And the exciting thing about covert consciousness as a diagnosis is that it's very hot in the research right now. And essentially, the way to determine if someone is in a state of what we call covert consciousness is through neuroimaging, EEGs, things like that, fMRIs. And essentially, that is a state where somebody has such a profound physical impairment that they are unable to do absolutely anything but appear that they are in a coma. So in some ways, it can be even harder to diagnose than locked in because there's very, very, very limited motor function available. And so these patients really are at the mercy of the clinical staff that's working with them to be sure to thoroughly assess their neurocognitive state through functional neuroimaging to see if that patient is in there. So when I learned about covert consciousness, I was like, okay, new fear unlocked. Add that to the list of things that I hope I never have to experience in my life because it sounds truly awful, but it is an emerging and exciting area of research. So something to keep out for. So that being said, essentially you'll notice that in the coma column, we're not doing anything, right? There's no sleep-wake cycle. We're not responding to light. There's no visual tracking. When we start to move into unresponsive wakefulness, or what most people formerly knew as vegetative, that's really kind of the big key there was, it's making noise. I thought I silenced all my things. Sorry about that. Is the establishment of a sleep-wake cycle. And that is really kind of like the defining characteristic of we're no longer in a coma, we're moving into unresponsive wakefulness. And usually with this, we will see some eye opening. Pretty much everything else, though, is just not happening. It's not there. It's highly variable. Moving into minimally conscious, you'll see that we have the sleep-wake cycle, we have the eye opening, but now we're starting to show some signs in some other areas. We are often tracking visually. Visual tracking does tend to be one of the more common sort of characteristics that will move a patient from unresponsive wakefulness into minimally conscious state, but not always. And then things like command following, it's going to be very inconsistent, contingent emotions, so showing like appropriate emotion to the environment, also very inconsistent. And so what we tell our families when we're working with them, when they have a loved one in a minimally conscious state, we'll say the most consistent thing about being minimally conscious is that the responses are inconsistent. It's consistently inconsistent, which can be very frustrating, as you can imagine. But if you know what to look out for and how to prompt your patient and how to create an optimal treatment environment, then we can identify signs to help us know when a patient is emerging from that disorder of consciousness. So if there is interest in covert consciousness, we may be able to create a future webinar on that topic. So let us know in the chat if that's something that you feel like you might want to learn more about. And I do have some resources that discuss it here at the end that you can look into if you'd like to. Okay, so moving on. This here, types of responses, generalized versus localized. So it seems like a lot of you have worked with the disorder of consciousness population. Does anyone know how to document the types of responses when working with disorders of consciousness? Like, have you received training in this area of how to differentiate between generalized and localized? Again, quickly guess and ask. Okay, I see enough no's to spend just a little bit of time here. So I gave this example in part 1, but I'm going to give it here in part 2 because I feel like it's really salient for all of us. So I want all of you to just imagine for a moment that you are back in grad school. I know. And you are, in a library or a study space. It's absolutely quiet. You think that it's just you, another student, and like the librarian, and that's it. It's empty. And then so it's quiet, you're focused, everything is in place. And then all of a sudden you hear, bam, a huge noise, stack of books has fallen over. How are you going to respond to that scenario? Throw it up in the chat. What are you going to do? Jump? Yell? That's me. I'll be screaming very loudly. I'm very hypersensitive to things like that. Someone wrote jump, scream, look. Yes, 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 all 3. So all of you are describing very localized responses. They're appropriate, they're meaningful, and they are very connected immediately to the event. A generalized response in this type of scenario would look a little bit like what the symptoms are in this column. So if we had that same exact scenario and that loud boom came and you weren't expecting it, and a patient with a disorder of consciousness, you might see like increased tone, right? Or you might see no reaction at all and just a little bit of eye movement, or their vitals might change a little bit. Maybe our heart rate goes up because we've been startled, but physically we're not really manifesting a response anywhere else. Maybe start to vocalize, groan, whisper a little bit, or sometimes even seemingly inappropriate responses like smiling, right? Those would be general. we are aware that something happened in our environment, but we don't have the ability to respond intentionally and specifically to that stimulus. Does that make sense? I just need like a few yeses and I'll keep going. Because if it doesn't, I want to make sure that really is understood. Okay, fantastic, good. So a localized response is exactly what you all described. I'm going to be looking because it's a safety issue, right? And that lizard brain kicks in. I'm going to be looking to see where that noise came from. I'm going to be attending and making sure there's not some bad person out to get me. I'm going to be, peering around, maybe moving things out of the way. For an individual with a disorder of consciousness, if I provide a noxious stim, maybe I'm going to swat at it. Maybe I'll say stop or ow or get away. So the reason that it's so important to really, really understand the difference between those types of responses is because according to the coma recovery scale, which is like the gold standard tool that we use with patients with disorders of consciousness, the more frequently we're using localized responses, the more likely we are beginning to emerge from a disorder of consciousness. When we are providing generalized responses, we may be in that unresponsive wakefulness, we may be in that minimally conscious state. There is some general awareness of our environment, but we're not moving to a place of active consciousness. Okay, one more check-in. Does that make sense? Just a couple of yeses and we'll keep going. Okay, bless all of you for letting me know that I'm keeping everything on track. Okay, it's very easy to get convoluted with this because there's so much to discuss. All right, so another quick recap for part one would be treatment areas. So pretty much every single session, you're going to be doing an alertness check. And that's like kind of what we do with the Glasgow Coma Scale, right? Are we responding? Are we aware of our environment? That sort of situation. We're going to be looking at functional communication, using some kind of like low or high-tech communication system, command following. We're going to see how our patients are using objects. Are they tracking anything visually? And then this is a little bit newer in the literature, but swallowing, which of course is like, hello, that's where we shine, right? So the assumption here for the kind of the rest of the presentation is that we've already done that initial evaluation. I have no idea what's making noise in my office. I apologize, y'all. We have no idea what is, we have completed the evaluation. We know all of the patient's baseline responses. We've completed that family caregiver interview. We have gathered as much information about personal interests, pre-morbid skills, maybe even things that, we're really good at, but things maybe we're not so good at. Maybe our patient was a terrible dancer. Those really, that minutia, those little nuggets of information or details. Okay, good. I'm glad you can't hear random sounds in my office. I think it might be my Apple Watch. I'm going to sit on it because it's bothering me and distracting me. Okay. Music, TV preferences, hobbies, what their profession was, where they went to school, all of that kind of stuff is extremely valuable for your treatment sessions. So when you're doing your initial evaluation, not only are you looking at what the patient's performance is, but you're learning as much about that person as possible. My instructor, when I was learning how to work with this population, told me, I want you to pretend like you are going to date this person and you want to know everything about them to make sure that like you jive, which I thought was a really great example, or play detective. So let's go ahead and move forward from there. Alrighty, so now we're going to come into part two. Forgive this corny graphic, but I needed a transition slide. Okay. Alrighty, I think we have a question. Casey, you'll let me know if this is a good time to
There's
respond.
one question.
Okay.
General response to noxious stimuli, not following instructions, but will inconsistently swallow with oral stim. Where are they?
Great question. So with that limited sort of information, I would say that we are probably floating between unresponsive wakefulness and minimally conscious minus, MCS minus, or we might be solidly in the MCS minus range. What would really be the key differentiator here is if we're engaging in any kind of visual tracking. But typically when we are demonstrating volitional manipulation of a bolus, that is when we tend to be more on the minimally conscious side. We can be unresponsive. We can be in an unresponsive wakefulness state and still be like managing our secretions. So the swallowing piece isn't necessarily going to be a differentiator between the stages, if that answers the question. Eyes are also closed. Okay. Yeah, I would say this to me sounds a little bit more like an unresponsive wakefulness state, just kind of with the description that you've provided here. Okay, cool. Thank you, Margaret. That's a great question. Okay, so moving in here, this is our case. Buckle up, my friends. We have a 24-year-old male. Past medical history, nada, pretty much nothing. ADHD and anxiety, which like who doesn't have that nowadays, right? Prior level of function, civil engineer, project manager, in a long-term loving relationship, really close with their family members, and truly 100% independent in all aspects of their life, ADLs, IADLs, everything. This person completed a master's degree. They enjoy art and drawing, used to draw like, anime when they were younger and kept up with that talent. Music, listening to music, playing around a little bit with guitar, traveling, very, very social, and then lifting, very into fitness, but specifically like lifting weights. The family describes this person as funny, kind, and loving, obsessed with his dog, obsessed with his PlayStation, and recently upgraded to professional grade cookware and chef's knives, likes to like show off a little bit with some of the toys in the house. And so cooking has become a new passion for this patient. So I'm trying to paint a picture for you. So unfortunately, this patient was in a severe motor vehicle accident and suffered a traumatic brain injury. The neuroimaging revealed that there was diffuse axonal injury and encephalopathy, multiple areas of hemorrhage, both gray and white junctions, and in the basal ganglia. So lots of involvement from that kind of shearing effect from the diffuse axonal injury. Some of the symptomology early on is that autonomic instability. So if you're not aware of that, that's just like an inability to the body is unable to regulate itself. So temperature, heart rate, all that kind of stuff is sort of going crazy. So we have a lot of medications to manage that. And a lot of external aids and stimulation to help keep this patient stable. There was a clavicle fracture, a scapular fracture. If you don't know what the scapula is, it's that guy back there. Left rib fracture, right wrist injury. So a little broken kind of all over the place. This happened on April 30th this year. Didn't really, it's an example. So the patient, interestingly, after the accident, the patient was actually alert when the EMTs arrived, and he scored a 15 on the Glasgow Coma Scale, but then had a very sudden loss of consciousness with a very severe grand mal seizure, which lasted approximately 2 to 3 minutes. So the Glasgow Coma Scale basically went from the top to the bottom, of the lowest score being a 3. They were intubated and sedated for the first 3 days of their hospitalization, with frequent seizures and neurostorming for the first 3 days. So they were successfully weaned from the vent, but a PEG tube did have to be placed. Okay.
There is a question.
Okay. All right, let me see.
Autonomic instability versus autonomic storming. What is the difference?
Great. So they can overlap a little bit. Technically, autonomic, so neurostorming, what we call neurostorming, is in a way an aspect of autonomic instability. But autonomic instability in this context, pulled kind of from the patient medical record, would indicate that when they came in, basically the body has undergone severe trauma and nothing is doing what it's supposed to be doing. The body has absolutely no control. The brain is not sending messages the way it needs to send it, and everything is kind of topsy-turvy and upside down. Storming is a much more isolated response. It tends to be environmentally driven or physically driven by what the patient, we're going to dive into that here in just a second. I'll dive a little bit more into neurostorming. And the neurostorming tends to be more of used prognostically, because the more a patient is storming, the longer they're storming, the less likely that we're going to have recovery from this traumatic brain injury. Whereas the autonomic instability that happens right after a traumatic event tends to calm down and settle down when the body has been stabilized. Does that make sense? Yes. Okay. I think I explained that right. Okay. Okay, perfect. Okay, so some comorbidities that were also occurring. Great segue. Thank you for the segue, Edie. We had neurostorming. And so this is also called paroxysmal sympathetic hyperactivity, or PSH. Absolutely nobody calls it that, by the way. Everybody calls it storming or neurostorming. That's the vernacular in the medical settings. So this can look like hypertension, hyperthermia, tachycardia, diaphoresis, or like excessive sweating, O2 desaturations that can require suctioning. And so essentially, really quickly, what's happening here is that the brain's ability to regulate the sympathetic and parasympathetic nervous system is damaged. And so as a result, the body goes into like this fight or flight response and is extremely sensitive to stimulation. And so neurostorming is often an exaggerated and often episodic response that can be characterized by alterations in the level of consciousness, some of these symptoms that we have presented here, and then things like increased posturing, dystonia, and then sometimes even agitation. So this is why stimulation management is such an important part of care for severe brain injuries, especially in the acute care, ICU, and even in the subacute, like inpatient rehab setting when they're going into that, next level of care. If we are still neurostorming, we have to be really aware of what is triggering the storming event so that we can reduce that those occurrences from happening to hopefully reduce the effect on the body. Because if all of these things are happening to the body, imagine the stress that is putting on the heart, on all of the internal organs. It's a very stressful state to be in, and that just long-term is really not good for the body overall. And so it can really damage a lot of the organs. A lot of people can end up with heart conditions and require heart medication because of the severity of neurostorming that they've experienced. So neurostorming is also wildly variable. It can occur for a few hours, or it can for a few days or a few weeks, or it can occur for a few minutes every single day for several months. Like it really just depends on the severity of the brain injury. Prognostically, like I mentioned before, the longer the neurostorming is occurring, the worse the prognosis for recovery. So it's very important to be able to identify neurostorming when it's happening, so that you can document it appropriately, because your care team needs to be aware of the frequency with which the neurostorming is happening. So sorry, I'm getting thirsty. So that being said, we can't necessarily prevent neurostorming from happening, but a lot of times we can use pharmacological interventions to manage some of the symptoms or manage some of the sensitivity to the environment, to help reduce kind of like the instigation of that neurostorming event. So I know that was a big info dump and I said I would do it really quickly, and I did. So let me know if that didn't make sense, or if you have any questions about that. But moving into the other comorbidities here, I mentioned the limitations from the injury to the body here, clavicular and scapular. There was still some glass in the left hand that could just not be removed, tiny, tiny shards. The patient is left-handed, so obviously this could be an issue. Keep that in mind, wink, wink. Generalized weakness in all extremities just from the prolonged hospitalization. I don't know if you all are aware, but after 72 hours of immobility, we begin to have muscle atrophy. So when you have a patient that's been in the bed for 2 weeks and is barely getting moved or ranged by rehab or nursing, you have really severe muscle wasting that can happen, which is going to result in that weakness. Okay. Acute interventions. So what they did for him is they put an intracranial pressure monitor in place on the second day. However, it was incorrectly placed, so they discharged it, and thankfully they didn't need it anymore. So the internal pressures did come down enough that there was no longer a need for that. So think about what that could mean prognostically. And then, like I mentioned before, there were significant pharmacological interventions to help keep this patient stable. All right, that's the case. Everyone good so far? Yep. Okay. Can you tell I'm a therapist? I'm like so feedback driven. Okay, great. I saw a yes. We're ready to go. So they have discharged from acute care, and we are now transferring to our post-acute setting 3 weeks after the accident. So we're still early on in the case. The initial team evaluation indicates that this patient is in a minimally conscious state. So hopefully my little cheat here works, but I want you to take you back to a minimally conscious minus state. So this patient is opening their eyes. They have an established sleep-wake cycle. We are often tracking visually. We don't have any object recognition yet, very inconsistently following commands and not really showing a lot of emotion. Oh, yay, that worked. Good. Severely limited use of upper extremities, which we kind of expected. Intermittent neurostorming noted during the evaluation. And then we have some repetitive movements to make note of. Pay attention to this, wink, wink. They are turning their head left and right, so much so that we have a small bald patch at the back of the head from the frequent friction that's happening there. We're keeping a close eye for skin breakdown. We are randomly kind of kicking that left leg, typo, noted, dang it. Intermittent spells of like rapid blinking, and then increased agitation when soiled. And sometimes that agitation triggers a neurostorm. So that we've already identified a trigger for a neurostorm, which is good. And then the family dynamics are a little bit complicated. So he is close with his family, but apparently this patient is estranged from their father. The parents divorced when they were very young. Father is now involved in the care, insisting on participating in the decision-making. Other family members are frustrated because he was not involved in the patient's life, but now all of a sudden wants to be. And then kind of the biggest issue that the rehab team is having is that the father is incorrectly interpreting behavior, such as like squeezing hand and repetitive movements, as signs of consciousness. So based on what we have so far, does anyone want to take a stab at prognostication based on the information we have? Are we looking like we got a chance to emerge here? What do we think? And don't worry, there's not really a right or wrong answer. I'm just curious to see where your thoughts are. Don't be shy, friends. Oh, I love that. I'm hopeful. Yes, chance to emerge. I agree with all of you. I also am cheating because I know the outcome, but I agree with you. I think your instincts are right on par. So let's keep going. Yep, we're showing localized responses. Excellent. That's a good sign. Okay, so this is what our plan of care is going to look like. So I'm going to go back to the original slide just to give you a chance to look at it again. But what we're going to do here is start with our function, or kind of our first tenet in our plan of care. Functional communication. So what does this look like? Yes, no questions is kind of the standard. This is what is covered with the coma recovery scale, which again is the gold standard. So here's the key. The yes, no questions have to be double elimination style questions. They have to be verifiable. So I'm going to go back to the original slide. I'm going to let you look at it for a second. We'll come back here to this. And I'd like for somebody to throw out a possible yes, no question that you could ask this patient. So I'll give you a few seconds to look at that. Just to kind of refresh your memory. 5 more seconds. All right, here we go. I'm going to go back to it. So, okay, I see some questions here. Is your name X? Love it. Name is a great question. Do you have a dog? Great. Do you have a cat? Good. Asking if they want to listen to music. Is your name, dog's name Rover? Okay. A school question, like where they went, like, did you go to X school? Yeah, good. Are you an engineer? Excellent. Good. These are great questions. So are you standing? Excellent, Latifa. Thank you for that one. So when we are thinking about verifiable yes, no questions, they have to be questions we absolutely want, like, know the answer to, right? So I see a couple questions here and I'm not picking on anybody, so please don't take it that way. But I think I saw one answer that said, if they wanted to listen to music. So that is a great question when you're trying to think about preferences, but do we have a way to actually verify if they do in fact want to listen to music? Not right now, at this time we don't. What we could say is find out who their favorite artist is and say, do you like X so-and-so? And then we could do a yes, no question based on those preferences. But I love in the chat section here how you all use those personal details that I gave you to come up with personally salient questions, because those are going to be more likely to be answered than are you a man? Are you a woman? You know, gender differences aside, are we in Florida? Are we in Alaska? Like, those things might not matter to this patient. We could ask them, but we have a much better chance of getting a response if we're asking questions that are personal to them. Okay. Yes, closed versus open option, exactly. So, and then of course, we want to be considerate of whether or not we're able to use low or high tech. So here's the thing. If the patient cannot verbalize yes or no, what methods can we use to determine how they are answering the questions? Throw your ideas in the chat. Yep, speech generating devices, eye blinks, see a lot of eye blinks. Thumbs up, thumbs down. Look this way for yes, that way for no. Great. Love this. Love this. Open mouth, tapping your fingers. Excellent. So I see some really good answers here. One that I want to talk about really quickly because it comes up a lot is the blinking. Blinking is not preferred for yes, no. Can anyone talk about like why blinking might not be an ideal modality for a yes or no? Right. These are great responses. It could be reflexive. We have to blink, right? And so unless we're providing specific parameters like blink, blink twice, right? We can't really use that and know for certain that we're interpreting their responses. So it's kind of this double-edged sword where you have to provide a really concrete double elimination yes no question, but then also provide them with a very concrete way of expressing yes or no. And so again, not trying to make anybody feel bad, but if they had something in their eye all of a sudden at the exact moment that you asked them that question and they double blinked because they're trying to get it out, could they be misinterpreted? Great. Here, Monique mentions they could be blinking because they have dry eyes. Hand squeezing is another one. Why might we not use a hand squeeze as a verification method? Yeah, reflexive. It comes down to those reflexes. So it's called a palmar reflex. There's a video that's going viral right now on Instagram of this cesarean section. And the first thing to come through is the little baby's hand, and the doctor puts his finger in the baby's hand, and that baby grabs that finger, right? And so we know when we have a severe brain injury, we tend to revert to some of those primitive responses. And when we see disintegration of reflexes, right? So, as we get older, when we're in infancy and as we get older, we integrate those reflexes and we kind of grow out of them. When we see those come out, that can be really indicative of sort of just the severity of our impairment and the impact on cognitive function. So when you're thinking about modalities, think about things that you can really control. So for example, I think I saw somebody say, look this way for yes, that way for no. That's fantastic. In his case, though, what was he doing uncontrollably? Putting that head back and forth, right? So much so that he had a little bald spot in the back of his head. So for this one, we might do a thumbs up for yes, a thumbs down for no. A thumbs down could look like this. A thumbs down could look like this. A thumbs down could look like this. It could look like anything, but we have to model it for the patient. So this is kind of the only slide where I'm going to dive really deeply into how we're providing the prompting, because it's pretty much the same for every area. So the first pass, I might say, is your dog's name X, or do you have a dog? We'll keep it simple. Give me a thumbs up for yes, a thumbs down for no. And then I don't do anything else. I just wait and I give them a full 10 seconds. And if we have no response after 10 seconds, then I'm going to grab his hand and I'm going to say, hey, do you have a dog? Yes or no? Hand over hand. I'm manipulating the patient's hand. Then I bring the patient back to neutral. And then I wait 10 full seconds. The reason for this is if we have an impairment of initiation, we all know just from principles of motor learning and techniques like melodic intonation therapy and things like that, that sometimes we have to kind of prime the pump and initiate that motor plan. So by providing the hand over hand, right, with the thumbs up and the thumbs down, we're kind of giving that model there to see if they can then replicate it and kickstart that for them. And so then on the third pass, we would wait 10 seconds. If we don't have anything on the third pass, we always want to end the question sequence with success. So I would, for him, if he didn't answer, I would take his hand and say, hey, do you have a dog? Yes. Yes, you do have a dog. Your dog's name is X. And then we move on to the next question. Does that make sense? Good. Good. Okay. And then I think I saw, can you clarify again what you mean by double elimination? So double elimination means that I can ask the question in a positive and in a negative and get consistent answers. So for in the example of the dog, you know, if I was to say, do you have a dog? Yes or no, right? And then if I know that he does not have a cat, I would say, do you have a cat? Yes or no, right? I'm going to ask an answer that is related semantically or related topically to the question, and then ask an opposite one. Sometimes it's as simple as appearances. So if I've got visual tracking and I'm wearing something, I might say, is my shirt blue? Yes or no. Or, you know, look up for yes, look down for no, or open your mouth for yes, look to the right for no. I mean, you have to get really creative with what the patient can do based on their physiological impairments, right? And then I might say, you know, if they say no, I'd say, okay, is my shirt green? You're giving the correct answer and the incorrect answer, and you're making sure that both responses are accurate. Does that make sense? Okay, good. And then we have a question from Edie. Do you recommend saying the options each time you do a question? And should you switch the order they are provided? So you can, but in this initial phase, really what we're trying to do is, this is going to seem wild to all of you, but we don't really care about accuracy. Right now, in the early stages, especially because he's MCS minus, we just want him to respond consistently, because then that moves us into plus, right? Because someone can be disoriented. It doesn't mean that they're not conscious. So do we like accurate answers? Yes, absolutely. That is just even more indicative that we are moving in the right direction. But really what we want is response, an appropriate response. It does not have to be accurate though. Does that make sense? Okay. So, oh, I see music therapy here. Contrasting yes, no questions. I love to see this chat blowing up. This is great. Okay, so we are responding, we are documenting, great note, Donna, we are documenting responses. Now, remember though that we end with success. So let's say I said, do you have a dog? And I get this. I might be like, you know, no, yes, you do have a dog. What do you mean you don't have a dog, right? And keeping things light. You can acknowledge the response and validate that they responded. And in fact, you want to, because one of the tenets of therapy that we learned early on in grad school is what? Positive reinforcement. Great job. You answered that question. I'm not going to say that to a 24-year-old, but I am going to be like, no, what do you mean no? Yes, you have a dog. This is his name. You love him so much. And then we move on to the next thing. Okay, so any form of communication is accepted and valid. If they verbalize, if we're getting a thumbs up, thumbs down, if we have yes, no cards stacked after we have verified that there is intact visual perception, whatever modality you have to use it. But that is why we are masters of this domain when it comes to treatment and disorders of consciousness, because we are the communication experts. The onus is on you as a clinician to find the thing that allows them to give you a response, whether it's accurate or not. Okay, so moving on from there, looking at my notes here. So this is anecdotal. There is not an established literature base for this. It's purely anecdotal, but I do want to share it because I think sometimes one of the things that our field lacks that others don't is this idea of carryover of similar principles. And so what I mean by that is that we are, most of us, I think, very familiar with melodic intonation therapy and how that works. And the whole idea of principles of motor learning and priming the pump and automatic speech tasks, like that's what we do for aphasia and things like that, right? So if I have a patient who is an MCS and I'm almost always, if they're an MCS minus or MCS plus, I'm almost always going to make a little bit of time somewhere in my session to do phrase completion tasks. And I like to do it with music. I cannot tell you all how many times I have had a patient who will not say anything, but I sing a lyric to their favorite song and they complete the phrase. And just like that, we have gone from unresponsive to MCS or MCS minus to MCS plus, and we are moving along there. I treated a lot of teenagers with disorders of consciousness, and I have on many occasions been tempted to send an email to Drake himself to be like, your hotline bling helped me move several teenagers from MCS to Rancho 4. Thank you for your service. Because when I would say, I know in that hotline, and so many of them would go, bling. They wouldn't tell me what their name was. They wouldn't tell me what their mom's name was. No questions, but they finished that song lyric. So music is powerful. Music activates both sides of the brains. So just a little nugget for your toolbox there. I've had patients who were musicians and played the piano, were not responding, not really moving their hands. My music therapist would initiate dun, 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 that chopsticks. And you better believe we saw some fingers moving appropriately to the melody. Get creative. This is our superpower. Use it, and you'll be shocked at what you can accomplish. Okay, moving on. Thank you for coming to my TED Talk. All right, so now we have command following. So this is really important. We need to keep it simple. I'm trying to make sure I'm good on time here. So I know we started a few minutes late. Okay, all right, well, we got this. We only have a few more. Okay, so this one's going to seem obvious here, but for command following, why would we need to avoid asking the question, can you or will you? They can refuse, my friends. It is in our patient's Bill of Rights. They can say no. So you have to be really careful with patients who are in a disorder of consciousness because, again, we know from the literature, individuals with brain injury tend to be more concrete, right? Our ability to engage in abstract reasoning is much higher up on that skills of cognitive hierarchy, that cognitive recovery hierarchy that we have. It tends to be much higher up. So if I am dealing with somebody who is in a very concrete headspace that is taking things quite literally, and I say, can you open your mouth? And they don't want to open their mouth, they won't. But here I am interpreting that as a non-response, right? So please, I'm begging of you, do not say, can you or will you? You're going to give the command. You're going to use a very short and simple phrase, and you're going to give lots of wait time. You're also going to really heavily consider motor abilities. Anybody who's worked with individuals with spinal cord injuries who do not have disorders of consciousness knows this as well. So somebody wrote just like middle schoolers, or in my case, my 5-year-old daughter. Boy. So I'm going to give you, I have some examples of like a rote command that you give that is like kind of like a more automatic thing that mostly everybody would know how to do. Does anybody want to take a stab at one that would be like a command? That's like a motor thing. Show me the others. Stick out your tongue. Love it. Smile. Great. Open your mouth. Beautiful. Well done, friends. You got it. I might do something like a fist bump or a high five or shaking hands. I might say, shake my hand, and I hold it out. Shake my hand. If this is their hand, I guess that's hard to do, but if this is their hand and this is my hand, I would go for the second round, I'd go shake my hand and I would lightly touch. And I'm looking for any kind of like thumb moving, fingers closing in. It doesn't have to be a full handshake. It just has to be an acknowledgement of that motion. Or maybe my hand doesn't move at all, but it starts to come up and down. Be hyper perceptual and hyper aware of their response to you, right? And then the third pass is we're grabbing their hand and we're completing the handshake. Greetings are really powerful because social norms are deeply ingrained. They are things we learn in childhood. And therefore, while we don't know a lot about how long-term memory is stored, we do know that it is really primarily suspected to be in the basal ganglia, striatum, cerebellum regions of the brain, the hippocampus. And those are all what? Those are all subcortical. So if we have a traumatic event where we're dealing with axonal injury, and most of our injuries are looking to be superficial, topical on the brain, maybe some of those subcortical systems are intact, and we can use the power of automaticity and rote behaviors to elicit a response. So again, get creative, think about your neuroanatomy, think about your neurocognitive networks and neuroplasticity, and capitalize on that. Okay, so let's see. What else do I have here? So avoiding baseline behavior. So we mentioned it before, but I wouldn't say shake my head. I wouldn't say kick your leg, because we have seen that those things are happening with no responses, and we don't want to misinterpret that and do them a disservice. Okay, Casey, I see that the chat is popping off, which is like, oh my gosh, making me feel so good, but I'm having a hard time keeping track. So make sure, let me know if we see any questions there. Okay, and then okay, so I think we've kind of got it here. If nobody has any questions about command following, we'll keep moving on. Alrighty, so the next one is object use. This one can be a little bit trickier, but essentially what it means to use an object according to the parameters of the JFK coma recovery scale. And the disorders of consciousness scales and other such scales, object use is demonstrated by the ability to grasp, release, and demonstrate conventional use of common objects. That's a fancy way of they're using functional common objects functionally. And so for this activity, you do want to use common objects that are relevant personally to the patient. And then again, you want to consider your motor skills. So I'm sure you're seeing a pattern here of behavior, right? So I'm going to go back to the patient information for like 15 seconds, and I want you to think about some functional objects that this patient might like. Okay, we're back at it. Oh, I love what I'm seeing so far. Yes, yes, friends, you're getting it. Video game controller, paintbrush, whisk, pencil, cooking, ball to play fetch with his dog. I love the creativity that I'm seeing here in the comments. You get it, right? It has to be meaningful. So I have done things like taking a cell phone, especially I had a patient once who had multiple girlfriends and had their accident. And at the hospital, 4 showed up at the same time, all claiming to be his girlfriend. And the parents picked the one they liked the best. But what I did was in our session, I know, I'm telling you, nothing surprises me after working with brain injury. I turned the ringer off on their phone. I call if it was available, if not, any phone was fine. And we made sure that the ringer was on, which nowadays may not be relevant because like who has their ringer on anymore, but whatever. And I'd call it, and you would not believe, again, how many times we saw absolutely no functional object use. But when I placed that phone in the hand and it rang, swipe. Friends, let's just use things that we know that they know how to use and are meaningful to them. And if we didn't answer, I might be like, oh, your girlfriend's calling, because we know that this gentleman has been in a long-term relationship with his girlfriend. We might say, oh, your girlfriend's calling. Your girlfriend's calling. What are you going to do? You're just going to let it go to voicemail? And then we see a swipe, right? This person loves to lift. Maybe I'll put like a 1-pound weight in their hand. They are obsessed with their dog. Maybe I'll do a dog leash or one of the dog's toys. I'll ask family to bring a toy from the house that they're familiar with the squeaking sound. Other common objects, if you don't have maybe family that is available to provide those to you, maybe it would be like things that are, again, more rote. So if I hand somebody, pretty much anybody, even a child, if I hand them a pair of sunglasses and they do have that ability to demonstrate some functional object use, they barely even need the command. I'll be like, the prompt is, these are a pair of sunglasses. Show me what you do with them. And so what we hope to see is, this, right? But if I'm holding it up and I say, this is a pair of sunglasses, show me what to do, and I even get this, it counts, right? Because there is an acknowledgement that there is something there. It's a localized response. Does that make sense? So we get credit, for lack of a better word. Now, if we take it, put it on our face, that's like ideal, right? That tells us that we're moving along more. But even just the act of reaching for it, holding it, getting it somewhere near our face, anything like that would count. I've used whistles, spoons. I've even put some liquid in the spoon because new research is telling us that patients who are in MCS plus or maybe close to emergence will respond orally to a bolus because, again, subcortical rote, we've been eating and drinking since we were in utero, right? Like swallowing our amniotic fluid. Toothbrush, I've even brought in cigarettes for my smoker friends. I brought in lighters, anything that is relevant to them. And so, again, the prompt is, this is an X, show me how you use it. 10-second wait time, first pass, no prompts. Second pass, I'm providing a multimodal prompt. I'm putting it in the hand. If they're holding it on their own, I'm maybe like lifting the elbow to help them bring the sunglasses to the face. Third pass, we fully execute. These are sunglasses. Show me how to use them. No response. I'll say, here, I'll help you. We're going to put your sunglasses on. Ooh, don't you look cool? Make it fun, right? It doesn't have to be sterile. All right. Moving on, because we are running out of time. All right, visual tracking. So this one seems pretty obvious. We are looking at this every session. I don't know that I would say that speech pathology is sort of like diagnosis, whether or not a patient is visually tracking. This is going to be an important area where co-treatment and collaboration with your interprofessional team is very important. If you have access to a neuro-optometrist, please use them. I've so many times had a patient who will not track, and it's because they had such severe double vision that it hurt to look at anything, such severe photosensitivity that they could not stand to transition their eyes, severe visual field cuts, hemianopsias, inattention. You need somebody who is skilled in assessing those things visually to be able to tell you whether or not that is something that they can do. And something to note, with anoxic events, cortical blindness can be a really common occurrence. You need to make sure your patient can even see, right? And so that's when we might do something like visual threat to see if we're getting some kind of a response. This is something you need to do as early on as possible, because if you're going to be using prompts that require visual awareness, you need to make sure that there is visual awareness and visual perceptual ability. So if you don't have a neurooptometrist on hand, occupational therapy, many of them specialize in visual modalities using assistive technology. So really quickly, the Tobii Dynavox has really brilliant software. I'm not promoting them or affiliated with them or anything like that, but they have really brilliant software that is infrared, and you can put like a YouTube video on the screen, for example, and you can have patients whose eyes are moving so imperceptibly that you cannot tell, but then you play back the software from Tobii and you can see exactly where the patient was looking on a screen. I had a patient who was a football player, had a motorcycle accident, loved to watch football. We put on his favorite team. It did not look like he was attending. We played back that infrared tracking system. Not only was he watching, his eyes were right on the mark with the ball. When it got hiked, I don't know. I'm not a football player. He watched the ball go to the quarterback, watched it go down the field, watched the play happen. And so to be able to back that up with evidence with the use of infrared, we very quickly were able to move him from an unresponsive wakefulness state to an MCS plus purely because his eyes told us that he was attending, right? So again, think of things that are salient. We are running short on time, so I'm going to go ahead and give you some examples here myself, but a mirror is very powerful to use for visual tracking. Selfie mode on a phone. I've had some younger adults who won't track themselves in a mirror, but I'll get their mom to say, hey, or their girlfriend or a friend to be like, hey, go take a selfie. And so they'll take their phone camera and they'll go, hey, so-and-so, and then the patient sees the phone and goes, he makes some kind of face or smiles a little bit or follows the phone. Those can be powerful. Photos of pets or loved ones, playing a favorite movie, music videos. I know we don't watch those like we did back in the day with TRL, if you're of my age and whatnot. But music videos are still really powerful for patients. So consider adding that to your toolbox as well. I'm going to be trying to move through these, so let me know if you have any questions. We've just a couple more slides. Swallowing. Okay, so what we have here essentially is we're doing oral care in every session. We know that oral care in and of itself is not billable. However, if you're using oral care as a means to monitor response to the environment, you better believe that that counts as billable. Why? Because if you put a toothbrush in a patient's mouth and we're lateralizing that tongue to get rid of it, or we're pressing our lips together because we don't want it in, we're showing signs of oral defensiveness. All of those things are indicative of an awareness to this external stimulation, right? If your patient is demonstrating volitional swallowing, they're able to maybe handle an ice chip or two after some oral care, don't be afraid to send them for an MBS. The research, and it's in my resources here at the end, it was out of a study from Belgium in 2018. They found that patients who were consistently able to volitionally manipulate a bolus, so chew on some ice chips, move a bolus from one side of the mouth to the other, they had something like a 60-something% emergence rate, like really, really high. And so that's our domain. I see a question from Rachel. Are we billing for swallow or communication? I'm billing for communication because these patients are usually in my setting at the time was inpatient rehab. We're looking for a response to the environment, which is like a method of communication, but you could always check with your facility to see what they're okay with. Now, if I am in fact doing a modified bedside swallow study, like modifying it somehow, or I am doing an MBS or fees, then yes, absolutely, I would be billing for swallowing. You want to consider risk, of course. We don't want to create an unsafe environment. We don't want to incorrectly communicate to the family that this person is able to like eat full meals and encourage unsafe behaviors. families, when they have a loved one who is so impaired like this, they latch on to any kind of hope that they can have. And so if we're not doing much of anything, but we're eating pudding in therapy with the speech pathologist, we have to be really careful that they're not tempted to replicate that in the room and create an unsafe situation for the patient. Okay. And then family training, which would be pretty straightforward. So, okay. So benefits of treatment here. When we say treatment kind of in this non-traditional sense. This slide was in part 1, but it felt appropriate to include in this presentation as well now that we've gone through like a partial case. And I've added a few things here as well. So caregiver training obviously is the most important. We want to be conducting these components of these sessions with the family in hand. And at one point, just flipping over and you're sitting back and you're coaching, and it becomes a caregiver coaching model where you're showing them how to move through the first request, the second request, the third request, all with the 10 seconds in between, giving them ideas on prompts to use. We have a very important role in specialist referrals. Sometimes, a lot of times, unfortunately, we have issues like spasticity. We have visual issues that are happening. We need to make sure that we are looping in the appropriate members of the team in the event you're seeing somebody like this, like in a home health setting or in a non-traditional setting where maybe you don't have immediate access to your interprofessional team. Helping to get DME set up. In our case, that would be any AAC devices that the patient might be appropriate for, but also collaborating with PT and OT about standards and other types of equipment so that the family knows how to use those while also prompting and eliciting potential responses to their environment. If you're working with pediatrics, you're going to be really involved with school reentry. And so sometimes that looks, if they're in a disorder of consciousness, we're not necessarily going to school, but the IDEA Act mandates that they have access to that stimulation and that inclusion in their environment. So you'll play a role there as well, especially if there's still some neurostorming going on. And then, of course, the big one is monitoring for signs of emergence and then using that data. This is the most powerful one. If you take nothing else away from this presentation, this is the most important thing. You're going to use all that data you've collected about their responses to create as optimal as possible an environment for responsiveness. There isn't any literature right now that tells us that what we're doing is going to pull a patient out of their disorder of consciousness, nor do we have anything that's going to make them emerge faster. However, if they're capable of responding and we are constantly providing them with that ideal, optimal stimulation, and they therefore are responding more, maybe, just maybe, we can help them get there a little faster, right? So make sure that you're using your interprofessional colleagues for that holistic collaborative care approach. And hopefully we'll see the outcomes that we want. Unfortunately, they're not always what we want them to be, but as long as we are being creative, really harnessing and mastering our superpowers, our flexes of communication, specialization, and I feel like speech pathologists are really in tune with our patients. We just have this ability to kind of read those paralinguistic features of speech and those nonverbals, sometimes a little bit better than other interprofessional partners. Capitalize on those skills and help your patients' families and your interprofessional team be as aware as possible of what your patient is actually truly capable of despite their disorder. Whew, we did it, friends. We got it. Right at 60 minutes. Okay, I think we're over by a few, but we started a little bit late in my defense. These are my questions. Any last minute questions I can hang back in the chat because I think we have our next presenter here. You all are so kind. Thank you. I'll be in the comment section unless there's anything urgent, Casey, that you want me to address right now.
Yeah, if you want to just pop in the chat in the comments, because we are running a few minutes behind. So we're actually going to take a quick break and then follow back up with our next presentation. So we'll be starting about 5 minutes later than we would.
Okay.
All right. Thank you so much, Isabel.
Or let me end my share.
Please view important safety information, including indications and usage, at the end of this video. Meet Janie. She's a speech-language pathologist, and it's her first day at Excellence Medical Center. She's excited to be part of a top-tier institution and eager to help her first patient. As she prepares to do her first modified barium swallowing study, Janie's surprised to learn they don't use the standardized Veribar barium sulfate products. At the weekly staff meeting, Janie brings up her concerns about doing MBS studies without Veribar. She learns that her colleagues know about Veribar and thought it would be nice to have, but feel they're okay with how they do things now. Janie responds, "This is not a nice to have, it is a need to have." She goes on to explain that Veribar is the only line of contrast agents approved by the FDA for MBS studies. It was developed in conjunction with doctors Jerry Logeman and Joanne Robbins, who recognized the need for standardized viscosities. The staff insist that they all mix the same recipes and therefore are already standardized. Janie points out it's impossible to be standardized when you're mixing and modifying contrast agents that are not developed or formulated for the MBSS. It is also much more likely to result in human error. Janie asks, how many have had patients who've undergone repeat exams? Janie insists that as SLPs, our job is to ensure the exams are standardized and reproducible across the continuum of care. She continues by discussing problems with the GI barium products, most of which are designed to coat, unlike Veribar. Coating can be mistaken for residue and lead to potential false positives. After making her case, Janie asked her colleagues if they would be willing to try Veribar. When her colleagues agreed to try Veribar, Janie contacted Bracco to consult with a clinical specialist. After a trial, everyone agrees that the Veribar products should be implemented. However, they disagree on which Veribar products they prefer. Janie refocuses the staff on the science and reminds them that evidence, not opinion, should guide clinical decision-making. The staff expresses concerns that radiology won't allow the full line, and they begin to discuss which product they could forego if they needed to compromise. Janie responds, "We should not compromise when it comes to patient care. I will be happy to talk with radiology and present the literature." The next day, as Janie meets with the radiology administrator, she discusses the importance of using standardized materials and how it relates to patient safety, professional communication, and protection from liability. She also explains how the Veribar line is different from other GI barium sulfate products and how it meets the needs of the MBS studies. The administrator is impressed when he learns that only Veribar is FDA approved specifically for MBS studies and offers benefits beyond improved efficiency. From that day on, the only product line at the Excellence Medical Center used for modified barium swallow studies was Veribar. For more information on the Veribar family of products or to learn about our sampling program, email us at veribar@diag.bracco.com. Provide your name, location, and phone number, and the appropriate sales specialist will contact you. Please view important safety information, including indications and usage, at the end of this video. Meet Dave. Dave is getting ready for his annual trip to the Outer Banks of North Carolina for a weekend of fishing and fun. It's a tradition that Dave and his fraternity brothers have been doing for 25 years. Dave looks forward to this trip every year, catching up with friends, fishing, and eating. For him, it's a time to relax. But this year, he almost didn't go. You see, 6 months ago, Dave had a stroke. In the hospital, while taking his meds, he began to cough. His nurse made a note of it, and Dave was referred to a speech-language pathologist for potential stroke-related swallowing issues. Meet Sandy, Dave's first speech-language pathologist. Due to concerns about Dave's ability to swallow, Sandy recommends a modified barium swallow study, or an MBS study. Sandy has been conducting MBS studies for years, so preparing the different contrasts is nearly automatic for her. First, Sandy prepares the thin liquid. She pours about 3 ounces of liquid EasyPake into a cup. But EasyPake is a little bit thick. It pours more like a nectar than a thin liquid. So she adds about 3 ounces of water to thin it down. Perfect. Sandy's happy with her thin liquid mix. Next, she prepares the nectar thick liquid. Looks about right, she thinks to herself. Now Sandy is preparing a honey thick liquid. Sandy's done this countless times and quickly eyeballs the right amount of thickener. Next is the puree. Sandy mixes easy paste with pudding, the way she's accustomed. Finally, Sandy prepares the solid by spreading some easy paste onto a cookie. Sandy is confident with her work. The nectar thick liquid wasn't exactly to her liking, but she quickly dismisses any doubts and begins the test. She hands Dave the thin liquid and instructs him to take a small sip to begin. After the test, Sandy meets with Dave to discuss the results. She tells him about the upcoming therapy. When she lets him know about food restrictions and modifications, it really hits home. After 4 weeks of therapy at the rehab hospital, Dave is on his way to take a second MBS study. Meet Kim. Kim is Dave's current SLP and has been working with him at the rehab hospital. They are both excited with his progress over the past 4 weeks, and Dave is hopeful he can return to a normal diet. He wants to enjoy his trip to the Outer Banks, and this includes cooking and eating all the fish they catch. Kim has prepared more MBS trays than she can remember and has always done it the same way. Kim wonders if this is really a reproducible assessment. As Kim reviews the results with Dave, neither one can believe it. How could it appear that Dave's condition hasn't improved compared with Sandy's test? Later that day, Kim remembers a conversation with a colleague about Veribar, the only standardized contrast approved for MBS studies. Kim contacts Bracco for information about Veribar and requests samples. The Bracco dysphagia specialist explains that not all barium products are alike and schedules an online education session to explain the science. After receiving the samples and retesting Dave, Kim finds that the results are consistent with her initial expectations. Dave is both relieved and excited because he really has improved. He's also excited about going to the Outer Banks and enjoying his regular meals the way he's accustomed to.
Veribar barium sulfate. Veribar thin liquid barium sulfate for oral suspension. Veribar thin honey barium sulfate oral suspension. Veribar nectar barium sulfate oral suspension. Veribar honey barium sulfate oral suspension. Veribar pudding barium sulfate oral paste. Indications and usage. Veribar thin honey barium sulfate oral suspension, Veribar nectar barium sulfate oral suspension, and Veribar thin liquid barium sulfate for oral suspension are indicated for use in modified barium swallow examinations to evaluate the oral and pharyngeal function and morphology in adult and pediatric patients. Veribar honey barium sulfate oral suspension and Veribar pudding barium sulfate oral paste are indicated for use in modified barium swallow examinations to evaluate the oral and pharyngeal function and morphology in adult and pediatric patients 6 months of age and older. Important safety information. For oral administration, this product should not be used in patients with known or suspected perforation of the GI tract, known obstruction of the GI tract, high risk of aspiration, or hypersensitivity to barium sulfate products. Rarely, severe allergic reactions of anaphylactoid nature have been reported following administration of barium sulfate contrast agents. Aspiration may occur during the modified barium swallow examination. Monitor the patient for aspiration. Please consult full prescribing information for Veribar products. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Veribar is manufactured by EZM Canada Inc. for EZM Inc., a subsidiary of Bracco Diagnostics Inc., Monroe Township, New Jersey 08831. Veribar is a registered trademark of EZM Inc.
Welcome back, everyone. And I'm going to introduce our next presenter, Kelly Salmon.
Hi, everyone. It's good to be here. Good to see everyone logged in. And I'm excited to speak with you all on a topic today that is near and dear to my heart. And I will first share my screen and then we'll get into it. All right, so my topic for today is talking about dysphagia in adults with intellectual or developmental disability. The underscoring theme of my presentation is to talk about using clinic and community partnerships to really optimize outcomes in this patient population. I'll share some of my experience working in a university clinic and how we help provide services to this group of individuals by forming partnerships with community-based SLPs as well as members of the interprofessional team that typically work with these individuals in their home or institutionalized settings. Oh, let me just get the, here we go. My disclosures are listed here. Instead of reading them line by line, they are available in the handouts as well. A little bit about me. I have been a speech language pathologist now for over 20 years, almost 22 years to be exact. And while it doesn't seem to be that long ago, it was, and I've come to terms with it. But I've spent most of my career working with adults in medical settings. I've had the wonderful opportunity to work across the continuum of care. My most recent full-time clinical experience was working within an otolaryngology and head and neck surgery practice in a large urban medical center. But I've since transitioned to full-time academia. I'm currently an associate professor at a small university in the suburbs of Philadelphia, Salus University, and I teach within the graduate program there. I've been lucky enough to maintain a pretty robust clinical practice as part of our on-campus clinic. So I get to share my expertise and work side by side with my students within my areas of expertise, which do include swallowing, oncology, rehabilitation, addressing head and neck lymphedema, a little bit of voice and motor speech as well. Oops, went a little too fast. The learning objectives for this evening, we're going to talk a little bit about identifying the unique challenges and risk factors associated with dysphagia in adults with intellectual or developmental disabilities. We're going to hope to gain an understanding of the practical strategies and interventions for assessing and managing dysphagia in this population. Again, kind of focusing on using clinic and community partnerships to optimize outcomes, and then learning how to collaborate with interdisciplinary teams and to leverage community resources to develop comprehensive dysphagia management plans tailored to the specific needs of adults with intellectual or developmental disabilities, overall promoting improved quality of life and health outcomes. So a little bit of background or kind of laying the foundation and providing some basic definitions of this population. I can't move forward without thanking a mentor of mine, Dr. Christine Goldinia. She spent the bulk of her career really working and advocating for this patient population. And she was the one who introduced me to working with this population. And we've really been able to partner with each other to provide services to these individuals. So I can't thank her enough for her mentorship and her expertise in this area. So in terms of an introduction, just to give some terms and definitions, developmental disability is an umbrella term. It includes intellectual disability and other disabilities that are apparent during childhood caused by a problem that starts anytime before a child turns 18 years of age, including before birth. Intellectual disability falls under that umbrella of developmental disability, and it's characterized by significant limitations in intellectual functioning as well as adaptive behavior. Intellectual disability originates before the age of 18 and often co-occurs with other developmental disabilities. So examples of developmental disability include the conditions listed here: things like ADHD, cerebral palsy, autism spectrum disorder, Down syndrome, other syndromes like Fragile X syndrome, fetal alcohol syndrome. And you'll see that intellectual disability is listed as its own category that falls under the umbrella of developmental disability. Often in these individuals with intellectual disability, there are comorbid or co-occurring developmental disabilities. So they may have one or more other conditions that are listed here. So how common is intellectual disability and or developmental disability? There was a recent study done in 2023 where data from the National Health Information Survey was collected and aggregated and used to develop a prediction of the prevalence of developmental disability and intellectual disability within the United States. Between 2018 and 2021, the estimated prevalence of any developmental disability in the United States was about 16.65%. And this was based on calculations that were done on a collection of data with over, I think, 23,000 individuals, in order to make estimates regarding the entire population. The prevalence of intellectual disability alone is estimated at 1.72%. Over the past decade, the prevalence of developmental disability has increased, with it being about 18% between 2015 and 2017, compared to about 16% between 2009 and 2011. The prevalence of intellectual disability increased by a little over 3.5% in 2019 and 2020, compared to data from the same survey that was completed in 2014 and 2015. So while the overall prevalence may not seem like a whole lot, it is on the rise, or it is increasing for both developmental disability in general and the subcategory of intellectual disability alone. If we look at classifying intellectual disability, the distribution based on severity, you can see here that most cases are considered mild, about 85%, and the remaining more severe levels comprise the remaining 15%, with profound disability being only about 1.5% of individuals with intellectual disability. So most kind of fall within that mild to moderate category. In terms of how we classify intellectual disability into these categories of mild, moderate, severe, and profound, there's a couple different ways that they have been classified either in the past or currently. And you'll see here that there's information from the Diagnostic and Statistic Manual of Mental Disorders from the 4th edition, as well as the 5th. And you'll see that there was a big change between those two versions of this manual, where originally the classification was based purely on IQ scores. More recently, in the 5th version of the DSM, you can see that the scores are based on daily skills. So, for example, someone with a profound intellectual disability would be someone who we would expect that would require 24-hour care, whereas someone with a mild degree could live independently with some level of support. The other category is based on the American Association on Intellectual and Developmental Disabilities, and they base their classifications on the intensity of the support that is needed for that individual. So again, as examples on either end of the severity scale, someone with a mild intellectual disability might need intermittent support during transitions or periods of uncertainty, where someone with a profound impairment would require pervasive support for every aspect of their daily routine. So these are some systems that are used to come up with that classification from mild to profound. What's really interesting in this particular population is looking at some of the data surrounding causes of death in this population within the United States. And we're focusing here specifically on areas related to feeding and swallowing disorders or difficulties. So in the first row, you'll see listed the prevalence or percentage of individuals with no intellectual disability, otherwise healthy or otherwise not classified as ID or DD. And then you'll see for individuals with intellectual disability based on the severity, they rated it, they combined mild and moderate, and they combined severe and profound. And then there's also an overall summary of the percentages for all individuals with ID. And you'll see some things that really stick out here for this particular population are pneumonitis due to solids and liquids. So, inflammatory processes within the lungs due to aspiration of food and liquid. So in the general population, individuals with no intellectual disability, that is listed as a cause of death in only 0.72% of cases. And if we look at individuals with intellectual disability, you see those numbers are significantly higher, 4.35% for individuals with mild to moderate severity, and 13% for individuals with severe to profound impairment. So that is significantly increased over the general population without ID. Other interesting findings include influenza and pneumonia as being another upper respiratory, lower respiratory issue that impacts this patient population. And then the last column on the right looks at choking. So, we know that aspiration and choking are different things. Choking is complete blockage of the airway, asphyxiation. And so in this population, this is a pretty relatively common finding that is unique to this population in particular. And you'll see that choking is listed as a cause of death in only 0.18% of the general population. And those numbers are much higher, significantly higher in individuals with intellectual disability across the board from mild, moderate to severe and profound. So knowing this information, knowing the prevalence of intellectual disability, knowing some of the causes of death that are different in this population compared to the general population, it leads us to looking at some special considerations when we're evaluating these individuals, both clinically, and then we'll talk a little bit later about evaluations through modified barium swallows and fees and how our approach to those instrumental studies might be slightly different in this population. So when we look at a clinical swallow evaluation, the components of the evaluation remain the same in this population, but the questions we ask and the things that we might look for in a chart review may be slightly different or have a different focus in terms of areas of interest. So when we're looking at a chart review and a medical history, again, there's some things here that are the same as any other population, like looking into why they're being referred for assessment and why at this point in time. We also want to know about their developmental disability diagnosis or diagnoses, including the onset, and any other health issues, acquired or chronic issues. We also want to be aware of any medications and potential side effects, what their primary means of nutrition is, their respiratory status, and any surgical history that they may have. Another important component of assessment in this population is the patient and caregiver interview. In a little bit, we'll talk about the importance of caregiver involvement and caregiver buy-in in addressing feeding and swallowing impairments in this population. So the interview with the caregiver as well as the patient is another important component. So for these individuals, we do want to dig a little deeper into information about their residence or their environment, like where do they live, do they have a history of institutional living, and what level of support do they require. In addition, we want to ask questions about their social history, including things like smoking history, alcohol history, any recreational drugs, meal times and support. So, across the gamut when it comes to eating and feeding. We want to know, are they doing their own shopping and preparing of food, or are they reliant on someone else to complete those activities? What is the process for requesting help if needed? Are they receiving assistance at meal times? And if so, what is that caregiver doing or helping to provide that individual? We also want to know whether or not they're using a feeding tube and whether that's their primary means of nutrition or if it's there in a supportive manner to supplement what they're able to do by mouth. And we also want to ask questions about oral care. Are they able to perform this independently? Do they require assistance? What is the normal routine for them? With mealtime supports, the prevalence of the need for mealtime support, based on a study done by Ball and colleagues, was about 15% of adults with intellectual disability in the United Kingdom. So about 15% of individuals required some degree of mealtime support. And based on the information obtained in this study, some of the reasons that they might need mealtime support would be for modification of the texture of the food, to provide prompting, pacing, encouragement, assisting with adaptive equipment, helping to correct body position during meal times, assistance with getting food to the mouth, modifying fluid consistencies using thickeners, modifying the mealtime environment or their routine, monitoring or controlling diet and fluid intake, and then assistance with providing enteral feeding through a PEG tube. In addition to patient and caregiver interview and digging into mealtime supports, we also include a cognitive communication screening as part of our assessment. Often these individuals have had past evaluations that we can review to gain additional insight into cognitive communication status, but we may still conduct a brief screening so that we get a sense of this individual's level of function, and again, obtain information from the caregivers to fill in the gap. When we do an oral motor and cranial nerve exam, often, depending on the severity of the intellectual disability, individuals may or may not be able to follow simple or complex commands. So we often have to use modeling, visual and verbal cues to encourage participation. And we often have to adjust our approach based on the individual's understanding and comprehension. And in more cases than not, I have found if you're not able to really elicit responses, we need to kind of more informally observe cranial nerve function in the context of things like spontaneous movements, facial expressions, and then look at function during oral intake or trials that we're doing with them. In addition, we would assess oral hygiene and dental health. Additional anatomic and physiologic assessments that we may perform in this population do include looking at secretion management and drooling. We may also look at oral and facial structural abnormalities or anomalies. We want to see if we can observe characteristics of either volitional or spontaneous cough responses. And then we look at positioning and postural stability. This is often an important factor for many of these individuals. Do they eat in a typical chair, or are they in a wheelchair, or do they need to be in a hospital bed when they're eating? So looking closely at positioning and postural stability, especially knowing that the risk of choking in this population is significantly higher than maybe some of the other patient populations that you would be evaluating. With our clinical assessment, again, we're looking at mealtime observations, trials of food and liquid. Ideally, we would want to observe these individuals in their home environment if possible. However, that may not always be possible. And so in that case, we would want to try to replicate their typical feeding setup if we're completing the assessment in the clinic. So for example, we might want to make sure that the caregivers bring some familiar foods, bring the individual's adaptive equipment, We would consider environmental factors like having the caregivers present or not present, lighting in the room, background music, etc. And often we do encourage those caregivers to attend the sessions because they're the ones that are most often working with these individuals and providing those mealtime supports. So for our assessment, ideally, we want to see what that interaction looks like. We want to see, how they're executing strategies and what that mealtime looks like. So we want to see, what the behavior is like, sizes of bites and sips, the rate of presentation, etc. In this population too, there are also behavioral considerations. So we want to observe and look for maladaptive eating and drinking strategies that these individuals may have developed over time. We look for impulsivity, the speed of eating or just kind of shoveling that food. Looking at cognitive impairments and how they might affect judgment of bolus size, pacing while eating. And then we might look for other behavioral issues like pica, where people, are consuming non-food items like fabric or dirt or chalk or other things that we normally would not eat. Disruptive behaviors, refusal, apprehensiveness, obsessive compulsive routines, or inability to adhere to prescribed strategies. So that's our initial clinical assessment and some of the information that we want to gather initially. There are risk assessment tools and screening tools that have been validated in this population of adults with developmental and intellectual disabilities. So these can be very helpful tools in helping us to establish a baseline level of risk based on the information that we get from these validated tools. So we're going to go through 3 tools in particular. The first is the Dysphagia Disorder Survey. The second is the Choking Risk Assessment and Pneumonia Risk Assessment. And the last one is the screening tool of feeding problems. Again, these are all tools that have been validated in this population of adults with developmental and intellectual disabilities. So the Dysphagia Disorder Survey is a screening and clinical assessment of swallowing and feeding function for eating and drinking developed specifically for children and adults with developmental disability. The statistical analysis that was completed during the validation process was performed on a sample of about 650 individuals between the ages of 8 and 82. They all had intellectual and developmental disability, living in 2 residential settings in the United States. The Dysphagia Disorder Survey is a reliable and valid test for identifying and describing swallowing and feeding disorders in children and adults with developmental disability. The Choking Risk Assessment and Pneumonia Risk Assessment, these tools each consist of items that designate risk factors for or that are related to choking and pneumonia risk. The predictor variables that are included in this risk assessment have correctly identified 92% of individuals at risk for choking and 86.5% of individuals at risk for pneumonia. So the data suggests that both of these tools have high specificity. And remember, specificity is a measure of how accurate a tool is at correctly identifying individuals with a condition or a disorder. So in this case, this tool has high specificity. So it does a good job at identifying people that do have the risk of either choking or pneumonia. And therefore, we can use this tool successfully to help us predict risk of choking and pneumonia within these adults with intellectual or developmental disability. Based on the information that we get from this tool, we can implement precautions to mitigate choking and pneumonia risk to try to avoid, the undue impacts on quality of life for these individuals. The third tool is the screening tool of feeding problems. This was developed as a means to identify feeding problems presented by persons with an intellectual disability for diagnosis, treatment, and evaluating the outcomes of treatment. This is a 23-item feeding problem screening instrument that is, again, validated for individuals with intellectual disability. The items for this scale were developed to target feeding problems identified in the literature in the areas of risk for aspiration, food selectivity, feeding skills, deficits, food refusal, and associated behavioral problems, and nutrition-related behavior problems. So this one was validated on 570 individuals ranging in age from 14 to 87. And this may help serve as a good initial assessment tool for identifying the existence of disorders related to feeding and mealtime behaviors that meet diagnostic criteria. So you may use one or multiple of these 3 tools as part of your initial assessment to really give you a big picture of risk assessment, mealtime behaviors, other feeding and swallowing skills that we may want to have a baseline measure of. So as I mentioned, there's a lot of information that we can gather from our clinical assessment, from administering some of these validated tools. But we know that we get the most objective information from instrumental assessments. And often, there is a myth that these individuals cannot participate reliably in these types of assessments. However, these individuals are often great candidates for participation in either modified barium swallows or FEES exams. So these individuals, again, can participate and benefit from instrumental assessments with a few key considerations. For individuals with intellectual disability, some of the indications for an instrumental exam may include, the clinical swallow assessment, suggesting that they have compromised nutritional or pulmonary status. The individual or the caregiver's complaints or symptoms don't match the findings of your clinical swallow evaluation. The clinical swallow eval or the case history is suspicious for dysphagia, or the individual is fully dependent on others for feeding or for oral care. So when considering an instrumental assessment for these individuals, we should include the following: communication between the speech language pathologist and the caregivers before the exam so that they have a clear understanding of what to expect and why we're doing this assessment. It also requires often quite a bit of coordination with caregivers to ensure that a familiar mealtime partner is present for the exam. So sometimes that could be, a family member who's a caregiver. It could be an aide, a nurse, a nursing assistant that works with this individual routinely. In addition, to reduce anxiety surrounding the procedure or the process, we often, involve the individual that is part of that feeding or mealtime routine for that individual. And we also encourage them to choose things like familiar or preferred food and drinks to bring that to the exam, and also helping to modify environmental factors. So the lighting, music. Some individuals, want to have their headphones on or have, one of their favorite shows or I had a patient who just liked to have YouTube running in the background. And so they had their tablet and we had it there so that it was, something familiar for that individual while we were preparing to do our FEES exam. So trying to make that individual as comfortable as possible and have as many familiar routines and people and materials for that individual. We also would use verbal reassurance or distractions during the exam, especially for that initial part of doing a FEES exam and getting the scope passed and in place to be able to evaluate swallowing. In addition, as I mentioned, we want to try to replicate the individual's natural mealtime environment to the best of your abilities. Again, encourage presence of preferred or familiar caregivers, include the individual's own adaptive equipment for feeding and positioning, ask the caregivers to bring the individual's towels, blankets, etc., and allow the individual to have stimulating or comforting items during the exam. So pictures, headphones and music, tablet, toys, etc. Keep in mind the purpose of doing an instrumental assessment, and it's to provide us with some really important information. Most importantly, we want to know why. Why is this individual presenting with signs of dysphagia? Doing these assessments allows us to develop an individualized dysphagia plan of care, and it assists us in developing a prognostic statement and to help frame our expectations regarding our approach to treatment. Is our approach going to be a management approach where we're really focusing on using strategies and compensations to manage the symptoms of dysphagia? Or could this individual benefit from a more rehabilitative approach where we are working on addressing underlying issues related to weakness or tone or incoordination? So if we look at some of the approaches to dysphagia management, this is true across all populations, but in particular, we do look at the International Classification of Functioning of Disability and Health, so the ICF or the World Health Organization framework. And when doing that, the 4 key pieces of the puzzle are the health condition, which is the disorder or disease that informs our predicted outcomes. This is what helps us to get a sense of what we can expect in terms of outcomes based on interventions or how a disease may stabilize or progress over time. We look at body function and structures. So we look at the anatomy and the physiology and the function. We look at activities and participation. So the execution of tasks or involvement in life situations. And then we look at environmental and personal factors. So physical, social, attitudinal, and environmental factors that might be present within that particular individual's life. So there's also practitioner identified barriers to dysphagia management for individuals with intellectual disability. So this is based on the work of Chadwick, and we see that there can be many different levels and barriers to managing dysphagia in this population. So it could start before we're even ever consulted. There could be barriers within the referral process, transitioning from pediatric to adult-based services, confidence and expertise of the SLP serving these individuals. Assessment barriers include things like difficulty conducting assessments, accessing instrumental evaluations, management and implementation barriers, things like caregiver beliefs and attitudes, food and drink modification, caregiver knowledge and understanding, and challenges with time. Ongoing adherence barriers, difficulty with adherence within the staff, the family, and the client themselves. And then organizational barriers, things like multidisciplinary challenges, general practitioner barriers, barriers to obtaining the necessary resources, and then medical staff lacking knowledge and understanding of dysphagia, as well as enteral feeding in this population. So when we look at approaches to treatment in this population, we look at habilitative versus rehabilitative approaches. For these individuals, they should be fully considered for either approach, but the decisions that we make are going to be based on evidence-informed practice and really driven by the plan of care. So with a habilitative approach, this is a process that's aimed at helping individuals to either attain, keep, or improve skills and functioning for daily living. It could include things that are management-based or compensation-based, like alteration of food consistencies or liquid viscosities, compensatory strategies that do not alter physiologic function, and then postural changes. In one of the case studies that I have, we'll talk a bit about the importance of postural support and positioning. And then a rehabilitative approach is where we're really focused on trying to alter swallow physiology over time. And it includes things like skill and muscle strength training. In terms of other considerations, we apply the ICF to maintain a person-centered approach, thinking about, what is the purpose of this technique? What is the impact on the swallow mechanism? Does this technique fit the needs and limitations of my patient? Rehabilitative exercises have mainly been explored with other populations with dysphagia, for example, post-stroke dysphagia. However, data regarding people with intellectual disability primarily focus on younger people, so children and adolescents less than 18 years of age. So the safety and the efficacy of these interventions for adults with intellectual disability are unverified and untested, meaning there's kind of a gap in the literature in terms of, the role of rehabilitative exercises and, what can we expect in terms of outcomes if we take this type of approach with adults with intellectual disability. But we don't know if we don't try. So creativity and staff engagement is really essential in this population. We often need to think outside of the box to address some of the, feeding, swallowing, behavioral issues that are present in this population. And again, thinking about, what are we trying to achieve in terms of developing our plan of care for these individuals. If we look at compensatory approaches, again, there are many different components to this. There's the obvious things like altering food consistencies, liquid viscosity, using compensatory strategies and maneuvers, postural supports, but this also includes, caregiver support and caregiver training, consistency training. So making sure that staff and caregivers know, what the appropriate, food and liquid preparation should look like. So, being able to educate them on, the IDSI levels and give them concrete examples of what that individual's food and liquid should look like when it's mealtime. Training with visual aids, written directions, having the caregiver demonstrate a desired action. So spending time with them one-on-one to really make sure that they're comfortable with any strategies or techniques that we're recommending. Patient engagement, often making a game out of it or using a reward system is highly successful in this population as well. So again, some tips and tricks with compensatory strategies. We want to think about what we are attempting to address or to train. We may modify food consistency, liquid consistency. Are we trying to facilitate better airway protection? Are we going to modify bolus size or rate of presentation? And what will we actually train the caregiver to do during a mealtime to optimize this individual's functions? We have several different tools and adaptive equipment items that we can use with this population. The photo here are nosy cups of varying sizes. So the advantage to using these types of cups is that the individual can maintain their head in a neutral position. They don't have to put their head into extension to get the liquid back into the oral cavity. It allows them to maintain kind of that ideal posture with a neutral head position. Similarly, this cup is called the dysphagia cup. And it's kind of an interesting shaped cup. It's a little more narrow at the bottom and a little wider at the top. And it's also got more of an oblong or oval shape so that it also allows enough space and enough room so that the individual can tilt that cup without having to throw their head into extension. It prevents, or it helps to prevent liquids from escaping the lips and directs the liquid to the center of the mouth based on kind of how it's shaped. And it provides that sufficient nose clearance to empty the cup without having to tilt your head back. So this is, kind of a funny shaped cup, but it does serve some purposes that might be beneficial for these individuals. In addition, you might see use of cups like this. This is a double-handed or double handle weighted mug. So the gray disc at the bottom of the cup is actually kind of like a weight, and it makes the cup heavier. It gives two handles for the individual to hold on to for better control, to bring that cup to the mouth. And it can be used with or without the spout connection at the top. So this is another piece of adaptive equipment that may help to compensate for some motor control issues. In addition, there are other tools that we can use to help limit or modify the size of the bolus. So here is a volume control device that is meant for use with a straw. And this can be helpful when an individual has difficulty independently monitoring the size of liquid sips. This could also be that the caregiver doesn't know when to squeeze a straw to stop, flow of the liquid. So both of these tools, one is used with mildly thick liquid. So the blue device is used with mildly thick liquid, and the clearish white device is used with thin liquids. These both work. They have little weights built into it so that once the individual expresses 6.2 milliliters, or approximately 1 teaspoon of liquid, into the device, it will then close the spout so they cannot take any more than that 6.2 milliliters of liquid. So it helps to control the size of the sip, and it prevents the individual from taking sequential sips. They can't take another sip until the weighted or the weight drops back to the bottom of the device. So there are some tools out there that help us to limit bolus volume if necessary. Other things include the maroon spoon, which is often very helpful, not only for monitoring the size of the bolus, but also for individuals that might have like a tonic bite reflex. This is a great tool for that. And there's other adaptive utensils, like that looks like a regular fork, but it's a weighted fork. It's really heavy to provide that additional sensory input. A flat spoon to kind of help with individuals that may not have great tongue control, to really get that bolus off of the spoon. And then here's a knife with an adapted grip. So, we may be the ones to initiate these discussions on adaptive equipment, or we may work closely with an OT or PT that is able to collaborate with us to choose the best options. So caregiver training, as I mentioned, we can't emphasize the importance of this enough in this particular population. But we also need to consider the autonomy of the individual with the intellectual disability as well. These adults do have the right to participate in developing their plan of care. However, participation will depend upon the individual's capacity, and that should be documented. There's state-specific legislation that looks at advanced directives, and then there are rules and regulations that apply directly to this population to ensure that their rights are being respected, that if they do require someone that has the ability to make decisions on their behalf, that all of that is clearly documented. So working with the individual at whatever capacity they're able, plus caregiver training, is the key in addressing these issues related to feeding and swallowing. So what do we know about caregiver training and dysphagia outcomes? The most commonly used strategies include pacing, postural changes, modified diets, and utensils. And so if, a lot of what we're doing is focused on that caregiver training, what should we collect our data on? Talk about the type of training, tracking the success of the caregiver in achieving those training outcomes, and then documenting how we assess the caregiver's knowledge of what they need to do, as well as the things that we've taught them during training. How can we evaluate their baseline knowledge versus what they know after being trained? And did we evaluate, or can we evaluate, the caregiver's knowledge of non-adherence? So do they understand, the potential ramifications or things that could happen if, for example, the individual, receives regular solids instead of minced and moist solids? Do they understand that the choking risk for that individual increases substantially if we're not closely monitoring, the types of foods and liquids that they're being presented with? So there are some strategies for successful caregiver management training. We want to obviously develop a relationship. We want to use pictures, models, videos to educate them and explain what dysphagia is. Obviously, we want to acknowledge their beliefs and their fears as legitimate. Have frank discussions about the risks, the best interests, and why we might recommend food and liquid modifications. We also, again, want to highlight the risk of non-adherence to these recommendations to staff. What could happen if they're given the wrong type of food? What could happen if we don't sit them upright before feeding them? What could happen if we don't, make sure that we're pacing that individual during a mealtime? Obviously, involve the individual with intellectual disability in the training of their caregivers. See if they're able to help provide feedback regarding, some of the strategies, the pacing, the bite size, the sip size, et cetera. Focus on positive changes, and then, observe and record the caregivers, give them feedback on their performance. All of these things help to ensure, caregiver buy-in of, why it's so important to, implement some of these strategies and techniques for the safety of these individuals. When it comes to effective and ineffective strategies for caregiver training, here's kind of a compare and contrast of things that typically work really well versus things that don't work so well. So, using a patient-centered approach is important. Being innovative in how you present your training and how you engage the individuals in training, involving multiple members of the team, being consistent, having open discussions. These are all things that lead to good caregiver buy-in and consistency with training. Ineffective things would be, giving them information only once and expecting them to implement a plan based on that one-time interaction. Relying solely on verbal and written content, relying only on the self-motivation of others, ignoring the beliefs and values and feelings of caregivers. So those are things that may kind of be a barrier to establishing effective caregiver training and interventions. So I wanted to talk a little bit here at the end about our community to clinic pipeline. In my personal true fashion, of course, I include way too much information in my presentations. I included 2 case studies here, but I don't think we'll have time to get to both of them. But the first one, I think, will be a really good example of kind of how we make this partnership between the clinic and the community work. So for us, we have connections with several group homes and community-based facilities that are residential care facilities for individuals with intellectual disabilities. And we have close relationships with the speech language pathologists that are the primary SLPs that work within these settings and within these institutions. They're the ones who are doing that clinical assessment and determining some of the caregiver training strategies. They're the ones that are recommending instrumental swallow assessments and referring the individuals to us to have those things done. Our clinic is a university clinic, and we're fortunate enough to maintain a pro bono status, which means that we do not have to access an individual's insurance benefits or charge them out of pocket or even a sliding scale. We're able to provide these services completely pro bono. So that does give us the opportunity to form some of these partnerships and take away some of the barriers that might otherwise be in place. Within our clinic, we are able to offer fees exams and the opportunity to have patient caregiver and intra and interprofessional education to really collaborate as a team to optimize the outcomes for these individuals. So we work with caregivers, we work with the primary SLP, and together we collaborate to develop goals and plan and the plan of care. So in order to highlight an example, we're going to just go through this one example and kind of talk you through how we've been able to leverage these types of partnerships to serve the adult population with intellectual disabilities within our region. So this case was a great case. And another great thing about this as a university clinic is we get to involve our students. And typically when we do fees exams, we have a team of students, usually 3 students who collaborate and assist with that exam for each patient that we have come in and do a fees. So they're getting that hands-on experience, and not with passing the scope, but with everything else, providing instructions, completing the pre-exam, helping to interpret the exam, thinking through, making recommendations. So that provides another unique angle to this collaboration. So the example, the case I wanted to talk about first and foremost here was a 33-year-old female with mild to moderate intellectual disability. She does have additional developmental disabilities, including muscular dystrophy. So she's been identified as an adult with intellectual and developmental disability. Her muscular dystrophy has progressed significantly over the past year, resulting in occasional coughing while eating and drinking. This is what her caregiver and her team has observed. Despite that, she has no history of pneumonia, no history of aspiration or choking events, no chronic upper respiratory infections. She lives in a group home with 24-hour support. She is dependent at this point for all ADLs, and she has been bedridden with a past history of some areas of skin breakdown. So, nutrition for her is of utmost importance. So when the community-based SLP evaluated her for her clinical swallow evaluation, she found that this individual was confined to her bed for meal times. And that was because she was lacking a wheelchair with proper head support. So I'll show you an image of what she looked like in her wheelchair before they were able to obtain the proper head support for her. So she couldn't maintain her head in an upright position in the wheelchair, so her mealtime was in her hospital bed where they could at least raise the head of bed to a position where her head was not falling forward and she was supported during her mealtime. In terms of cognitive communication status, she was able to engage in limited reciprocal verbal and nonverbal communication. During our assessment, she was not able to follow your typical commands for the fees exam, where we ask people to go through a series of tasks to look at vocal fold movement, velopharyngeal closure, et cetera. So we essentially, for our oral motor and cranial nerve exam, had to observe function through spontaneous movements and during our swallow assessment. So she had no prior instrumental swallow assessment documented anywhere in her medical history up to the point that the community SLP completed the clinical swallow assessment with this individual in her group home. So she was being fed minced and moist solids and thin liquids through a cup with a straw. They did attempt feeding her in her wheelchair, but she became fatigued within about 5 minutes. She was unable to support her head in an upright position and had kind of that chin to chest posture, which resulted in a loss of the bolus, poor bolus coordination, along with difficulty coordinating breathing and swallowing. With her wheelchair reclined, like a tilt in space wheelchair. At that point, with her being reclined, she did consistently demonstrate coughing within that position. So they retested everything with her in bed, with the head of the bed elevated and her head and neck and shoulders supported. with pillows. With those supports, she was able to consume her prescribed diet with only occasional coughing. A detailed meal plan was created, the caregivers were trained, and an instrumental swallow assessment fees was recommended. While the patient did not have a documented history of dysphagia, her rapid progression of her muscular dystrophy put her at significant risk of experiencing a dysphagic-related event such as choking. The instrumental assessment was recommended to further identify any components of dysphagia and determine the least restrictive food and liquid viscosity. So I'll move through this quickly in the interest of time, but her community SLP, again, has lots of expertise in working with this population and came up with this beautiful individualized feeding plan created for the staff and caregivers taking care of her. So it details her diet recommendations, provides pictures, it shows her adaptive equipment, gives instructions on what they should do if she's coughing, and there's a photo of how they should set her up in the bed to make sure that she's best supported for successful feeding and swallowing. So here's an image on the left of what she looked like in her wheelchair, even though she has the straps and supports for her trunk and her chest. Her head was still falling forward, and in that position, she was experiencing coughing, again, difficulty coordinating breathing and swallowing. And then the image on the right is how she looks with the head support that they were able to obtain for her wheelchair. So she was in a much better position once they were able to get the right postural supports. So when she came to us for her FEES exam, she came in her wheelchair with her head support, and that was the position that we tested her in. We had her primary caregiver from the group home come with her, and they brought some food items that she's been eating at bedside, minced and moist solids, and we had the thin liquids ready for her. So the image on the left is what her oro and hypopharynx looked like before we gave anything by mouth. And she has some really interesting anatomy. Her velum is just resting there on the tongue. She doesn't have well-defined vallecula, piriform sinuses. And as a result, we can see in the first image on the right, she did have quite a bit of pre-swallow spillage. The bolus reached the level of the laryngeal surface of the epiglottis before she initiated a swallow, and this was with a pureed solid bolus. Here, the image on the left shows that she had penetration to the level of the inferior 1/3 of the laryngeal surface of the epiglottis with that pureed solid. And the image on the right is one that's a little scary. Here she was taking a bite of her minced and moist solids. And you can see that the bolus spills all the way into the pharynx. Right now, it's kind of sitting along the laryngeal surface of the epiglottis and the posterior pharyngeal wall. So it obscures our view of the airway, of the vocal folds, and, could be obstructive, right? But eventually, with multiple swallows and a delay in time, she was able to eventually trigger that swallow and clear some of this material. But when you're looking at this, you can see why there would be concern for choking, right? If there was anything more solid than this, you could absolutely have a situation where, a big piece of food is directly obstructing the airway. Okay. So the image on the left, multiple swallows with lots of time in between. She still had significant residue within that post-cricoid space after that solid trial. And we did see that there was some penetration of that material at the level of the anterior commissure, the proximal trachea, and the right ventricle. We did get adventurous and gave her a bite or a small bite of a piece of banana just to see what she could do from a mastication perspective. And that's what we see here on the left. It kind of fell straight to that post-cricoid space. And again, partially obstructing our view of the laryngeal structures. And again, here's that banana just kind of sitting there. again, all things that we would be somewhat concerned about. We also did see some retrograde bolus flow with that soft solid after she had taken a sip of liquid. So, yeah, we tried a lot of different things. We observed deficits across the phases of the swallow. And what we did find, though, is that even though she did have some degree of airway invasion, penetration, trace aspiration, she did actually have a delayed but robust sensory response to aspiration. So she was able to produce a strong and effective cough response that cleared the aspirated material from the proximal trachea. So, when we were watching this study in real time, it looks scary to see that material kind of hanging out in the pharynx, definitely presenting, a choking risk. But at the same time, we had to think about, this individual has been eating full meals at this level of, food and liquid consistency for quite some time. And she's been able overall to manage that successfully, no respiratory issues or anything along those lines, no choking issues. She's got very attentive caregivers. So as a result, we did not change any of her recommendations at this time. We didn't recommend a more restricted diet. We agreed with the recommendations that were set forth by her primary SLP. We reviewed several compensatory strategies and mealtime supports with her caregiver, and kept them in the loop that if anything changes or there's any additional concerns, if her disease progresses, have her come back and we'll be more than happy to reassess. But then at that point, we turned over her daily care to her caregivers, her follow-up care to her community-based SLP, and really worked as a team in order to optimize this individual's function. And if nothing else, doing this exam, we now have a baseline level of function for her so that if we do need to reevaluate, we can look for any change in function so that we know whether or not we need to make changes in her plan of care. All right, so I know it's 7:05 exactly, so I will stop there. Let me just put my contact information here for you all. If anybody has questions beyond what I can answer for you now or in the chat, my information is here, my email, my Instagram contact. Always happy to answer questions, talk about my experience and hopefully, just prepare people for the opportunity to work with these individuals. It really is unique, especially with all of the caregiver training and collaboration, and super rewarding population to work with as well. So I thank you all for your attention, and hopefully there was at least some new information or some things that will give you food for thought moving forward, and make you feel hopefully a little better prepared if you do have the opportunity to work with these individuals. So thank you all. I really appreciate it. I'll address any questions that there might be, but I'll get off of here to let the next speaker come on. So thank you all. I really appreciate your time and attention.
Thanks so much, Kelly. Yeah, there are a few questions that popped up in the chat. Okay, I'm going to introduce our last presenter, last but certainly not least, Katie Threlfeld.
Hey guys. All right, can you guys hear me okay?
Yep.
Awesome. All right, I'm gonna get my slide deck pulled up and then we'll get started. Okay. Ready for us and we'll get going.
I could see it, but I think it's in presenter view.
Can you see just
Okay, wait.
my screen now?
Okay, now I think it's good.
Perfect. Okay. Good deal. All right. I wanted to get it set up so I could be monitoring questions if they come in as we go. Hello, everyone. Thanks for hanging in there for the last presentation of Spring 2024 MedSLP Summit. I know it's late for some people and it's a Sunday, so I'm just excited to be presenting and to have so many people here with me today. This week's, this spring summit, the focus, when I found out, it was really wanting to talk a lot about advanced therapy for complex patients. I knew immediately I wanted to present on AAC and assistive technology and how those two really compare together to provide individuals with increased access to their environment, to really promote independence in ADLs, and to really maximize functional independence. So really thinking about AAC in combination with assistive technology and what we can do as speech language pathologists, the power of those two things. So quickly, I'll go through my disclosures. As I said, my name is Katie Threlfeld. I am a licensed ASHA certified speech language pathologist and a Rehabilitation Engineering and Assistive Technology Society of North America, or RESNA, certified assistive technology professional. I've been a clinician for about 10 years with clinical experience in AAC across the lifespan. I'm currently a clinical assistant professor and a virtual clinic coordinator in the CAT School for Science and Health at Yeshiva University in their online master's program. I am an adjunct faculty member at the University of Arkansas. I do some work for Forbes AAC, and I am a paid mentor for the MedSLP Collective, and I will be receiving an honor from the collective for this presentation. So we'll get through the nuts and bolts early on, do intro, and then we'll dive into the who, the what, the when, the where, and the why of AT and AAC, making sure we're really thinking about these two items, what they mean, and how they can pair together for our patients. And we'll talk about evaluating for alternate access for individuals with complex communication needs. And we'll discuss how we can maximize individuals' independence for accessing their environment through AAC and AT. We'll finish off discussing funding barriers and solutions for those barriers, and then hopefully have a few minutes for questions. So the learning outcomes for today, after this presentation, participants will be able to identify 3 alternate access methods that may be utilized to access AT and AAC systems, describe 3 ways accessing ECUs through an AAC system improves an individual's independence and functional communication, and then explain 3 barriers and 3 solutions for increasing accessibility through AT and AAC. Sources from today are up to date as in like a week ago, continuing to add and really make sure everything in this presentation is ready to go. The fun, but also the challenge of presenting on something like AAC and AT is that it's technology. It's always changing and always advancing. Just this week, Apple announced that they are going to be putting out their own eye tracking system through iPads this fall. So it's always changing, it's always evolving and improving, and that's what's fun about AAC and assistive tech. So I wanted to start this presentation with this quote. It says, "For people without disabilities, technology makes things easier. For people with disabilities, technology makes things possible." I find this quote to be very powerful, particularly because it was originally quoted in 1988, which, I wasn't even born then, right? So to think about the technological advances since this quote was said, and knowing that this was well over 30 years ago, but it couldn't be more timely and relevant, I think is just a great way to kind of kick off this presentation. We know that technology is a very powerful tool And we know that assistive technology has made and continues to make tremendous advancements. And this continues to significantly improve the lives of individuals with disabilities. Like I said, just this week, Apple announced new accessibility features coming later this year, including eye tracking, their own eye tracking on iPads. And we know there's been significant technological advancements over the last few years. Think about things like our wearable devices, wearable technology like smartwatches or fitness trackers, track vital signs, can provide reminders for medication, and can even detect falls for individuals with mobility impairments. Okay. Think about things like voice recognition and voice assistance. This voice-controlled technology, such as like an Amazon Alexa, allows individuals with disabilities to control their devices, send messages, set reminders, and perform various tasks through voice commands. You know, there's ongoing advancements to things like text-to-speech software, as well as speech recognition software. There's a good amount of research going into BCIs, or brain-computer interfaces, that enable individuals to control devices and communicate using their brain signals. We also know there's smart home technology advances, things like smart thermostats or smart lights, right? All of these things continue to advance, to improve, and to provide opportunities for people with disabilities to make things possible, right? That technology can do that for them. So let's talk briefly. We'll move through these kind of quick because this is a more advanced CEU. But quickly, I want to talk about the who, what, when, where, and why of AT and AAC. Right? These technological advancements demonstrate the power of technology and how that can enhance the quality of life for individuals with disabilities and can really promote inclusion and independence. As I said, for the purpose of this presentation, when we're talking about maximizing functional independence for AAC users, we're talking specifically about individuals with more complex needs, right? Particularly thinking about those who are not ambulatory, who are maybe, have involved fine and gross motor systems, talking about patients who have more involved medical diagnoses, so individuals with TBIs or ALS, the pediatric population, thinking about individuals who may have a diagnosis of cerebral palsy. That is the population we're addressing today. So the WHO, there's an estimated 5 million Americans and 97 million people in the world who could benefit from AAC. Right? AAC is used by individuals of all ages and abilities, individuals with developmental disabilities or progressive diagnoses, acquired conditions such as aphasia. AAC and AT can be utilized by individuals across the lifespan. Right? Methods can be low tech, no tech, right? Something like a simple gesture or a point. It can be high tech, right? So individuals may be using high-tech AAC systems. Regardless of this type of system an individual is using, we know that the goal of AAC is to provide individuals with the means to communicate effectively and independently. And through that, we're also thinking about how an individual who's using AAC may benefit from assistive technology items, right? There's more than 2.5 billion people worldwide who need one or more assistive technology items. And we know that with this aging global population and rise in non-communicable diseases, it's estimated by the World Health Organization that approximately 3.5 billion people will need assistive technology by 2050. So the who of AT and AAC is really all-encompassing. Next, we have the what. So I want to make sure everyone today we're all kind of on the same page in terms of what we're discussing We're talking about AAC, or augmentative and alternative communication. It's an area of clinical practice where we focus on helping individuals either supplement or compensate for impairments in their speech and language production. AAC actually falls under the broader umbrella of assistive technology, right? Assistive technology is the use of any equipment or tool or strategy that can improve daily living, functional daily living for individuals with disabilities or limitations. Again, AAC, really kind of an umbrella term for all of the different ways we communicate outside of our verbal communication. Gestures, pointing, light text systems, high text systems, and so on. Can be utilized for individuals across the lifespan with various needs in terms of communication needs, access needs, and so on. And then we have assistive tech. This includes any equipment, item, software, or product that is used to increase, maintain, or improve an individual's functional abilities. So again, this is that umbrella term, AAC falling under this umbrella term. We think about AT as being things like communication boards, right? Light tech AAC, or speech generating devices. But then assistive tech also includes things like prosthetics, mounting systems, switches, accessible keyboards, different types of software that can be utilized in the classroom for different specialized curriculum. All of this can fall under assistive technology. And then we talk about the when. We know that assistive tech and AAC is most often utilized by older individuals, children, and adults with disabilities, and then for individuals with long-term health conditions, and that's according to the World Health Organization. AAC is incredibly unique in that it's different for each person, right? It can be utilized augmentatively. So when it's being used to supplement verbal speech, it can be utilized alternatively. So it can be used to replace speech. It can also be a temporary form of communication, maybe being utilized in the ICU or when someone's recovering from some sort of acute condition, right? It can be temporary, it can be permanent, it can be for short-term needs. Each individual is going to have unique needs for AAC and AT. And that takes us to where. AAC and AT is utilized in many different settings, right? We know that speech language pathologists play a vital role in AAC assessment and intervention. According to ASHA, the professional roles and activities for SLPs in this area of clinical practice includes clinical and educational services. It includes diagnosis, assessment, and treatment, as well as advocacy, education, administration, and research. As speech language pathologists, we have many different roles and responsibilities in this area of clinical practice. Things like screening. So we may be screening individuals to determine if they may benefit from AAC assessment and intervention. And again, when we're thinking about the where, we're thinking about how screening for AAC can be done maybe at the bedside in the acute care setting, or it could be done in an early intervention assessment for a pediatric patient who is at risk for global developmental delays. SLPs also need to determine, after that screening, do we need to pursue further assessment or refer for outside services? Those outside services may include referrals to professionals such as assistive technology professional, an OT, a PT, maybe a vision therapist, or maybe music therapist. Lots of different professionals you may be working with in these instances. We're also documenting progress and determining whether there needs to be ongoing AAC modifications. And almost always an individual's AAC system is going to require modification, pretty frequently, right? Thinking about how an individual's needs regarding their AAC system may change based on their abilities, may change based on their medical status. So those modifications may be needed, for example, for a patient with a diagnosis of ALS. We know that how they access their AAC system may change through the progression of the disease, right? They may require and rely on more word and phrase prediction as the disease progresses to prevent fatigue when that disease is progressing, right? We also want to ensure that we're providing programming support. We're going to be providing technical support, and we're going to be working with individuals through kind of like that trial process to determine what system is best for them. And then we move into the why, right? We know that AAC combined with assistive technology can really provide individuals with increased access to their immediate environment, right? This is going to provide an increased level of independence and autonomy. It's going to increase their access to both their immediate environment, but maybe also their school environment, work environment. It's going to allow them patients who use AAC to increase their ability to communicate with various communication partners for a wide range of communicative functions and really promote independence in ADLs. So the next slides I wanted to go through thinking about the who, what, when, where, and why of AT and AAC. We want to think about through the use of AAC and AT, this is going to allow individuals, it's going to allow for communication rights that are ensured for all individuals with disabilities. So I wanted to talk about the Communication Bill of Rights from the National Joint Committee for the Communication Needs of Persons with Severe Disabilities. The purpose of the NJC, the National Joint Committee, is to advocate for individuals with significant communication support needs. Through this Communication Bill of Rights, it states, all people with a disability of any extent or severity have a basic right to affect, through communication, the conditions of their existence. Beyond this general right, a number of specific communication rights should be ensured in all daily interactions and interventions involving persons who have severe disabilities. So I just want to think about how we can, through AAC and AT, ensure that these communication rights are available to all. According to the NJC Communication Bill of Rights, to participate fully in communication interactions, each person has fundamental communication rights to interact socially, maintain social closeness, and build relationships. They have the right to request desired objects, actions, events, and people, as well as the right to refuse or reject undesired objects, actions, events, and choices. Each individual has the right to express personal preferences and feelings, and the right to make choices from meaningful alternatives. They also have the right to make comments and share opinions. Moving into number 7, each individual has a right to ask for and give information, including information about changes in routine or environment. The right to be informed about people and events in one's life. The right to access interventions and supports that improve communication, and a lot of that we'll talk about today. The right to have communication acts acknowledged and responded to, even when the desired outcome cannot be realized. Under this Bill of Rights, it also says that individuals with disabilities have the right to have access to functioning AAC and other AT services and devices at all times. And we move into number 12, the right to access environmental context, interactions, and opportunities that promote participation as full communication partners with other people, including peers. The right to be treated with dignity and addressed with respect and courtesy. The right to be addressed directly and not spoken for or talked about in the third person while present. And the right to have clear, meaningful, and culturally and linguistically appropriate communications. A lot of what we'll talk about today will be kind of focused on number 12 here, right? An individual's ability to access environmental contexts and interactions. But regardless, all 15 of these Bill of Rights should be considered when we are practicing as speech language pathologists who may be utilizing AAC. So how do we ensure individuals with disabilities have access to these communication rights? Of course, this is going to start with evaluation and assessment for access to AT and AAC, right? We're thinking about alternate access methods, thinking about individuals with complex motor needs, complex involvement in terms of physical, sensory, or cognitive impairments. We're wanting to evaluate for alternate access to identify the best, most efficient, effective way an individual can access their AAC system and integrated assistive technology. And we're thinking about things like switches, mouse alternatives, keyboard adaptations, eye gaze systems. We're talking about things like adaptive software, so on. Of course, I could give a 2-day CEU on alternate access methods. That's not the point of this course today, but I do just want to briefly talk about the importance of assessment components and what this means for individuals with complex communication needs to ensure that they are able to access their AAC system, thus being able to access additional assistive technology, environmental control units, and so on. When we think about an assessment, an AAC assessment includes case history, prep time, language and communication assessment, symbol assessment, of course, right there, that third to bottom bullet, access assessment, as well as device trials and AAC instruction and personalization. Just a couple notes on here when we're considering AAC and assistive technology evaluation for individuals with complex needs. We're thinking about how important it is in that case history to gather a very thorough, really thorough case history and information regarding a patient's medical diagnosis and medical history. We're thinking about, is this a progressive diagnosis? Is this acquired? Is it chronic? We want to gather information about their current plan of care. Have they been trialing AAC with other clinicians? We also want to, a big note on here with case history, ensure that we're getting information regarding medications, right? Medications are really important to document because this can affect and impact the way an individual accesses their AAC system. For example, some medications can impact an individual's eye tracking and eye movements, right? Which can affect their ability to calibrate with an eye gaze device, thus making it be probable that an eye gaze system might not be best. Thinking about patients who maybe take medications to manage spasticity, right? If that's a situation where that medication maybe wears off later in the day and spasticity increases later in the day, we want to know that and consider that as part of our assessment and gather that information in the case history. When we are assessing alternate access methods, we want to, especially for those with complex communication needs and complex motor involvement, we want to ensure that we are working collaboratively in a multidisciplinary fashion, working with PT, working with OT for assessment. We want to ensure that the patient has their seating and positioning needs have been met for them to be seated and positioned comfortably to access an AAC system. And then we also work collaboratively with our clinician peers to identify best access methods, whether that be switch scanning, eye gaze, or mouse control. When we are thinking about device trials for patients with complex needs, it's very common that a trial may be warranted, right? What we do in an hour or 2-hour evaluation is really just a snapshot of what an individual is capable of throughout their day, right? We want to ensure that the system we're recommending is best for that patient. And so a device trial may be warranted. With alternate access methods, access to AT and AAC is dependent on an individual's ability to not only effectively access that system, but consistently access that system, right? We want to identify a motor movement and access method that a patient can consistently, from the moment they wake up to the moment they go to sleep, can consistently utilize to access their system, right? If they have a diagnosis where they fatigue later in the day, we want to consider that, right? If there's a medication that affects them differently in the morning, than differently in the morning than in the afternoon in terms of their motor movements, we must consider that as part of our alternate access method assessment. When we think about selection methods, typically it's broken down into kind of 2 categories. We think about direct select. This is done with a physical touch or generated movement, or indirect select, so scanning methods, partner-assisted scanning, switch scanning, and so on. When we think about alternate access methods, we know that we really want to ensure that we are evaluating completely for a patient's needs, because this will make sure that the patient has equitable access to technology and digital resources, regardless of their physical, sensory, or cognitive impairments. Just want to briefly talk through a few of these, and then we'll move into accessing the environment. There's so many alternate access method options out there, right? This is like one of my favorite areas of clinical practice. And I often get asked, how did I learn so much about alternate access methods? How did I learn which ones to trial with different patients depending on their needs and so on? For me personally, the best thing I could do to learn about these different methods was to try these methods myself, right? I would, sit in a chair, or sit in a manual chair or a power chair and think about, okay, I'm right-handed. What if I lost the ability to use my right hand, right? So I would trial things with my left hand. Maybe think about, okay, for whatever reason, if I can't use my hands, maybe I could trial something like a proximity switch with, the side of my head. Thought about it in those ways, tried them myself, really wanted to learn those motor movements, how they affect my, working memory and my cognitive load as I'm trying to communicate, trying to access my system, and so on. But for me, it was really about understanding these methods, understanding the movements required for these alternate access methods, and understanding how I can use those to access an AAC system and assistive tech. So just kind of briefly, for those of you who are maybe new to AAC and AT, just to talk about a few alternate access methods, we have up here in the top left a microlight switch from AbleNet. This is a mechanical wired switch with a cord length of 5 feet that provides auditory and tactile feedback. It's activated by just pressing down with that finger. On the top of the switch, it only requires 0.4 ounces of pressure. So even if a patient just can barely slightly tap the finger, right? That's all that's required for that switch. So it's something that can be really helpful in terms of a switch option for a patient who is really involved fine and gross motor impairments. But if they can consistently utilize a single finger or thumb, that might be a great option. In the top right, we have the Head Mouse Nano. In that photo, it's attached to a MacBook with a back mount bracket. Head Mouse Nano is a head tracking mouse simulator for individuals who cannot use or have limited use of their hands, right? It provides direct access to a computer or a tablet or speech generating device with natural head movement. So what the Head Mouse Nano does is it tracks movements of the user's head and turns them into directly proportional movements of the on-screen mouse, right, or the selector, okay? So able to utilize Head Mouse Nano as a mouse to access a computer or a speech generating device. We also have in the bottom left the Swifty USB switch interface and Orbi switches. So this I feel like is probably what people are most familiar with when they hear a switch. It looks kind of like a jelly bean switch, right? And this instant, an individual would be able to utilize that USB switch interface and a switch to access computer systems, speech generating device, Windows, Macintosh computers, and so on. And then the bottom right, we have a sip and puff breeze switch. This is a more advanced USB switch. It's going to be connected directly to a standard USB port on a computer or a laptop or an AAC device, and provides hardware emulation of mouse buttons or joystick functions just through that sip and puff motor movement, right? Here we have a couple more switches in the top left. This is called a candy corn proximity switch. The candy corn switch is a highly sensitive proximity, uses a highly sensitive proximity sensor for activation. This is one that I've used for patients quite often who are unable to use their hands. They're able to have we were able to position the candy corn switches right at their temples, right? And just with a slight head movement, they were able to access that proximity switch to then access their AAC device. With the proximity switch, there's two sizes. There's a small and a large now, and that can be helpful to trial both sizes to determine what's best for a patient. Proximity switch, again, can be really helpful for patients who maybe need some kind of auditory feedback because it has a little buzz that it makes really quiet, but a little bit of an auditory feedback so the patient, the individual knows that they've activated the switch. And again, it's great for someone who maybe doesn't have the pressure to activate something like a jelly bean switch. They can utilize something like a proximity switch instead. And then on the top right, we have a pillow switch. This is a mechanical wired switch, again, with a 5-foot cord that is pressure activated. And this can be really helpful, this pillow switch, for patients who maybe have some sensory needs, maybe need something softer, maybe something not so harsh or hard. It just feels like a pillow. It can be great too for those who maybe are using head or cheek activation, and it can be placed in whatever position needed for the patient in terms of their motor movement that they can control to access that switch. And then finally, we have eye gaze cameras for eye tracking. Of course, there's many different eye gaze cameras and trackers out there. This is a technology that tracks and interprets the movements and focus of a person's eyes. It allows an individual to control a computer or speech generating device using just eye movements. So to kind of quickly, to wrap up here, for alternate access methods, work as a team, work with PT, work with OT, work with a rehab engineer to determine A, that the patient is seated and positioned in the optimal way for them to access their system. If they're uncomfortable, if they're having to hold up their head, if their body is not supported, we can't be expecting them to use their body to access a switch or a head tracker or a joystick because they're concerned about where their body is in space. And so we want to ensure that they have optimal seating and positioning before we start trialing alternate access methods for access to AAC and AT. Buchelman and Light recommend, I think this is incredibly important for patients with more complex involvement, really thinking about how we can observe the individual in practical functional activities. Again, when we see a patient for 1 to 2 hours for that initial AAC eval, it's giving us just a small snapshot of their abilities and what they can do. Access can change depending on medications, motivation, patient's level of fatigue, and so on. And we must consider that as part of our evaluation. Once we've identified the optimal alternate access method to an AAC system, we are then going to be thinking about how we can consider different types of assistive technology and environmental control units individual can access through their AAC system. And that's kind of what the next few slides are on. Before we go into that, just kind of thinking about AAC and AT through the lens of the ICF. When we're thinking about the ICF, we know that this is the International Classification of Functioning Disability and Health. It's a classification of health and health-related conditions for individuals, and it was developed by the World Health Organization in 2001. The ICF framework was really developed and created to be used in interprofessional collaboration, and I think it's a great way to be thinking about AAC and AT when we're considering its use and its function for individuals with complex communication needs. We are thinking about with AAC and AT, right, in regards to impairments in body structure and function. This is going to include underlying strengths and weaknesses in speech and language production, as well as maybe written communication, as well as access to the AAC system. How is that going to be affected by impairments in body structure and function? We're also thinking about comorbid deficits, right? Does the patient have, for example, if a patient has a diagnosis of childhood apraxia of speech, is that their only diagnosis? Or are there other, comorbid deficits that must be considered when we're coming from the lens of the ICF? We want to think about limitations in activity and participation, right? How is the health-related condition affecting the individual's ability to participate in everyday activities? How is it affecting their functional communication? How is it affecting their social communication, their interaction with other individuals? And then contextual factors, thinking about barriers and potentially ways to facilitate successful communication, participation, quality of life. So talking about accessing the environment for AAC users through AT, the first thing I wanted to talk about is accessible toys. A lot of this, what we'll be talking about, will be for older children and adults, but I did want to put a slide in on accessible toys as a way for individuals with complex communication needs to access their environment for the highest level of independent function. Accessible toys, this can include switch adapted toys. It can be toys that are controlled through their speech generating device and more. A lot of the AAC companies out there have a lot of accessible toy options, whether that be a software, whether that be an actual toy that's being controlled. Definitely recommend taking a look at these because they can be incredibly motivating for children. With accessible toys, we're thinking about communication outcomes. We know that children who are using their speech generating device to control toys, this can increase communication like requesting, right? I want more, something like protesting, telling the toy to stop, right? Or commenting, maybe they're playing cars and they're making the switch toy car go. They comment that it's fast or comment that it's red. Lots of different functional communication opportunities there. And then with functional outcomes, accessible toys are going to provide children with increased independence, right? It can improve cognitive function. It can also allow for children with complex communication needs access to play, right? Play is essential for children's development. Development of motor skills, development of cognitive skills. Traditional play, right? A child on the ground, crawling toward a toy, picking it up, putting it in their mouth, throwing it, whatever that may be. Those traditional play activities are often very difficult for children with complex medical conditions. And this, of course, can impact their developmental potential. With things like accessible toys, this is going to provide the opportunity to increase the number of independently accessible, cognitively appropriate toys for children. Instead of the child just having to watch maybe their peers or their siblings play, they get to engage on their own independently and really utilize these types of assistive technology options, really maximize play development. Other things we want to consider in terms of AT and AAC is phone control, right? I have cell phone or landline on here. I feel like most people have finally gotten rid of landlines, but not everybody. So I wanted to put that on here. Speech generating devices, high-tech AAC systems are easily able to be configured to control phone, right? Whether that be for texting, whether that be for making phone calls. Benefits of AAC for phone control, this is going to enhance communication, right? It's going to facilitate real-time communication with family and friends, or even emergency services, right? The ability to call 911 that maybe they were unable to prior. With AAC and AT, they're going to be able to have access to emergency services as needed. It's also going to improve independence. This can reduce the need for caregiver assistance in managing phone calls and managing text messages. We know that communication outcomes with phone control can be utilized for grading, sharing information, for asking and answering questions, and maximize independence, safety, as well as provide leisure. And I don't know if I shared my sound on here, Casey, so. Okay. So here's a video of a gentleman using his speech generating device to text his children. So I just wanted to quickly show an example of what it looks like to use a XGD for phone control.
Thanks very much.
You can see there, the dad was in the back, kids were playing, and through his SGD, he was able to send a text to his son, and quickly being able to communicate a message about the plants and wanting a hug from his. Next, I have, I don't know if this is the right term, a colleague of mine and I call it distance communication. So the ability to communicate via email, written communication messages through email or through social media. AAC and AT for email and social media really enables individuals to communicate and participate in online communities, right? These technologies provide alternate methods for composing and sending digital content. This is going to enhance social inclusion. This is going to increase digital accessibility, right? Communication is not just, verbal me and you, but I communicate on Instagram. I communicate on Facebook. Individuals with disabilities have every right to also communicate through those methods and through AAC and AT. With this, there's also options for accessible apps, right? Being able, there's nothing I like to communicate more than how much I love watching, Bravo TV. So being able to, for individuals who use AAC, being able to access apps like YouTube or Spotify or Netflix is incredibly motivating and important in terms of maintaining independence. We're going to quickly, I'm going over just a few minutes, Casey, sorry. We're going to quickly talk about ECUs. Next, environmental control units, or ECUs. These are a type of assistive technology that allows individuals with disabilities to control electronic devices such as televisions, computers, lights, different appliances. Research has shown that ECUs have been found to decrease burden of care for caregivers and increase an individual's independence, quality of life, and socialization. Individuals who use AHC, specifically high-tech speech-generating devices, can access and control ECUs through their AAC system. So first, I want to talk about AAC and AT for smart home products, right? Smart home assistants such as Alexa or Google Home, these are becoming very common parts of many households. And this presents a unique opportunity for AAC users to use their voice-operated, voice-generating systems to control and command these smart home products, right? Pairing AAC with a smart home product can really improve motivation. Also, it can enable AAC users to manage their environment without having to rely on caregivers. It provides control over essential home functions such as lighting or security systems, temperature regulation. All can be controlled through a Alexa or Google Home that's paired with a patient speech generating device, an AAC system. It also can improve quality of life and really empower individuals who use AAC to interact with their environment more effectively, more independently, which can enhance comfort and convenience. Here's a quick example of how a patient uses their SGD for controlling a smart home product.
Alexa, dim dim lamp to 20%.
It's a really quick video. Oh gosh, no, it's really not one. But if you can see here,
Dim dim lamp to.
So she's telling her Alexa to dim the den lamp to 20%. So through her Alexa, she's able to control her immediate environment all through her speech generating device. We also have things, and I'm going to kind of quickly move through these because we're running out of time, but I just have too much I want to talk about. I get excited about all this. We also have door openers. So things like smart doors, deadbolts, garage doors. With this, an individual through their speech generating device can control different types of door openers. Of course, one of the biggest functional outcomes for this would be safety, right? The ability to escape in an emergency. You know, if there was a fire in the home, a patient who is maybe reliant on their power mobility chair in his home alone could utilize their speech generating device to open their door and exit the home. Also, kind of on the opposite end, security, being able to lock the door after someone leaves or close the garage door, being able to exit the home, or, you know, from a comfort standpoint, you know, it was almost 80 degrees where I live today. So being able to go outside and just enjoy the weather, all of which is incredibly important in terms of independent function and quality of life. So here's a quick video of a gentleman using his speech generating device to open his door to go outside and let his dogs out. So through his speech generating device, he was able to open
this way.
his door, let his dogs out, let them back in.
I'm gonna let the dogs in.
Able to do that independently on his own.
Well, I am, but
We also have TV control. Again, thinking about safety, something like gathering information for weather, being able to use their AAC system or STD to turn the TV on, change the channel, turn up the volume. Also thinking about leisure, thinking about independence, not having to rely on a caregiver to change the channel, turn the TV off, and so on. So just a quick video on that. I really like this video. Oops.
Okay, homework time.
Mom here clearly told the daughter it's time to turn the TV off for homework. She didn't want to, and so she was able to control the power off of the TV through her SGD, communicating to her daughter that it was time to go work on homework. Finally, just quickly wanted to talk about lighting. Things like smart bulbs are available to be programmed through an SGD for a patient to be able to turn the light on and off. You know, this can enable individuals to manage their environment, again, without having to rely on caregivers, provide control over essential home functions, right? Again, something that can also be used for safety, right? Being able to turn the light on when it starts to get dark out. All of that can be done through AAC systems. So kind of concluding this section, ECUs and different types of assistive technologies that can be programmed and controlled through an SGD are really going to enable individuals with disabilities to have the opportunity to interact with and control their environment at their highest level of independence. Technology advancements are going to continue to advance ECUs and allow ECUs to become more sophisticated, to become more integrated within AAC systems, and thus improve ease of use, which I think is going to be really powerful in the next several years. Okay, I'm going to go through this next section pretty quickly. I want to just talk briefly about funding barriers and solutions. As we all know, one of the biggest barriers with technology is the cost, right? AT and AAC can be expensive. Individuals may not have the financial resources to purchase them out of pocket. Insurance coverage continues to be restrictive in terms of what is covered, leaving individuals with significant out-of-pocket expenses. And so I wanted to talk a little bit about some solutions, thinking about things like grants, legislative action, different advocacy that's going on. All of this is hopefully going to continue to break down those barriers and provide more solutions for individuals who need and use AHC and OT. Quickly, just for those who don't know, funding sources for speech generating devices include private insurance, public insurance, TRICARE, grants, foundations, and more. Speech generating devices are considered DME or durable medical equipment, so they are funded through insurance. If an individual has more than one insurance, such as like a private insurance and Medicaid, the evaluation must be submitted through private funding first before it can be submitted to Medicaid, as Medicaid is always the payer of last resort. Assistive technology is a little different than an SGD, right? It can be funded through both public and private sources, but it's definitely a bit of a different path. In most cases, it's going to require a higher level of demonstration of medical necessity for the product or equipment. And sometimes, something like an Alexa or Google Home, that's never going to be covered by insurance and will need to be purchased either out of pocket or through some sort of grant. One thing I always like to bring up is the Assistive Technology Act. The original legislation was passed in 1988, reauthorized in 1998, and then again in 2004, and most recently in 2022. Highly recommend, regardless of where you're living, to look into the Assistive Tech Act, find out where it is in your state, find out what kind of opportunities it provides for you as a clinician, for you as a parent or an individual who uses AAC. Lots of options in terms of what the AT Act provides. Under this legislation, each state provided with funding for their AT program, and this funding covers things like AT device loan opportunities, so loaning out different types of assistive technology or SGDs. It looks at AT financing. Highly recommend you look at your state waiver program. There's some really phenomenal state waiver programs that can cover SGDs and an additional AT for individuals who need it. There's AT reutilization programs. There's training and technical assistance. Lots of options within the AT Act. So take a look at it. There's also various organizations. Let's say you've exhausted all efforts through insurance and they're not providing coverage for, maybe the SGD was covered, but additional ECUs or AT components aren't covered. Pursuing things through different organizations, both at the local and national level, can be great for patients. Something like Team Gleason, right? For patients with ALS. Team Gleason has provided over $15 million in assistive tech for people living with ALS. And this can include things like co-pays for SGDs, as well as home automation systems for ECUs. Also, if you're an individual working with veterans or working at the VA, funding for AAC and AT through the Department of Veterans Affairs can be really beneficial, can provide really significant coverage, but it's going to depend on different factors. Things like the veteran's specific needs, eligibility, additional resources. For certain conditions, there is automatic coverage. So for example, with ALS, the VA announced in 2008 that ALS would become what's called a presumptive illness for all veterans with 90 days or more of continuously active service in the military. So what does this mean? It means that if a service member is diagnosed with ALS, their condition is presumed to have occurred during or being aggravated by military service. The VA automatically will cover AT and ADC options for patients with a diagnosis of ALS. But again, it can be dependent on various Of course, IDEA, we know that AT and AAC can be funded by public school education system. Can't go too into this, but I will say I highly recommend looking at the guidance letter that was provided by the U.S. Department of Education's Office of Special Education Programming. Say that 3 times fast. But it was in ASHA, and there was a great write-up on it. It was a comprehensive guidance letter clarifying federal mandates for schools to follow in terms of what should and needs to be covered and documented in regards to AT and AAC for IEPs and IFSPs. So take a look at it. There's funding that can cover options for patients who require AT and AAC through IDEA. So kind of summing this up, this course on maximizing functional independence across environments for AAC through AT. We really want to think about how powerful AAC will be when used in conjunction with different types of assistive technology. Thinking about things like assistive technology for phone control, ECUs for door control, right? We know that this can really provide opportunities for individuals with increasing their independence, as well as promoting participation in different ADLs. We know the ongoing technological advancements in the areas of AT and AAC are really exciting and are going to continue to provide individuals with disabilities many opportunities through these technological advancements. So I'm going to end where I started, that quote from the beginning. And I remember this: for people without disabilities, technology makes things easier. For people with disabilities, technology makes things possible. Thank you all for hanging in there on this last CEU of the evening. I really appreciate it, and I'm more than happy to hear from you if you have questions. As I said, I'm also a mentor for the collective, so you can catch me there as well.
If anyone has any questions, feel free to pop them in the chat and we can answer 1 or 2 of those before we go. Also, just a quick reminder, if you are interested in ASHA CEUs or PDHs and joining the collective, I just added the link in the chat. And just a reminder for those who are members, to take the quiz within 2 weeks of the summit. You must receive an 8 out of 10 on the quiz. And the quiz can be found on the website, the course page. It will also be emailed. And I also threw the link for the handouts in the comments as well. Right. I don't see any questions, Katie.
Awesome. That means I answered everything.
If any questions pop up, please feel free to post them in the Facebook group and we can definitely tag Katie in.
Absolutely. Please do. And have a great week, everyone. Happy Monday Eve.
Have a good one, everyone.
Bye.